Good morning, dear colleagues. Today it is day 2 of our training in endoscopy, and this is actually the 34th International Congress for Gynecological Diseases. And the first one was organized 1991. So we are having as many as 34 summer congresses and 15 winter congresses. Thank you for the previous day. It was actually a celebration of surgery, of medicine, as well as a celebration of international friendship. We have been with many of you and we have received many words of gratitude of yesterday. I thank you again for being with us. We can sense your pulse, and it is very important to work together. So we should join our efforts to do that. And this is an unprecedented course. And let me give the floor to Professor Vito Cella. He is a young professor in Pisa University. He's a prominent expert in robotic surgery, a director of ICF ward in Pisa, Italy. We are good friends with Professor Vito Cella for many years, and he has contributed a lot to this topic. And he has done as many as 2,000 robotic surgeries, but this is the statistics of 2 years old. He is a unique surgeon, and he is a big friend of ours. And today, Professor Cella is going to tell us about new opportunities in robotic surgery. Please, Vito, the floor is yours. Good morning.
Good morning, and thank you. It's an honor to be here at the 34th International Congress wait, good. Okay. And to the 34th International Congress of Endoscopy. Thank you for the invitation. It's an honor. So I want to, my talk was about new opportunity in robotic surgery. So what we know that robotic surgery is a developing technique, and in the last few years we know that robot is in our society more and more. We can, with the robot, we can do a lot of things like cut the grass, clean the floor, and so on, and use it for cooking. And during the year, we are also new platform coming out. There is not the only platform that we know, but we are the other industry then produce platform. So that means the robot is increasing and robotic surgery is developing technology. Why born robotic surgery? Because I mean, everybody knows laparoscopy, but for someone it's not really easy. So to overcome the technical difficulty to perform surgery and also to perform surgery remotely. This is the evolution. We start with Zeus, the last one of the last robots in 2014. And every time we have a new platform, there is new, better characteristics. They increase, or we are better precision, grateful maneuverability, and surgical dexterity. This is the trend. This is the trend. The number of procedures increase every year. We have around, if we talk about Da Vinci, because now we have also new platform coming out. There are 4,200 Da Vinci system in the world, and we treat a lot of patients with this platform. And also there are a lot of, the number of surgeons increase every year. This is our data, and until 2040, we treat in gynecology around 1,000 patients. But if you see here, in 2009, this is the multidisciplinary center. Only in 2019, we treat not only gynecology, of course, but 1,300 patients. But everybody, we have to think a robotic surgery not only with I buy the robot and use the robot. No, is a developing technique, but we have to think also integration and also organization about that. So it's something different. Is a kind of, we can say, is a kind of a mission. You can see this is our multi-center for multi-specialty center for robotic surgery, and we are also the teleround, so we can check the patient from distance and talk after surgery, and it is a kind of answering consistency of robotic surgery practice, achieving outstanding quality standard, optimizing OR platform utilization. So we have a facility are a dedicated OR, a dedicated ward, a dedicated training area. And there are people that work for robotic surgery, so the OR team, and also we have a management team. They're working for robotic surgery. We have four robots, so we have to organize and manage all the robot, manage the training, the telemetry, and also the simulation. But I think is a different thing. It's not only made surgery, is organized everything around robotic surgery. So today I will talk to you about learning, training, mini-invasive surgery, complex case, and also the evolution, which is the opportunity of robotic surgery, which is the opportunity of this do thinking surgery in different way. Everybody, we know how is the learning curve. We grow, we have a step at acceleration, and after we have the plateau. What about we have paper published with robotic surgery? We know that the learning curve is easy in comparison with other technique, and for hysterectomy is around 20 Ks. This is the total hysterectomy time. This is the total robot time, and the time is increasing with the uterine weight. This is the learning curve still for hysterectomy and lymphoadenectomy, and the proficiency for robotic hysterectomy is around 20 Ks. And increase, more you perform surgery, more increase the proficiency. So learning curve is easy. What about training? Training also change. Training is training for people that do robotic. This is our center for the training, and we have the robotic simulator inside. Of course, a robotic simulator, they have tools then for robotic, and at the end of that, the virtual simulator, the robotics simulator, give us a score, and we have, of course, the score. We have to improve the score for when we perform the surgery, and is a kind of a similarity with the training for aircraft. Seem to be so far, but it's so close because we have the common attribute like technical proficiency, ability to adapt a new unexpected scenario, full commitment, communication skill, proficiency. So we have two virtual simulator, physical simulator, but we have also hybrid simulator. And which are the advantage of virtual simulator? Then automatically and objectively as a performance with real time, continuous tracking and learning improvement, and quantitative score for record. We know that also the training, the robotic training curriculum is inside the fellowship program of the school, but not only the simulator, also with robotic surgery, there is the possibility to have also the double console. That means that in the same time, the trainer and the student, they are doing surgery. And those are some papers then compare the different surgery with the dual console laparoscopic and robotic, and seem that robotic has less complication and the time of the surgical time is improved in comparison at the other case. So this is a training program. This is the double console for hysterectomy. And you see with the wage, the professor show to the student how where coagulate, where cut. This is the round ligament. This is the bladder, you see, and with the wage, and of course also show how to move to the how cut. This is the, you see, show the ureter before cutting the infundibulopelvic, and same thing. This is hysterectomy. This is the artery, the uterine artery inside of the uterus. With the way show the uterine artery where coagulate and cake, show where is the ureter in the other side. So to say, be careful because you have also the ureter here, so you can cut easily in this way, and show how put suture when in the vaginal cuff. Okay, so this is a double training. This is the training program for the double console, and this is the hysterectomy. Also, the Society of European Society of Robotic Surgery has a curriculum. The curriculum is important because certify the gynecology, not only the gynecology, but also the training center. So the alternate center, they have to have the characteristic, and this is the minimum requirement for the curriculum. There are different modules like laparoscopy, and at the end you are certified for robotic surgery. So we're talking about opportunity. Opportunity was also, you know, with robotic surgery, we'd increase the minimally invasive surgery, and you can see here how is at least double, and it decrease abdominal. This is the hospital. There's a paper where they show how the hospital with robotic surgery increase minimal invasive surgery. In the same time, there is also indirect increase of minimal invasive. This is a hospital without robotic, but is close to the hospital that has robotic surgery, still increase minimally invasive with laparoscopy. So we have at the end, which are the indication. They are benign and malignant indication. You can do with robotic surgery, myomectomy, hysterectomy, treatment of deep endometriosis, sacrocolpopexy, and for robotic malignant, we can treat, we can make the radical hysterectomy, pelvic lymphadenectomy, lombo-aortic lymphadenectomy, or metastatic cancer. Also, with robotic surgery, we can easily treat the complex case. This is a paper from endometrial cancer and how the impact of robotic surgery in the cancer in this center, and you can see how decrease abdominal and increase minimally invasive surgery. This is for benign disease, is the experience of high volume surgeon for benign disease. And when we use robotic surgery, is they treat with robotic surgery more obese patient, or patient that has adhesive disease, or more patient than have large uterus in comparison with vaginal and with laparoscopy. Hysterectomy, and you can see how increase robotic surgery and also laparoscopy. So how is big the minimally invasive surgery? Of course, obese, so it's complex and is a huge indication for robotic surgery. How also is an indication the elderly patient, because the elderly patient with endometrial cancer, elderly patient is a particular patient, is a very old patient, and then also is the care of elderly patient. We have to be careful about that. But the last part is the new part, is what we were talking about integration. So we are talking about surgical digitalization, which is the future of surgery. We know that already now there are integration in the robotic platform with the ultrasound. This is ultrasound. We can see ultrasound in our platform during surgery. You can see this is the interaction. Those are, we have to look for myoma, and we see where they are, the myoma. In the same time, we can use MRI, so integration. We have to make reconstruction of MRI and use still MRI for our surgery in our, but digital health will be the future and is a cultural transformation of traditional healthcare, becoming indispensable for the best practice. Surgery is one of the areas that has been benefit widely from this technology, and robotic system and the increasing emergency associated with that technology has greatly helped in performing the increasingly complex procedure and with the best outcome. Well, we know that there is the critical point is that there is a disparity with the advanced surgery, with the need of surgery in the world, and so the access of people to the surgical care. We know that there are a lot of people that cannot access to the surgical care, and this is important because so for that we need to change our mind. We change to teach. We need also to have more surgeon than we are before, because the need in the world is a lot. So how can digitalization in surgery impact healthcare and surgical training? We know, and I show you how is the evolution of the technique. So we start into abdominal surgery, and with big skin incision, to minimally invasive surgery, up to robotic surgery. We use training, virtual training, and with also dual console, but it's not enough. It's not enough because with virtual simulator, because the need is much more than, so the answer, we need more surgery. And how can robotic and digitalization impact in the surgical training? All this time is insufficient, is inadequate to increase the demand. We have to arrive to the new stuff. There is a new digital surgery. There is a digital surgery 4.0. What does it mean? It does mean that advanced imaging, big data, machine learning, advanced virtual simulator, tissue analysis, and artificial intelligence may change surgery and training toward cognitive surgical, robotic, and skilled training, achieving in every precise surgery and tailored for each patient. That means that in the future, in the very close future, it will be the training no more one-to-one way, but maybe 1-2,000 way. So we will use new platform, probably with the virtual glasses, and we'll have remote training, no one-to-one, but probably 1 to 1,000. And this is play a crucial role to teach, to teach and to spread our surgery in the world. We know that how already we have a paper about the new strategy and to the new telemetry and the new teaching also. And also we will have how we know new robotic platform for us. Then this is, for instance, the blue is a new robotic platform vaginally. You can see here, this is the image, this is the vagina, and you see how work the platform, and also the new platform for single site surgery. And new also physical simulator then can improve the team working, increase management and resolution, and the analysis with the briefing and with the database, then teach how familiarize with the new complex and we do complex surgery, and where we are in front of critical scenarios. So the conclusion is the robotic surgery will be a part also, and the combination or with the artificial intelligence and digital surgery may allow to augmentation of surgical capability and to optimize the outcome and increase access to care. This is our probably what everybody is the dream of every surgeon. This is the dream, the new robotic integrated OR, where the technology like MRI, CT scan will be integrated with the robotic, and also where we could perform telesurgery and treat our patient in the future. I think I leave you with the last picture. And last picture is maybe in the future, the robot will be a babysitter of our child, and also it will teach soccer to our child in the future. Thank you very much.
Thank you so much, dear Professor Cella. I've been looking forward to your lecture and these minutes of communication. So I would like to ask you, what was your learning curve? How did you decide to switch to robotic surgery? You've been a prominent expert in open surgery, in laparoscopic surgery, and a specialist in reproductive technologies. So our country, Russia, is very grateful to you. And so my question is, what was your learning curve, starting from classical approaches, from open surgeries, endoscopy, to robotic surgery?
Oh, of course. Actually, I started with laparoscopy surgery in my country a long time ago. It was one of the first to do laparoscopy, very few open surgery, and doing a lot of laparoscopy. And at the beginning, was very strange to start to do laparoscopy. And I was really expert in laparoscopy. I went to, of course, we have to recognize to Arnaud Vatier's. I went to him and he teach me laparoscopy long time ago, because seemed very young, Arnaud Vatier. But I mean, it's also is a big expert, Arnaud. But I started with that, and after we had a new robot in my hospital, and the person that bought the robot was a woman, was a thorax surgeon, and I went to her and I say, I would like it. That was 2007. I impressed. This is really a new technology. I want to try. So I say, of course, come. I am happy that you come, because I am, say to me, I am the first. I want someone else, some gynecology also, then work with me. So we start. I went to around the war. I went to United States, because United States was the first using robotic surgery. And at the end, I mean, it's really easy. I mean, I do surgery seat. I do surgery easy for me. I am now less stressed than, because I am far from also the operative, the bad operative there. I can talk, and so the learning curve was really easy, easier than laparoscopy. Also, when I think and every time I was doing robotic surgery, I was thinking, okay, I'm doing robotic surgery. do you think the world can understand, it was 2007, world can understand robotic surgery? Because laparoscopy is so, I mean, minimally invasive. It's easy also. I mean, everybody's doing laparoscopy. I learned laparoscopy. How can share robotic to the worldwide? Because how then people that do laparoscopy then can understand robotic surgery. At the end, I think, and I talk with many, with Arnaud, with you also about that many times, and it's complete. I mean, when you try robotic surgery, is a different way. You have to think, and also we develop in PISA a model. It's not only robotic. It's a model of teaching, is a model of treat the patient, is a model with telesurrounding, is a model, is a new model, is a management also, because we have cost. Also, we have to think about cost. Well, I mean, we have to effort. Right now, we have 4 robots. So it's a new organization. It's a new organization of surgery. This is why I think at the end, my learning curve it was an easy learning curve, also for cancer in some time, because for lymphadenectomy is much more easier. And I think we have to change your mind when you do robotic surgery. You have to think to really organization. We have to think to integration. And this is why I'm happy to do robotic surgery, and I try to teach robotic surgery.
Cella, many say that robotic surgery is aimed at surgery on the prostate gland, on oncological malignant tumors. But as we know, you also operate on benign tumors. What are the advantages in using robots in gynecology, specifically on benign tumors? So we can understand that this is all about telemedicine. It is to get rid of tremor of the surgeon's hands, to get rid of being weariness. It is a key lock, so-called key lock surgery, 360 degrees with a poor imaging quality. These problems can be solved by robots. But what are the other advantages in gynecology using robots? What's your take on that?
I think one of the most difficult surgery in laparoscopy, of course, Professor Romeo say that is not true, but is one we use suture. You know, Professor Adamian, you do a lot of teaching class of suture, because suture is the much more difficult things, I think, in laparoscopy, is a kind of a barrier for people that do laparoscopy. Suture is much more used in benign disease in comparison with the cancer. So when we perform myometry, when we perform sacrocolpopexy, I think it's much more easier using robotic, because suture is dramatically easier than laparoscopy. So the learning curve is dramatically easier than laparoscopy. So this is why I mean, myometry, of course, is costly, but every year is less costly for us, because we manage the cost. So also, I think benign disease, for instance, myometry is one of the more difficult surgery in gynecology. Lymphadenectomy is easier, because you are of all you don't need the suture. Now with the sentinel lymph node, you go, you see the lymph node, you remove the lymph node. And I mean, if you know the anatomy and you study the anatomy, it's easy. But suturing is not only study. You have to train it. You have to train it. You have to train it. So I think this is the place also for benign disease in robotic surgery.
Before I give the floor to Giacomo, I'd like to share my experience. 15 years ago, we brought a robot to our training course in Moscow. That was not easy. We invited Advincula, many other robotic surgeons, but at that time we did not have a robot, but we wanted to show a surgery. We brought a robot from Prague, and Intuitive helped us in bringing the robot. We said it's very expensive, but this thing can work with a robot. It's a good procedure. That is why some 7 years ago, I went to Strasbourg to Maresca and they said, I want to try it myself. Maresca laughed at me. He said, you are like a robot yourself. I said, no, I want to have a go. So I took this course for 2 days, 2 swines, 32 kilos each. But I said, well, I cannot just introduce a troll car into a pig. I didn't get used to it. So for several minutes, it was like playing with toys. And I was very upset. I thought, well, I cannot do it. My grandchild can do it much better. He said, well, take it easy. But as soon as I entered the abdominal cavity, I realized that the pig was like a person. I operated for 2 days on a pig. I did not lose a single drop of blood, and I am still happy that I had this very expensive but great experience. They promised us to have a robot, so I will try to include more and more people into using robots. Thank you very much, Professor Celavita. You made our morning. Thank you so much. Dear colleagues, let me just put on a video before I give the floor to our next presenter. Dear colleagues, of course, endoscopic courses have had a long history since 1991 with all those wonderful gentlemen working with us, especially Professor Jacques Camus. We also have our giant endoscopic courses. I long for them, and I am glad that despite the pandemic, we're going to present the hero of our time, the developer of hysteroscope, the creator of all hysteroscopic procedures, Professor Jacques Camus, who is not a doctor, but an engineer. He created a wonderful machine that is an alternative to a major surgery, and in some cases, an alternative to hysterectomy, an alternative to infertility treatment. Professor Jacques Camus, the Women's Clinic, Port Royal, and Pierre and Maria Curie University. Jacques Camus has the holder of the Legion of Merit Order. Jacques, I'm glad to see you. Hello. Jacques, can you hear us? Jacques, can you hear us? Please turn on the microphone. You are muted. Unmute yourself. Please unmute yourself, Jacques. Unmute yourself. Unfortunately, he cannot do it.
I'm sorry, I have it. You have it? Microphone array.
Yes, we can hear you. Please go ahead. Jacques, you look great. You look great.
Can you hear me? Is it fine?
Yes, yes.
Everybody can hear me, but I cannot. Good morning. Everybody can hear me, but I cannot. Good morning, Leila. It's such a pleasure. You look like very fine. I'm happy we passed all this very sad period, and I hope we're entering a new era with, and we shall see each other in Moscow or Paris. Okay, how? I wait to have
both in Moscow and in Paris.
Do you have a good sound? Because you seem there's a space between when I speak and when you try.
The sound is okay. The sound is okay.
Yeah, but
the sound is perfect.
I have no image. Afficher d'agrès vidéo.
Yes, you should share the screen. There is the share screen function at the bottom. Click on it and then click on full screen.
Oh, here. Partage. I'm pushing on the screen with my presentation, but nothing partagé. No. Oh, yeah. Here. I did see the presentation and it disappeared again. Nouveau partage.
We can see your slides, Jacques. Jacques, we can see your slides on the screen.
Yes.
Please go ahead. They are not full screen, but at least we see some of them.
Okay.
You can click on full screen and if you want, but that's also okay.
Okay. Oh, all right. So what shall I do something special now? I have not I see on a small screen. Partager l'audio.
Well, click on full screen. I think it's in the upper.
It is full screen. It is full
Okay, go
screen.
ahead, go ahead, go ahead. We can see the slides. We can see the slides. Professor
Yeah,
Amu,
but
please go
I
ahead.
cannot see them in full screen. That's the problem. When I push like this, nouveau partage, contrôle à distance, arrêter, désactiver le son. Sorry, I see my presentation, but I see it on a tiny screen, which is about 1 inch, 1.5 inch. No, it doesn't come. And it's full screen.
Jacques, can you click on F5? Press F5. Will it help? Press F5. Can you hear me? Jacques, we can see your slides.
Yeah, but I cannot see you and I cannot see the slides. This is, let me, shall I open again the presentation? No. You see the slides. Zoom.
Try to press F5. If you hear us, this is Moscow. Jacques, try to.
I cannot see you.
You cannot see us, but you can hear us. Press F5 on your laptop.
Press the
F5 button.
Record. No. Contrôle à distance. Vous êtes en train de partager. New. Yeah. It doesn't come. I don't see the full screen of my presentation. Sorry. Okay. Okay, so I can speak now. Is that fine?
Yes, you can speak. We can see the slides. Please go ahead.
Okay. So good morning, everybody. And I'm going to start with the conclusion for a very simple reason, is to show you how we have, why hysteroscopy is a revolution. It's a revolution because there's a special step to follow to make a new technique as a revolutionary. It's innovation and advanced technology. And anyway, these two things are the base of a revolution in scientific, industrial, or medical progress. That's why I start with this, to have to prove it. So the first step was to innovation, was to create a new instrument, and this new instrument was created now a long time ago. It was a new optic with a addition of a system, a proximal system here, which offers a vision which goes from the infinite to the contact of the scope. And the second innovation, which was proximal and under control of hands, you see it here, under control, which permit to focus and to have a clear vision from from the hand and not from the distal part of them. These optics, these new optics have excellent definition because it has a resolution like a microscope. It's a resolution of 0.2 micron. It has full quantity of light is used when we use such a system, and we have a depth of field which goes from the infinite to the contact of the scope, and a very wide angle of vision. So this was the innovation, and technically it was realized by, once the patent was created and protected, it was a long time ago. Then Storz family, Mr. Karl Storz himself has used his technical advance to realize what the patent shows, what the innovation was requested. So first of all, just 3 or 4 slides to show you the first step. The first step was, of course, diagnostic hysteroscopy. Once the instrument was created, we could make it more and more sophisticated. So we had a 4mm instrument for surgery, a 2.9 instrument for diagnostic hysteroscopy, and even very small optics of 1mm diameter for very special indication. Once we had the basic instrument, which was the microhysteroscope, then we had to create the feeding of this microscope. And the feeding first was gas distension of the uterus, and the system of controlling perfectly the gas delivery make it sure there's no possible embolization with such a system. Then one of the major steps was the video, because with the video we could simplify, and some of the characteristic of the scope was transferred to the video to have a very clear image. So diagnostic hysteroscopy was the main aim for about 2 years, and you see here ergonomic setting. The ergonomic setting, you can do that in your office. It has to be a special disposition with all the technical instrument, optics, and the feeding of the optics on your left, and everything for documentation and video on your right side. And this way you can perform the diagnostic hysteroscopy in a very simple and non-invasive way. The problem was to cross the cervical canal in a painless way without any anesthesia. You see that it's very complicated. So under vision, you could cross it without traumatizing this very fragile structure to get into the cavity. And once in the cavity, of course, you will going to explore everything with a wide angle, see all the details. You can see the glands here. You can see the entrance of the ostia. So you can explore all the cavity. One of the first new implications was microcolposcopy. Using the high magnification, we could explore what was the most important for the cervix, the transformation zone. You see it here with the junction here, the transformation zone here, and the epithelium, mature epithelium here. And with the television video, of course, we could simplify this vision. The vision is very easy to identify normality. And if once you have reached this zone, which is, you're going just to scan this zone, and here you see normality here and abnormal cells here. So it's a new approach to cervical neoplasia. And you see here how on the screen we could see very comfortably all the cells and do a prior diagnostic before treatment. Then we switch immediately after about a couple of years, we switch to operative hysteroscopy. So the next step were somehow difficult too. It took 2 years to develop and adapt operative equipment to the microhysteroscope. First, we have to set a new instrument, endomat, to irrigation, safe irrigation and controlled irrigation by endomat. Then we have to change all the basic of electrical generator to have a very safe again and control the resection without any spark or any danger or any bleeding. This also controls perfectly the bleeding while you're working or doing. And the video control every time is one of the most new steps. Just to give you an idea, it took about 4 years to optimize operative procedure. We started with polyp, then myomas, then synechias, and sometimes so and so for 4 years. But it took about 10 years to finalize new indication. First, it was intramural myomas, and let's say 2 examples, and adenomyosis. Now we do much more, but to show you the process of evolution of hysteroscopy. Here you have the different operative instrument. Here you have the setting of operating room to have again a rational and ergonomic work. And here the full instrument. So let's see the 2 examples, which are the last progress in operative hysteroscopy. I'm sorry, it's very early in Paris. Maybe the weather is still a bit cold. So first of all, adenomyosis, you have a prevalence rate of 20%, which is a common pathology now, which we find by hysteroscopy. There's a special risk of adenomyosis for special patients with multiparous, cesarean section, heredity, and so far, and the age. And the symptomatology is mainly dysmenorrhea and menorrhagia, not speaking of infertility, because the definition and the implication is not definitely non-perfectly. So how to diagnose adenomyosis? Diagnosis is very difficult because clinical point of view, it's very uneasy to speak of adenomyosis. Only in 15% of the cases of adenomyosis, you can evoke such a pathology. Well, diagnostic hysteroscopy also, since adenomyosis is beneath the endometrium, it's a very poor diagnostic tool. Hysterogram is practically the same level as hysteroscopy. It's indirect diagnostic, but not direct. But ultrasound, 3D dimensional ultrasound, is actually one of the best way to do a diagnostic with localization, the type of adenomyosis, and therefore to be very efficient in treating such a pathology. So, since we are dealing with such pathology daily, we did a classification, and this classification for adenomyosis give you here the frequency of 4 types of adenomyosis. You have the focal adenomyosis, which is the easiest one to be treated by hysteroscopy. You have the cystic adenomyosis, which is the most frequent, 45%, about half of the cases are cystic adenomyosis. You have adenomyomas, which are the more difficult to treat now. Fortunately, they are rather rare. And you have diffuse adenomyosis, which was a headache because to reach it, you have to remove the endometrium. And to remove the endometrium, instead of treating infertility, you're going to aggravate it. So it was treated only for menorrhagia and dysmenorrhea. But now we're treating such adenomyosis also. So let's see those 4 types of adenomyosis. First of all, infiltrating for menorrhagia. When in infiltrate, you see here, you are going to locate by ultrasound, you're going to locate the focus of adenomyosis, and you know where it is, so you are going to go exactly here to remove the focus of adenomyosis, as you see here. This is the more used type when you do operative hysteroscopy. This is severe adenomyosis, where you have too many extension of it, and you see here it's very difficult to treat because it concerns the whole thing. So you have also the cystic adenomyosis. Cystic, first of all, you're going to see it by ultrasound. You know exactly where it is, but as you see, when you do hysteroscopy, you cannot identify it because it's deeply intramural. So what we do, we know where it is exactly by 3D ultrasound, and we're going to try to reach it, the intramural cyst. So we know approximatively, here we can see the first image here, and we see the adenomyosis here, the cyst. So we're going to remove this cyst, and it treats this adenomyosis, which is cause of pain, mainly dysmenorrhea, this cyst. So if you remove completely this cyst, you will treat practically always. I'm sorry. Yeah. The third type is the focal infiltration. Here I take an example of in the horn. You have adenomyosis here in the horn, and in infertility, it is important when you have focus and failure of IVF, you're going to remove it. You know it is in the horn, so you're going until you reach the myometrium here, but usually it's very deep. So by hydromassage, you're going to bring the deep part of the adenomyosis. Here you see the ostia. You're going to see here, you can see, and you keep on doing here. You see the ostia here. You have to respect it, and you're going to continue until you remove, until you have only muscle beneath this focus adenomyosis. Now we're going to reach, we're going to see diffuse adenomyosis. What is the step to follow to treat such a pathology? Here you have, we do striation. We try to protect the endometrium. For that, we do furrows every 6 to 7 millimeters without destroying the endometrium. And here, every 6, 7 millimeters, we create a new, that's what we call striation, until we expose the whole beneath, the whole area beneath the endometrium. And once we have done that, we're going to, here, you see, once we open that, we look for focus of adenomyosis, like you see here, and we're going to destroy it. We destroy it, and you see we don't touch to the endometrium. That's why it's a way to work in the intramural part of the uterus without destroying at all the endometrium. So this is, you can also add other operative steps. You know that, for instance, for adenomyosis, you have very often associated polypoid hypertrophy. And here you see the detail of the endometrium. We shall respect, I'm sorry, we shall respect, you see, we're going to remove the excess, the hypertrophic part and the polypoid aspect of the endometrium, and respect the basal layers, which will give a atrophic endometrium very fast. Here you have the result. Once you have treated completely this uterus, you see after 2 weeks how the healing is so fast, and within about 6 to 8 weeks, you cannot see any remaining, any sequela of the striation. Everything becomes smooth again, and you have an atrophic endometrium. How do we do this hydromassage? It's a rhythmic and very energetic control of irrigation. You see here in the endomat, you have the flow and the pressure. And by alternating flow and pressure from negative pressure to very high pressure, we stimulate the intramural organic formation which comes into the cavity. Sorry. Oh. Well, the next thing to show you is how we treat intramural myomas. So for intrauterine myoma, the process, the operating process is very simple, and with the 7-millimeter loop, within few steps, few minutes, the complete fibroid is going to be removed. You just resect it until you see the myometrium beneath. Here you see the myometrium, and you are sure that all the myoma is removed. Here you finish by doing this. And of course, if you have interstitial type 3 fibroid, another, you just open and do exactly the same process. Okay. Here, always ultrasound is a complementary examination to be done. So how we do to remove a very deep myoma? Here you see we're going to localize the myoma, and by ultrasound, by 3D ultrasound, and like for adenomyosis or for the myomas, normal myoma, we bring the intramural part of the myoma once we open the capsula, and while we bring it by hydromassage, we resect it until again we see, we bring it in the cavity, and in a very safe way, we can remove it until we have the myometrium beneath, and we know that we have done the complete myoma. So how do we do that? You see the intramural. When you are in the cavity, you cannot see the myoma because it's intramural. So the principle is to open the capsula, which release pressure on the fibroid by the muscle. And you see that the muscle here is crushed from about 10 millimeters here to maybe 2 or 3 millimeters here. And this is the danger, is if you try just to go deep and remove the myoma, and you impact this part of the myometrium for 2-3 millimeters, you're going to fragilize the uterus. And you understand that it is so. The principle is to open the capsula, bring by hydromassage the interstitial part into the cavity, and while you're doing that, by this very energetic change of pressure, you're going to push the myoma toward the cavity, and at the same time, you're going to realign the myometrium, which immediately will become like it was before, fasciculated and reorganized and much thicker. I mean, this will come here, and there's a very safe way to resect whatever here without damaging the myometrium. So why do we say that hysteroscopy was a revolution in women's health? Just to give you two examples, in United States, where there is a register of all hysterectomy and curettage, in 1980 in USA, it was performed 2 million curettage under general anesthesia. So you can imagine the cost and the impact on the woman. And as you know now, with hysteroscopy, they all these 2 million, practically there's no exception, can be treated by a more simple technique and more precise and less invasive by hysteroscopy. They have or should have been replaced by diagnostic hysteroscopy in an office setting instead of 2 million general anesthesia in the United States. And furthermore, the sad thing is still a lot of people are performing curettage. They don't insist on the, but unfortunately, hysteroscopy takes time to become a generalized and practically mandatory process in treating what was treated by curettage before. Also, at the same period, they were performed 600,000 hysterectomy a year, and actually, except myomas of more than 4 centimeters or oncologic pathology, which still will require either hysterectomy or laparoscopic or by laparotomy resection of big myomas, all the other myomas, which are intrauterine and intramural, which are responsible of infertility, can be responsible of infertility, can be treated, as I show you, by operative hysteroscopy. So you can imagine in a way of economic benefit and comfort for the woman, the importance of such a new technique. And I think if you extend this to the world, you can imagine how much hysterectomies and how many million, tens of million curettage should be avoided. So now the real conclusion, diagnostic hysteroscopy, I think, is accepted by everybody as a routine polyvalent evaluation tool, and operative hysteroscopy, which become now common as a non-invasive alternative surgery. As you know, it is reliable, it is safe, it is reproducible, and it is cost-efficiency procedure. Well, I hope I convinced you to do, for those who are not using hysteroscopy daily, to try to come to such a tool, which it will be a big comfort for the gynecologist and for the patient. Thank you very much for your attention, even though it is a little bit artificial and through a computer. Thank you very much. So, hello, Leila.
Dear Jacques, thank you very much. A person who is a very honored professor and a member of Gynecological Legion, so is invaluable. I know no one who can compare with you. You love medicine, you love new things. And I have my question to you. I'm very happy to see you here. You are looking good. You have a French looking person, indeed. So, and this in the era of new technologies and artificial intelligence, everything you've been doing so far has always been innovative. But what comes next? What else can we invent to be better than hysteroscopy? We were very happy to have hysteroscopy enhanced. So it enhanced both diagnostic, rehabilitation, and treatment process. But what's your take on our prospects, on our perspectives besides hysteroscopy?
Yes, it's, I think Russia was, let me do a remark. You know, when we started such a procedure, when we started such procedure, the first people who were so interested were the Italian. Italian were becoming the best expert in hysteroscopy. And because of you, Leila, you did come to Paris, you did appreciate such a new technique, and I think you extend it. You are the responsible of extension of hysteroscopy in your beautiful country, which will visit, I think, the next meeting. And that's why. But I couldn't hear very well your question. Can you just in few words tell me if you asked me a question? No. Did you ask me a question, Leila?
Yes, well, I should say that hysteroscopy, as you said in your presentation, even me doing hysteroscopy for 30 years will stay with us forever, because regardless of the surgery, we should visualize the uterus cavity. So that is to see proliferation indeed, and to actually we have a complete pathological view on the uterus. And this is actually big data we are dealing with now. So many cases of hysteroscopy. Our instruments are being improved all the time, and the size of the instruments is reduced. We are switching to the low energy instruments, but the basic approach is the same.
Right.
So using hysteroscopy, we can have better visual improvement, regardless of what we use robots or what we do not use robots, whether we use lasers or we do not. So hysteroscopy has become a well-established platform to be used in everyday practice. Perhaps we have not reached our limits yet, but I think the person as you should even do something better. What are your dreams in implementing hysteroscopy? Should we train our doctors to master hysteroscopy in practice?
Yeah, I think we have reached a point where we cannot dream more. You know, we cannot go further than intramural pathology unless one day somebody will try to have an access through hysteroscopy to other kind of pathology. Already we have access by microcolposcopy, by high magnification, and by visualization of histological part of the uterus. We have already an appreciation of the pathology. When we see the pathology, we can, you know, when you do a lot of hysteroscopy and you have a beginning of adenocarcinoma, which is in situ adenocarcinoma, well, it will be one day treated like we do for the cervix. That means when it will be in situ, I think then one day we shall be able to have a treatment, a less invasive treatment of such pathology, and especially the best treatment is prevention. And if you do routine hysteroscopy for these patients, you will identify the situation so early that most of the time, a very simple treatment will come over this pathology, all the pathology of the uterus. But what is the future? I don't think we can adapt robotic to hysteroscopy, because you have a woman in front of you, you're going to put it. So I think we have reached some limit, but I'm sure a new generation will find new indication. But for time being, it's difficult to go further than what we are able to do. But it's, I think it has to become, rather than trying to go further and further, I think the next step will be that every gynecologist have hysteroscopy capacity to do it in his office. In my opinion, this is the next and major step, because it will prevent from so many, it will be such a good prevention. It will be such a easy treatment of minor pathology beside oncology, that I think the future is, and for infertility also, you understand the impact of hysteroscopy before doing an IVF or in infertility. And I think the next step will be to introduce this instrument in every gynecological practice. That's my hope. But I cannot imagine other. We shall maybe one day. Let's hope, Leila, that we shall see something new in the new years coming. Anyway, if there's anything new, you will be the first to know it. As usual, you know always the first thing when it happens.
Thank you very much. So I've been looking forward to your lecture and to your answers to my questions. And here you are. And as you said, hysteroscopy has received a legal background for all gynecological diseases. And hysteroscopy is going to reveal the secrets of fine structures of endometrium in infertile patients, possible treatment of synechias, as well as thin scars or niches within the uterus. And hysteroscopy will help treat adenomyosis. So there is no need to cut the uterus using laparoscopy, as long as we can do the same from inside. So we can reconstruct the uteral abnormalities using hysteroscopy. And you have identified a good learning curve with the light at the end of the tunnel, and hysteroscopy will be there with us forever. Thank you very much again. Good luck and be safe.
Thank you, Leila.
Dear colleagues, so we are closing the first session and we're switching to the next seminar dedicated to the gynecological abnormalities. Just a couple of minutes.
Dear colleagues, today we start another important section called the Experts School on Uterine and Vaginal Malformations. During 10 minutes, I will present the introductory presentation. The Kolokov Center is the holder of major data on vaginal malformations, then Professor Jan Walski, and then Professor Arakilian. Please put on the video. Well, uterine and vaginal malformations are a serious problem. Everything starts from the beginning of menstruation. Those who have problems with the outflow of menstrual blood, hematoculpus, beer culpus, and as for classification, there will be a separate presentation. That's the classification prepared by our department. For those malformations, you need to free the vagina, create a new window, and laparoscopy is needed to separate the adhesions. And here you can see colpoproesis. Colpoproesis is done at our center virtually every day, or at least every week. That's a disease which, despite the fact that we encounter all too often and looks simple, unfortunately, this is a non-standardized procedure, and at our department, we do a lot to standardize it. You can see the procedure right now. Colpoproesis is being created in a patient after demasculizing procedure. The procedure is done in a standard way using two approaches, the vaginal approach, when we do the transectional cut along labia minor and in the vulvar area. You can see that we have two approaches, and imaging, thanks to Edward Ossip, can be done from two approaches. The surgeon uses a lower approach. We open the abdomen using the special navigation. In the abdomen, we form the entry to the vagina, while the bowel will be sutured to the skin of the perineum. Well, you can also see we form a window and we form the vaginal vault. Despite the fact that we've been conducting those courses for too long a time, and not just in Russia, but globally, unfortunately, right now, this procedure is still considered to be a unique one, maybe because any colpoproesis and any malformation are unique in nature, or maybe because there are no clear boundaries when you can see the facial space, etc., but bringing to bear the gender policy as well as different masculinization and feminization procedures. And you can see the doctors on both sides. We usually do this procedure to those people who decided to become women, and we had the first stage of feminizing procedure. All these stages were developed at the Department of Operative Gynecology at the Kulakov Center for Obstetrics and Gynecology. We've been doing this for many years. The most complex thing as far as malformations are concerned is to create a junction between the functioning uterus and the closed uterus. When there is a need, we do colpoproesis, and when there is a need to have the outflow of menstrual blood in the uterus, which is really functioning, there is a hematometer there with the part of the cervix or the rudiment which we have and which can be reached during the vaginal approach. So you can see the junction between the uterus and the cervical canal, which is basically fully absent. These procedures are very complex. We cannot guarantee that we'll be able to create this cervical canal, but we do have a lot of experience and data, and this is becoming a reality. All of these procedures are done just at our center. Anyone can come to us, and anyone can refer their patients to us. So here is the creation of the cervical canal. And as for this procedure, we create a vagina for situations when we do post-feminization of the procedure. That's the male pelvis. The male pelvis is drastically different from a female pelvis. You can see the doctors, and you can see that these procedures are done globally, but I cannot just travel all over. And as for the abdomen, it is not pulled properly among men who decided to become women. But again, we have many thousands of patients. And again, some surgeons have never seen such patients. Well, you can see the ureter has a special placement as well as spermatic cord. And of course, we must do everything to avoid damage. I think a robot could help us out here, and we'll be able to standardize these procedures. And it's not so easy to do the standardization. Well, pay attention to this specific procedure. We have 4 options of colpoproesis. That's a more or less standard option of colpoproesis. Everything starts with the laparoscopic imaging to identify the malformation and also to identify concomitant diseases. As for concomitant diseases, well, they can take place even when the uterus is absent, or there might be endometriosis. Why does it occur? It's hard to say, but we believe that allogenesis is very poor here, or the family forms of endometriosis or artificial immunity is not perfect. Well, the gauze is used for several days to maintain the volume of the vagina, usually on day 2 or 3 following the procedure. These patients get acquainted with their vagina that they hadn't before, and then during the month, they must just support it. Well, the properties of the abdomen due to metaplasia, epithelialization, when we have it on the part of the vagina, we have studied those processes. Now my students are already doing this. One of them is defending a doctoral dissertation. Another talented doctor, Andrei Popridukin, will be one of the most talented specialists who is going to use modern methods of navigation, modeling, and creating an artificial vagina, which in fact is a unique procedure. Just pay attention to this aspect. How do we create the vaginal vault if we create the vaginal vault using the rudiments? Well, in this case, it's a guarantee that this woman will never have a prolapse. This is another unique procedure. We show just our own procedures, never someone else's procedures. When there is a full aplasia of the uterus and the vagina, the young woman had pain. We did the laparoscopy and found extended endometriosis. Why does a young woman have extended endometriosis when there is the vaginal aplasia? So the Sampson's theory should be forgotten in this case. Moreover, using the ultrasound and MRI, we've seen that there are muscle rudiments with the cavity, and inside the cavity there is the hyperplastic process in a woman with the uterine aplasia. And you can see the picture when these rudiments are being removed. And in both of them, as you can see, there is endometrial hyperplasia. So the rule is if there are such rudiments and if they function, if there is a cavity, remove them, because we must control them and do not miss endometrial cancer. And we had patients who had the rudimental myoma, or if there is a pain syndrome in 64% of cases, when there are uterine rudiments, aplasia occurs, and there is adenomyosis. Adenomyosis is the reason for a pain syndrome. You can see with the removal of rudiments, nothing happens. And at our center, we have just at our department about 5,000 surgeries. We are a reference center, world reference center, and according to FIGO and WHO classification, and we treat all the difficult cases. And as for the intrauterine surgery or dissection of the uterine septum, we do it as a mandatory procedure. In the past, we did it when the woman had insufficiency, but right now the septum is a foreign body, which is a problem on the way of implantation. If a woman has infertility and she wants to have a baby, but she can't do it, in this case, we dissect the septum. This procedure lasts for 15 to 20 minutes max, but we also introduced innovations here. When we do the dissection of the septum, intrauterine septum, in order to identify the depth of the dissection, we use a functional MRI, and we also have a lot of patents concerning malformations, and Dr. Makian was the one who got this patent, and this is functional MRI because it shows that septums are different. One gets blood, it functions and causes pain, but the other one, doesn't have any blood flow, and it doesn't pose any risk. So right now we can see this is real navigation and modeling of the procedure in a real-time mode. You can see the nicely formed vaginal fold. As for ovaries, they always function in patients with uterine malformations. Colleagues, we have a course on hysteroscopy, laparoscopy, innovations in new technologies in gynecology every month. I am not going to speak volume on this at the International Congress. You know how to get to the Kolokov Center, so please sign up in advance. Come to us. It's a 3-day course, and you'll be able to see the use of new technologies in the OR, to listen to presentations, and please refer your patients to us. And you'll have a chance to assist our professors. Now I'd like to give the floor to Professor Jan Walski. Jan is thousands of people are listening to us. Jan Walski is a true expert in the field of ultrasound medicine, congenital malformations of the uterus and vagina, congenital malformations of the fetus. He's in high demand in his country. The theme of his presentation is congenital uterine anomalies. Jan Walski, the floor is yours. Good afternoon. Yes, we can hear you very well. Right, you can hear me and you can see my presentation. Good morning. I am very glad to participate at this Congress on a regular basis. I'd like to thank Leila Adamian for the opportunity to speak at this Congress. As for the theme of my presentation, It's a congenital uterine anomalies, or CUA. CUMs are very frequent pathologies. Well, you can see that there is a high prevalence of this pathology, but on average 0.4% in general population. These are women who have congenital uterine malformations of a particular type. If we look at women with infertility, this percentage goes to 4%, and in women with miscarriages, it can be up to 40%. As for fertility and the ability to get pregnant, well, usually the fertility is minimally impacted upon by Mullerian anomalies. Uterine pathologies usually lead to an increase in the number of abortions in the first and second trimester, have an impact on increasing the malpresentations and preterm delivery, and also the placental pathology. A few words about embryology. During the first weeks of development, each fetus, regardless of sex, has the Wolffian duct that serves for the development of internal genital organs. And in male fetuses, the presence of Mullerian inhibiting factor is usually associated with the presence of a Y chromosome, and as are Y genes on the Y chromosome, this results in the regression of the Mullerian duct. In female fetuses, the absence of MIF leads to regression of the Wolffian ducts and growth of paired Mullerian ducts. The Mullerian duct during the next several weeks is undergoing fusion to form the uterus and upper 2/3 of the vagina, and the lateral fusion of the Mullerian duct gives rise to the development of fallopian tubes. The Mullerian organogenesis is complete by the 5th month with the uterine septal resorption of the septum. Naturally, the pathology of the development of each stage leads to this or that group of malformations of the uterus. If there is the problem in the development of the Mullerian duct, then the problem of the development of Mullerian duct lead to agenesis of the uterus. Uterus can become unicornate if there is the problem in the fusion of the Mullerian duct. In this case, we have the bicornuate uterus and uterus didelphys, and if there are alterations in septum resorption, in this case, there might be different types of the uterine with septi, despite the fact that the problems of uterine malformations have been studied in the literature for more than 50 years. Still, there are a lot of problems and questions, and we do not have consensus on them. We will try to raise these questions in our presentation. We'll be talking about the diagnostic methods to detect uterine malformations, what classification systems exist right now, what are the contradictions between these classification systems, what are the objective criteria for the diagnosis of uterine malformations and the classifications of such pathologies, what are the clinical consequences and reproductive outcomes. when there is the existence of specific malformations, and what is the value of surgery. Naturally, the primary diagnosis of uterine malformations usually takes place when we use a 2D ultrasound. Well, you can say with confidence that there is a specific pathology here, but there is no clear description of the pathology if you use only a 2D ultrasound. Using hysterosalpingography and hysteroscopy allow us to define the internal structure of the uterine cavity, but does not give us the information about the structure of the organ. And as of today, only a 3D ultrasound and MRI are the diagnostic methods allowing us not just to determine the problems with the internal cavity, but also the external contour. And right now, it replaces laparoscopy to define the form of the external contour. That's why the hysterosalpingography was used before to determine the structure of the internal organ. Right now, the coronary slice of the 3D ultrasound or MRI in some cases allows us to get all this information. Accuracy and exactness of 3D ultrasound can exceed 92% according to different data. If we compare this method with other ones existing now or in the past to diagnose uterine malformations, you can see that 3D ultrasound has the highest diagnostic accuracy, 97% to diagnose uterine pathology. From a practical point of view, first we get a sagittal view of the uterus. We ask a woman not to breathe for several seconds. Then maximum quality setting, maximum sweep angle of 180 degrees. The preferred time for evaluation is the second phase of the menstrual cycle. And we get, as you see, well, the clear and right coronary view, thus allowing us to describe the uterine cavity, the external contours, and to classify it, breaking the case into specific groups. So well, you can see coronal plane and rendering, and you can see here that it's probably septal uterus, but only the coronary view allows us to say that here we're talking about the septum that divides the cavity. It's so-called the complete septum, and the cervix. Here is another example when the sagittal scanning using ultrasound shows that it may be a normal cavity, and only a 3D ultrasound shows that it's a unicornuate uterus with the regression or with the underdevelopment of the right part of the uterus. The use of other technologies such as OmniView is recommended in order to get a clear picture, because often uterus with congenital malformations has a band which is quite manifested. They're not in the same plane. Sometimes it's very difficult to get a coronary view, so the use of OmniView is preferable. It helps a lot in terms of exact diagnosis. And here you can see how this uterus, when we have a coronary view and we can get an image reminding us of a septum. And if we scan the same uterus by using OmniView, we can see definitely that there is a clinically important indentation, external indentation. A few words about the classification systems. There are several classification systems. The most widely used as of today is the classification system of American Fertility Society, or AFS, as it is called here, or of the American Society of Reproductive Medicine, which has existed since 1988. Here you can see the ASRM classification. I wouldn't go into detail because it is very well known to you, but this classification has also some drawbacks. First of all, it does not provide a clear diagnostic criteria to distinguish between different embryologically neighboring anomalies. For example, it doesn't provide the objective criteria to make a difference between the septal uterus and the unicornate uterus. It includes the uterine pathology, but it does not include the congenital pathologies of the cervix, of vagina. Obstructive anomalies are not included either. And naturally, this classification requires additional updating. These updates were made quite recently, only in 2016, by the American Society of Reproductive Medicine. They came up with the objective criteria for diagnosis of uterine pathologies. A septum, that means septate uterine, that means internal indentation in depth more than 1.5 centimeters. And in this case, it's significant pathology. Less than 1.5, it's less significant. There can be also external indentation when it is more than 1 centimeter. In recent times, as a result of such problems with this classification, new classification emerged, and one of the most widely used classifications is the classification of ASHRAE. This classification, unlike the American one, does not only include uterine classification pathologies, but also the cervix pathologies, vaginal pathologies, and also there is a graphic scheme for the right definition of a particular uterine pathology. But the problem is that the standard here is the uterine wall thickness. We know that the uterine wall thickness is quite problematic thing in terms of measurement. This classification provides two ways to measure the thickness of the uterine wall using a 2D ultrasound or 2D longitudinal plane. When at the level of the middle of the uterine cavity, we can measure the anterior and the posterior wall thickness, and we use the average arithmetic meaning, and we can also measure the 3D ultrasound and the coronary view to measure the thickness of the uterine wall. And there will be the difference between the line that connects the ostium into ostium line and the line going parallel to the humerus area. So according to this classification, the internal indentation or the septum is clinically important if the thickness or its length is more than 50% of the thickness of the wall, uterine wall. And according to this classification, external indentation is important and significant if its depth is more than 50% of the uterine wall thickness. Naturally, this definition is quite problematic from several angles. First of all, the uterine cavity and the definition of this pathology of the uterus have never been proven on the basis of prospective studies in terms of their importance for reproductive outcome, in terms of efficacy of specific procedures, and that causes serious problems. Well, the technical part per self of measuring the uterine wall thickness is complex procedures, because if there is a myoma or adenomyosis or vascular pathology, they can have an impact on the final result. And also the ways that were provided to measure uterine wall thickness do not correlate with one another. You can see that it's one and the same uterus, and the wall thickness was measured by two different methods. In one case, it's 11 millimeters. In another case, it's 8 millimeters. And you can see the internal indentation was 8 millimeters. How can we classify this uterus according to the ASRM classification? This uterus is normal. According to ASHRAE classification, this is a septal uterus, and of course this causes a serious discussion. There are a lot of works that criticize the classification systems due to the lack of unity between them, and you can see a clear example showing that this is a septal uterus according to ASHRAE classification, can be normal according to the American classification, and the situation is becoming more complex when a group of experts, congenital uterine malformation by experts, CUME, decided to come up with their own classification and criteria to diagnose the external or pathological external contours.
They were using 10 millimeter threshold to identify the internal and external uterine contours. And therefore, there are 3 threshold levels used in 3 different classifications based on 3 different ways to identify the disease. And the comparison is quite vague here. So this paper was published less than 2 years ago. About 60 women were checked for uterine disease, and 32% of them had a septate uterus, and this is a non-selected patient population, and based on one of the 3 classifications, namely an American classification or ASHRAE, it is 31%, and a little above 2% of women had abnormality in accordance to all 3 classifications. That's why to find a good parallels between the 3 classifications is quite problematic. That's why, again, it is very hard to compare the results using 3 different classifications, depending on what criteria were used in a study. That's why it is very important today, when you diagnose a uterine abnormality, not only to name or classify the condition, but rather it is important to give a descriptive text outline to identify the uterine contours to provide a prospective data collection. Just a few words on reproductive implications of uterine abnormalities. So infertility and the recurrent miscarriages, preterm delivery, as well as fetal disease and placental insufficiency are quite common. So this systematic review that was published back in 2011, including over 4,000 women, and all the uterine abnormalities were associated with malpresentation, fetal malpresentation, and all of them, but awkward uterus, were related to the preterm delivery. Canalization defects of subseptate uterus were associated with statistically significant reduction of conception rate, as well as statistically significant miscarriage in the first trimester, as well as the unification defects like bicornuate, didelphus, and unicornuate uterus. Another meta-analysis published in 2014 reveals the following: the uterine abnormalities, it did not cause any statistically significant conception rate change or spontaneous pregnancy achievement or use of ART, and bicornuate and septated uterus were associated in miscarriages during the first and the second trimester. To summarize the above data, we can see that all the uterine abnormalities are quite permanent, and they are associated with malpresentations, and all but arcuate uterus are associated with the preterm delivery, as well as septate and bicornuate uterus are associated with higher probability of abortions or miscarriages. Management options are presented here. So the problems related to different classifications and very heterogeneous patient groups prevent us from getting uniform results. As to obstructive abnormalities, the surgical treatment to resolve the obstruction that leads to the clinical symptoms is undoubtful, and the other options of surgical treatment of non-obstructive congenital abnormalities, should they be diagnosed incidentally and are not associated with any problems, is still an open issue. Indeed, there is a negative attitude to metroplasty in case of bicornuate or didelphic uteri, and hysteroscopic removal of the uterine septum is indicated. What do we see in the literature? Coming back to the meta-analysis I have shown to you already, so about what's the impact of the uterine septum, we can see that the probability to conceive was not changed after septum resection, and the preterm delivery or miscarriage was not reduced after septum resection either. And as this work shows, the complete resection of the septum results in a reduced number of spontaneous abortions. So the recent Cochrane review demonstrated the efficacy of septal resection. And in this paper, which is 19 pages, demonstrated the combined approach based on the analysis of 78 sources, and there was no publication that completely met the criteria of the Cochrane review. And after analysis, there was 0 papers by the time that was available on efficacy of septum resection, and the authors concluded that the data is missing in the literature, and there is no evidence to support or to reject septum resection. That's why prospective trials are very important. Believe it or not, the same group, just a few months later, published the only randomized controlled trial currently available, where they randomized 87 women into 2 groups, septum management and septum resection. And the primary outcome was a pregnancy developing within 12 months after randomization. So this is a Kaplan-Meier curve to show that there was no difference between the 2 groups in terms of probability to conceive. And the conclusion was that septum resection was not an absolute indication. So there is a big criticism, including, well, internal and external criticism. And Professor Adamian mentioned this. Well, we should not join all septal uterus. We should distinguish whether there is vascularization or there is not, whether there is muscular layer or there is not. And until such a classification or sub-classification is developed, well, you should not be very serious about those results. Again, to summarize the above said, I should say the following. There is a serious problem related to the objective classification or a uniform or a universe classification on congenital uterine abnormalities. 3D ultrasound is the most accurate imaging, and because of lack of classification, ultrasound check should be done very precisely with a very distinctive description and to provide additional information for the surgeons. And currently, the congenital uterine abnormalities are associated with miscarriage during the first and the second trimester, as well as malpresentation of the fetus, and high quality evidence of the efficacy and safety of surgical treatment is lacking. Well, we should not forget about the abnormalities, that the abnormalities are associated with renal abnormalities, and every woman should undergo the additional exam for renal abnormalities. That's all I wanted to tell you, and I would like to thank you for your attention. Now, thank you very much, dear Professor Walski. It is so good to have discussed these issues. Well, and it is to say that it is a high time to develop a new version of classification, but because we are using all the possible imaging modalities in our center, both MRI, including functional MRI, and ultrasound, and 3D and 4D imaging, and hysteroscopy and laparoscopy. So we have all the options in place, and we are going to see the thesis of Dr. Arakelan to see the partial weight of certain imaging modalities, because all these patients are operated because of the reasons you have identified. So it's about miscarriage, which is number one, infertility due to unknown reasons, and inability to deliver due to the congenital uterine abnormalities. So, and these classifications you demonstrated is actually very heterogeneous. So from external view, the uterus can look as an integral organ, but it can be bicornuate or septal from the inside. There are over 5,000 patients included in our registry in Kulakov Center. And I would like to thank you again for your extremely interesting lecture. I think we should raise those issues to the next level, taking into account recovery of fertile function, and because all the septa are different and all the abnormalities are different. And thank you again very much. Dear colleagues, it's time for us to announce the next presentation, and later on we will participate in a live school by Vitoki. Dr. Popredukhin, Dr. Arakelan, Dr. Gusev, and your obedient servant. Andrei Popryaduhin is going to talk about current methods of imaging, modeling, and navigation, as well as diagnostics of various congenital uterine and vaginal abnormalities. Good morning, dear Professor Adamian. Thanks for your introduction, and let me present you our views on the. Will you please turn on your mic? Can you hear me? Good morning, dear colleagues. Let me present you our views on modern imaging options for navigation and modeling, as well as diagnostics of vaginal and uterine abnormalities. So the problem is quite prevalent, and we see various abnormalities in 4 to 7% in the general population. Symmetric uterine abnormalities of impaired fusion of the embryonal ducts, and over 30% of patients are infertile. The universal approach to standardize the diagnostics pathway as well as the surgical treatment is lacking. National Research Center for Obstetrics and Gynecology and Perinatology statistics is presented here. Academician Adamian was at the lead of this trial. Most important complaints were related to primary infertility, secondary infertility, pain syndrome, and problems in sexual life. This classification proposed by European society as well as American societies are not so informative because they do not reflect the variety of different types of abnormalities that we can encounter in the everyday practice. We have developed our own classification by Professor Adamian, taking into account all the possible options. It includes as many as 9 classes and 14 different types. Methods of diagnostics are presented here. The golden standard is ultrasound. And thanks to these achievements, this method has been implemented into clinical practice. Echohysterography, MRI, tomography, or a CT scan are also available. And in case of combined disease, we can combine all these methods together. Uterine or vaginal aplasia is a kind of syndrome which is characterized by presence of uterine rudiments of different expression. And correction of this method, the method which was developed by Professor Adamian, is implied by the laparoscopic assisted interventions. And one of the important and current view on the modeling of 3D objects are presented here. The surgeon who is well experienced in pelvic surgeries can identify the optimal volume of resection, taking into account the specific anatomy of the patient, which is within the area of surgical interest. Using multispiral CT and MRI with special software, we can develop or plot a 3D model to plan for technical difficulties we may encounter during surgery, and as well as various types of abnormalities. The universe approach to 3D modeling is lacking in the literature, and taking into account the intraoperative navigation option, which should be recommended for gynecological practice. At the first step, we have analyzed the CT scans and MRI scans in patients with uterine and vaginal aplasia. That classification is presented on this slide, and it implies fascial elements, fatty spaces, various types of blood perfusion, as well as the condition of the pelvic floor and other details. So these approaches were extrapolated to the visual picture, and we were trying to identify the anatomical parts, which include the urinary bladder, uterine rudiments, broad ligaments, and round ligaments. Using the color mapping, we were trying to analyze the alignment of various anatomical structures, including the uterus, the Douglas space, and topographic anatomy of recto-urethral and recto-vesical fat, as well as the structural anatomy of the rectum. This classification is presented here, and this is the first time it is presented during this Congress. One of the most important step for neovaginoplasty is presented here. We were trying to identify the anatomical structures to orient our surgical intervention. This is the rectum, the vagina, and the vaginal fornix. In some patients, the rectal vesical space was beyond 1 millimeter. It is also Denovilliers fascia and other structures, anatomical structure. Denovilliers fascia was an important structure that is used during colpopoiesis and neovagina formation. So you can dissect your tissues in the avascular areas along the Denovilliers fascia using the laparovaginal approach, using different areas of energy spectrum. This is a 3D computer modeling that can be used to extrapolate the observed data on the other patients. The success rate of your surgery depends on good knowing of anatomy, and to differentiate the pelvic portion of the ureter, where it flows into the urinary bladder, as well as levator ani structure, were taken into account. Hypogastric nerves, hypogastric plexus, and the condition of other neural plexus should be taken into account to reduce the complication rate, which include incontinence and urinary and fecal incontinence. The topographic features of uterine rudiments are shown here. It includes muscular bundles and fascia pubocervical, and all the uterine rudiments are just at the stage of their early development. We have found certain consequences of embryological abnormalities, and we identify the complex of uterine rudiments, including the muscular bundles and rudiment vagina, which includes the upper portion of the natural vagina. So, and it is in line with the classical embryological theory shown on these slides. And another important problem is a combination of vaginal and uterine aplasia, which are combined with extragenital abnormalities. which all make your surgery more complicated. In 2 patients, we observed uterine and vaginal aplasia in combination with a single kidney. And 3D CT modeling revealed a pelvic kidney, as well as calyces and pelvic system, which was also impaired. And it resulted in a higher risk of injury of the above structures. And we decided to refrain from surgery because of high risk of surgical complications, and conservative treatment was recommended. The double pelvic kidney was revealed, and non-functional uterine rudiment, and the only ureter was below the uterus at the level of confluence with the urinary bladder. At first step of surgery, a uterine rudiment was removed, and colpopoiesis with a pelvic peritoneum was done. And finally, I should say that based on the observed data, we have studied the anatomical structures of the vagina and the uterus, and specifics of the uterine rudiments were analyzed, and multivariate analysis and a virtual planning system were proposed using navigation systems for planned surgery. And we want to optimize the surgical treatment of patients with uterine and vaginal aplasia, and as well as standardize the approaches of surgical treatment. Thank you very much for your attention. Thank you. I'm very excited about your results. And so I should say that Andrei Popriadukhin is a very talented surgeon. He's working on his thesis right now, and he has done a lot to set up a patient registry. Now it is at the pilot stage, and let me congratulate you on your first publication and first presentation of your results in Russia, as well as at the international level. You are running ahead of time, I should say, with your results. Thank you very much. With that, let me conclude the session on the congenital uterine abnormalities, and we have seen the main message of this session, which is not only based on the knowing your anatomy or proposing or developing a new classification, but I should say that it is important to diagnose a disease on time, and this information should be communicated to your patient. And as soon as you see any problem related to infertility or miscarriage, right away, you should be ready to correct the abnormality, because in 30% of cases, it results in either infertility or miscarriage. So now it's 5-minute break, and we will be looking forward to a brilliant lecture of the pioneer in hysteroscopy in the real OR, Stefan Pitocchi from Italy. Well, 5-minute break. Thank you.
l'istoroscopista nel giorno della chirurgia. Quindi io finisco, vado giù e sì, sì. Mi sono fatto fuori un vassetto da 1 chilo una volta intero. Avevo timore la prima volta. Lei dice, no, no, prego, guarda, apri il frigo, vedi quanti ce ne sono. Perché usi quello scatolotto per fare da... Hai un'entrata... Vabbè, non ti conveniva mettere... suo dentro lo scatolotto. Con l'ingresso classico, ma non lo puoi attaccare lì, quindi devi comprarti l'adattatore mini normale ed è un'ulteriore perdita. Sì, è mini normale, poi devi prendere lo scatolotto per attaccarci quello, altrimenti devi prendere un adattatore che... ma l'adattatore, che da una parte ci plugga il cavo,
Stephanie and a live surgery. Stephanie Bitaki
Yes, good morning. Hi,
is
Leila.
head of the service
Yes.
of endoscopy of Ida Mora University. Stephanie Bitaki is the creator of his own hysteroscope. Stephanie Bitaki is the author of many surgeries and the creator of Office Operative Gynecology. Stephanie Bitocchi
Togliete
is
questa
our big
cosa
friend
bianca qua
and
sopra, o
teacher.
mettetela in alto.
Dear Stefan,
Mettila
the floor
alta,
is
sì.
yours, please. The theme of the presentation is evolution of hysteroscopy during the last 40 years. What
Stai
happened
registrando
in
tu?
hysteroscopy? Please, Professor Bitocchi, the floor is yours.
Good morning, Leila. Thank you very much. I'm very happy to be with you in this remote version. I hope this is the last one, and next year we'll be together again. Before starting, I want to introduce my team. This is my endoscopic team here that collaborate with me for every day for daily procedure. So as we said, having only half an hour, I would like to show to you images, as we usually do in Moscow, live procedure, instead of boring people with the presentation. So I will perform procedure, and in the meantime, I will give you all the information you need to be up-to-date, as you say. So today we have a lady of 61 years old here in front of us in our ambulatory. Our ambulatory is nothing special. You see, we are dressed normally. We just dress gloves and obviously mask because of the problem of COVID, and the patient is perfectly awake. No drug, no injection, nothing taken before, during, or after the surgery. So now I'm starting first with the office hysteroscopy, because I don't know the patient. I know that she supposed to have a polyp, but I don't trust, as always, any previous examination. I have to check myself what's going on. So we have our office hysteroscope, you know very well. This is the 4 millimeters, and we approach the vagina and the cervix in vaginoscopy. Okay, so we wait until all the bubbles goes out. No, potete lasciare la luce. We wait until all the bubbles goes out, and then we are inside the vagina. So I give you the endoscopic image, and in picture my hands, if I can do it. Okay, nella piccola, from time to time I will talk in Italian to give the right inputs to the technician. Okay, so I have to regulate the focus, usually extract the instruments, and I regulate the focus on the instruments. That is the best way to do. Okay, and then we look for the cervix. Patient, as I told you, 61 years old. So usually in this lady, the cervix is not located. There is always a little bit of prolapse and of the cervix. So we have to look carefully for the cervix. And you see, you start seeing the posterior fornix and then the ostium. Then when you get into the cervix, you start moving, rotating the scope in order to fit the shape of the cervix, that usually it's oval, with the oval profile of the instrument itself. So being a menopausal patient, obviously we encounter a certain stenosis or reduction in diameters until we are inside the uterine cavity, and we have a nice combination of polyps, fibrotic polyps. So I want to try to show to you, at least in one case, we have two cases, but I want to be sure that you see everything already from the first one. So the classic technique of polypectomy. We have the grafting forceps here, and that is the basic tool, and we slowly we use this technique, that is the new technique we described already many years ago for polypectomy. We don't grasp the polyp and pull the polyp towards us, but we do the different. We push the polyp towards the fundus slowly, and you can see that we shave completely. Look, the area here, we shave completely the area of connection of the polyp with with the surrounding myometrium. So this is an excellent tool, excellent technique, particularly in this patient with this fibrotic cystic polyp, because there is no endometrium at all. With the fertile patient, you see here the polyp. So the first polyp is being removed. I give the polyp to my assistant, and as quickly I go back into the cervix again. So this is the technique we perform, and then I will show you with the mini receptoscope. We will try to remove another one. Okay, so you will see the use of classic instrumentation and the use of the most advanced tools like the mini receptoscope. Okay, this is another polyp. We remove with the same technique. You see very easily. You see everything in real time. So there is no special effect due to the presence of the editing. And then at the end of the story, it remains one large polyp. You see, there is nothing left, but we have this structure that probably is not a polyp. It looks more hard. It looks like a myoma. We don't know if it's a myoma or if it's a polyp. So you see, it's very stable. So I cannot remove this. It looks more to me as a myoma, even if, you know, here there is something. So we use the mini receptoscope, and that is already prepared. So you see the cavity, we did already polypectomy. Here there is another one on the fundus. Let me check what is it. And even this one, it's quite hard, and it looks also this one as a myoma. So I will show to you now the myomectomy with the mini receptoscope. The ostium is not too large, it's less than 5 millimeter. You see here? So the opening of the forceps is 5, but this is less than 5. But anyway, I will talk now a moment in Italian. In the meantime, I change the cables, and I will inform the patient that the introduction of the mini receptoscope, she will feel a little bit of discomfort because we have to push the mini receptoscope to enlarge mechanically the ostium from 4 millimeters, that is even less because the oval instrument, it's called 4, but in reality it's 4.3 per 3.2. So that's the reason why it is easily to introduce a scope, the office hysteroscope. While the mini receptoscope, that is the smallest one available today, it's 5 millimeter, but it's totally round. So here we have the images from the mini receptoscope, you see, quickly mounted. It's always on our table. So, signora, adesso io ho cambiato lo strumento, sentirà all'entrata un leggero fastidio, ok? Un po' di pazienza e risolviamo la questione rapidamente, ok? So, we get in with the mini receptoscope. You see, this is the shape of the ostium. You have to take in account that this electrode is 3 millimeters. So you see, this is the exact shape of our hysteroscope. If I rotate the camera, it looks like the tip of my scope. So you see, it's totally atraumatic. Now with 5, I have to push a little bit, and the patient feels that I'm introducing something bigger. So it's only the matter of getting in for the first time. So the patient has been, okay, signora, tutto a posto, va bene? So now we are inside the cavity. We wait a little bit to clean. Okay, and you see the myoma here. So quickly, we go for the myomectomy. Okay, you see the myoma? You see nice capsula all around. Okay, so this is an excellent tool to remove pathology that normally are supposed to be removed in the operative theater within a certain limit. Okay, so I quickly do what I can do, and then we move. Okay, so bleeding can be easily stopped. And now the issue here is to evaluate the presence of the capsula. We have also the so-called Mazzone electrode in order to perform, if you want, the let's say the mechanical enucleation. So, but the problem is, while the patient is totally awake, I cannot play too much with the uterus of the lady. So I remove the chips. The chips are, let's say, they have all the same diameter. They change in length because the loop is closed, it's round. So, you know, I cannot do anything else than helping the chips to go spontaneously out of the cervix. I don't use the electrode as an hanger, but only to remove the, you know, to accompany the chips out. You see, here we have, so I have to stop this bleeding. Let me put the scope in the place. Okay. And then you see the capsula, the pink area. Okay. And we are removing completely the myoma. So this is a good myoma enucleation in full respect of the pseudocapsula. You see here, I put the electrode between the capsula and the myoma. And when I feel that the myoma has been captured, I have to clean the cavity a little bit. Okay, so you know, the electrodes helps. Ok, signora, tutto bene? Ok, un po' di pazienza. I'm removing these chips. Okay, and this helps me to have a good view of the cavity. So once again, the patient has no any kind of pharmacological support, nothing. Even, you know, some, let's say, Valium or things like this, we don't use anything. Okay, you see how the chips flow out because they have, they are totally round, and then it's out. Okay, so okay. So we are getting close to the end of the procedure. I have still here a little part of the myoma. You see the capsula here. Okay, so now the patient, when I am activated the electricity, she feels something because we are getting close to the myometrium. Okay, so so here we try to do our best in order to, okay. So it's fundamental for us to have, you don't see, but there is one of my younger assistant is next to the patient, and he's talk with the patient. I can explain the patient what we are doing and, you know, what has been done. So she tried to keep the attention of the patient away from the procedure. And this is absolutely important. So the myoma, it looks bigger than it was supposed to be. You see here. So we cut, and there is the intramural part going out. So you don't have to be, I mean, we are not pushed to run or to do everything in one procedure. The patient can easily come back if the procedure takes too time, or if the patient doesn't feel so good at the end of the story, because anyway, it's a heart issue. So at the moment, I listen the patient, and I listen the patient talking with my assistant. So we are still in a safety range. The only problem is that I have to reach the intramural area. So this is obviously intramural area means myometrium, and myometrium means innervation. So I have to wait for a little bit. Here you see there is nothing left. This is the capsula, still here, a little part of the myoma. Okay, I'm hanging slowly, and I remove it. Okay, so here you see we touch the capsula, and this is the reason why we did some bleeding, and it's almost done. Okay, almost done. So you see, probably not so good. The movement of the electrode are semicircular. So I try always to be at the beginning deep into the myoma, and then getting close to the capsula, I reduce the penetration of the myoma into the capsula. You see here, and I'm getting high. So this myoma probably will need a second approach in a week or something. And this is because we don't want to leave anything inside the uterine cavity. So you see here, let me regulate the focus. It's not perfect. Now it's much better. Okay, there is still a part of the myoma here. Okay. Okay, let me take all the chips out and having a view of the cavity. So you see, I'm just holding, taking by hands the chips. I'm not doing as we do normally with the classic rossettoscope, holding the chips in between the lens and the scope. Otherwise, the electrode will probably broken. It's a very delicate, it's a small one. So miniaturize, and then okay, I'm removing these extra chips. Okay, you see the chips float out. So here to play with this, it's absolutely important to have a good generator. We use autoconform starts, that it's perfectly calibrated. There is an option to work in a better way with the mini rossettoscope. In fact, I have noticed a big difference, for example, between this version and the previous version that was provoking a lot of sparks on the electrode, and the sparks means a reduction in the life of the electrode that anyway are disposable. Okay, look at the nice view of the capsula here, and the patient is in the moment talking with my assistant, so I feel again safe. Okay, but you see, and we are getting close again to the osteo, to the end. Let's take also these chips out. Okay, ok. Signora, stiamo togliendolo tutto. I'm explaining also myself, so the patient has to listen your voice also. You see here, still a little bit of myoma left on the lateral wall. Okay. Okay, so floating out. I leave for a moment this part of the myoma still there, and this probably will be an issue. I prefer sometimes to leave the opportunity to the uterus to contract itself and to remove and to push the myoma into the cavity, okay? There is still this part, but this is still intramural, okay? So I will not be disappointed to get inside the uterine cavity in a while. You see how much we took. I want to just approach quickly this smaller one. Okay. Okay, here we are. Okay. So this is the area on the fundus where we, and you see how delicate is the work you can do with this device. It's really powerful, and it brought the office surgery in a new dimension. Okay, so we still use bipolar electrodes and scissors and grasping forceps, but certainly to do this kind of surgery, this is fundamental. You see here how much of the myoma is still there. So it's a G1 myoma going deep inside. Unfortunately, on the anterior wall, you see the bubbles more than on the lateral wall because the bubbles stay there. Okay, so you see chips are floating out, and this myoma, the intramural part of this myoma, will be pushed into the cavity in the following days or weeks. So when we will go in for a control in maybe 1 week, 2 weeks, depends by the lady, we will find this myoma completely, the remaining part of the myoma. Okay, let me see if I can do something more. Okay, okay, we have here a small part, so almost all the myoma is gone here. Okay, so you just shave, you see, very carefully, the myoma using the mini rossettoscope. Here is already the capsula. Okay, let me take all the chips out. Okay, so it's perfectly done. Still here, I have to remove this part here of the myoma. Okay, now this patient is feeling a little bit of pain because we are close to the wall. Okay. And you see the difference when we get too close to the myometrium, we also touch the capsula and therefore we have a little bit of bleeding. So just stop the bleeding with the, this is still a part of the myoma. Patient, it's very good. It's very, let's say, give us the opportunity to do our job very good. So from time to time, I cannot say that it's totally, let's say, pain-free, but she tolerates very well also the small discomfort. Okay, so you see the fundus is clean. There is no part of the myoma left. You see how deep the myoma was. Let me have a look in the meantime to the lateral wall. Here, there is still this part of the myoma still connected. You see here? So I'm going between the myoma and the capsula and removing another large chip. You see here? I didn't touch the capsula because I put the electrode behind it, and you see the myoma is getting out. The problem is I'm losing space in order to have a better, let's say, okay, let's go out with the chips. I'm losing a working space, so I have to see when it's time to stop and leave to the uterus the possibility to divaricate un po' le gambe. I have to ask the lady to open a little bit the legs because I'm fighting against, the position of the legs. Okay, it's good. And the best part, trust me, is when you afterwards, you see the patient thanking you and going herself out of the bed, dressing and going home immediately. So the patient is still dressed the way she was dressed when she came in. So she didn't get naked or any special. You see here? Okay, still this small part. So probably we are ending, okay, the procedure. A little bit of bleeding here, so I have to coagulate. I don't care about that one. You see, I'm pushing. Okay, give me a little bit of time. See, signora, patient is laughing now because she said, you always say that you are ending, but you never end the procedure. So it's okay until the patient reacts like this. Okay, just put the electrode below, in between, you see the myoma and the capsula, and then we remove this one. So I'm really believe that we are heading to the close to the end of the myoma. You see there is this border that I don't want to touch that hide this part of the myoma. Okay, okay, we are getting close to this. Fantastic. Okay, okay. Okay, okay. You see the myoma here? Ok. Signora, abbiamo tolto un bestione, era enorme. Lei se l'era tenuto molto, molto caro nel suo utero, ok? So we are trying to joke with the patient just to finalize the last movement. Done this part still a little bit, but don't be, let's say, obsessed by the fact that you have to remove all the myoma. You will certainly have a chance to see the patient. You have to see the patient to guarantee the patient that the procedure was successful. So if something is left and it's not getting necrotic in the meantime, you will probably be okay. So you see, big myoma, big, and all the capsula is it's there. So we didn't. Okay, this is the remaining part. Every time I say that we are finished, patient, you see here, this is the capsula, and there is still this small part. Okay. Okay. Now it's really ending. Sì, sì, signora. Okay. Coagulation. Ending. Okay. Perfect. So we don't care if some chips are still inside. So excellent results. Again, one big myoma here and a huge one here, probably around 2 centimeters, totally removed. Okay. So, tieni qua. So, Leila, we are now close probably to the half an hour. It was my time. This is just to show to you how far we can go. Last time I was with you in Moscow, it was 2 June ago, because last year it was also COVID. You didn't have the chance to show the power of the mini receptoscope. So today,
we are still with you.
okay,
I
if
feel
you
you
want,
here. I sense your presence. Well, thanks to our congresses that are now counted to 34 summer congresses and 15 winter congresses, where we know very well the names of Jacques Camus, Professor Betocchi. So their methods they are demonstrating are now quite prevalent. So we have implemented all your recommendations, all your guidelines, but all the time we want to demonstrate your innovative approaches. Stefan, you have some 5 minutes. So what would you like to say? What would you like to conclude?
Yes, I will conclude telling you exactly which is the power you have in your hand. So people say, oh, okay, I want to buy this, I want to buy that, I want to do this, I want to do that. We have to fight with the money, of course. Let me move laterally because the patient is going out of the bed. I go here in the corner. So we leave the possibility the patient to leave our bed. Vieni vicino a me. So what the people have to buy to do hysteroscopy? Certainly, they have to start from the basic set. The basic set means the office hysteroscope you saw at the beginning. Without diagnosis, you cannot go anywhere. So the basic set is the scope together with at least 2 instruments, the grasping forceps and the scissors, okay? This is really super basic. With this instrument, you can perform hysteroscopy, you can take a biopsy, and you can remove small polyps, cutting adhesions, doing small, let's say, surgery. Then you have the second step is to buy bipolar 5 French instruments, like Storz bipolar, VersaPoint, the one you prefer, in order to add bipolar surgery to your tool of instruments. And then you have to change completely instrumentation by the mini receptoscope in order to approach all the pathology, but particularly those pathology you cannot approach, like this myoma. You cannot do it in office. You know, it's a headache. It's too big, the myoma, but you can do it in office, keeping your operative theater free from this minor surgery. And then you have the world of morcellators, you know, like the morcellators, like the Bugatti shaver. That is another world, another instrument. So you have to understand how much you can invest. Of course, the best would be to have everything in your office. The instrument, the office hysteroscope with the grasping forceps, with the electrode, bipolar electrode, the mini receptoscope, and the small caliber morcellator. We are lucky because we are a big institution, so we have everything. We have what I show you today. We have the trochlear device. We have the Bugatti mini shaver, so we can choose the best instrument for our procedure. It's like to have in your garage 3, 4, 5 cars, and you choose the best car for what you have to do. To go shopping in the center, you need a small car. To go out road, you need a SUV, etc., etc. But of course, not all the people can afford to buy all these instruments. So you have to start from the beginning, and then day by day, increase your power, your skill, and then your instrumentation. So this is the message, because you saw today myomectomy and you will tell, oh, I want to do myomectomy also myself. Slowly. You have to go slowly. You have to be able to start from the beginning and grow day by day. So I said really this is for me the main message. And then of course we have tons of different information, but you cannot give all this information in half an hour. Main message is choose your tools and start from the beginning. So thank you very much, Leila, for your invitation. I really hope to be with you next year again as we did before.
Dear Stefan, dear colleagues, it's been a great pleasure for us to attend this masterclass delivered by the renowned expert in hysteroscopy, and he's very precise, and this surgery was not resulted in any bleeding at all. So we are trying to use these methods, and the guidelines for hysteroscopy have been implemented in the Russian Federation. Well, I've got 2 points for you. I've just talked to my colleague. So we also do it under local anesthesia, but it depends on the patient's preferences. Because we work in Kulakov Research Center, this is a high volume center. We do hysteroscopies very much, but we do some intravenous sedation as well. But if the patient doesn't want to be sedated, well, why not? So you can do it at your, you take your liberty to do whatever you like. Well, dear Stefan, after having implemented these methods, we would not go for any wide surgery or open surgery or even laparoscopic surgery. So everything can be done hysteroscopically, including uterine septa, adenomyosis, and other conditions can be operated hysteroscopically. I've got one question to you, because you are a real champion in hysteroscopy and your brain is working at the highest level. So what's your next prospect? So what will be your next step to improve the results?
Of course, Leila, everybody has to choose the best environment where they prefer to work. Of course, I'm the guy who have to show the limits of the technique. So I like to present, when possible, a new limit for office hysteroscopy. So again, today you saw patient without any kind of drugs, nothing, even a small pill, nothing. The patient went out. In the meantime, I was talking. She's putting the underwear in the toilet, and she will go home. So nothing that remembers her the operative theater. But of course, you have to grow, and sometimes you feel protected by sedation or by local anesthesia. So you can start with sedation and local anesthesia, and afterwards reaching this. So my job is to show the people where they can go. And then, of course, it's not for everybody. They have to choose their own way. And of course, I'm trying to implement always new instrumentation, new technique, new idea. So, for example, we have now implemented the new concept of biopsy that you will, Signora, arrivederci. You know, the lady's saying bye-bye to us and she's leaving. So we are implementing a new concept for biopsies in presence of atrophy, in presence of or hyperplasia, adenocarcinoma. We are preparing a new generation of hysteroscope, much more flexible than the hysteroscope we have today. So we have worked on several, let's say, line on the medical one, try to find new application for the existing instrumentation, and for the instrumentation, try to find new instruments to improve and increase the power of hysteroscopy. So this is the job for people like me. I have to open the road. It's like when you have a lot of snow in Moscow and you cannot go with a normal car. You need to have a big truck that open the road and push the snow out. And then, of course, the cars behind the truck, they have to dress, the special tires and so on. So I like to think myself and other colleagues like the big truck that opened the road from the snow and allows the people to walk through the road and reach your house, your summer house, your winter house, your dacha, or whatever. So this is my vision.
Thank you very much. So I don't like your word of truck, but we are using a big car. So, or we have taken a big plane. So, and this is all aimed at our patients' health. Thank you very much for making our Congress so beautiful.
Спасибо большое.
So I want
Okay.
you now to get to the next presentation on hysteroscopy.
Stop a me, lascia il video, stop a me. Video audio.
Dear colleagues, I am waiting for connection of Jan Deprest from Belgium. We want confirmation from your side.
I am here.
Yes, are you with us?
Yes, I am here. I am on the screen, but I cannot hear Professor Adamian.
Good morning. Good morning. Let us move on along our agenda. And now we are having expert school on fetal medicine. And in this session, we will have Professor Jan Deprest from Leuven, Professor Valsky from Jerusalem, Professor Kostyukov, Gladkova, Tsekalo from Moscow, Kulakov Center, academician Kurzer, as well as Drs. Kosovtseva, Bashmakova, Malgina from Yekaterinburg. Let me give the floor to Professor Deprest from Belgium. Professor Deprest, a professor in gynecology and obstetrics in Leuven Hospital, University Clinic. Over many years, or decades even, you have been working with us, helping us in many issues. And he has done a lot to develop fetal medicine all over the world and in Russia as well. Thank you very much, dear Professor. The floor is yours.
Thank you very much, Professor Adamian. You can hear me well. If you could not, you hear me? Yep. Okay, so today...
Yes, please, go ahead.
Yeah. I would like to share with you breaking news. This morning in the New England Journal of Medicine, the results of this trial were published. So you're the first ones to hear about it. Congenital diaphragmatic hernia is a rare disease, and it is something we can diagnose before birth. In 2 out of 3 cases, the diagnosis will be made in the 2nd trimester. Although in the 1st trimester, the diagnosis is possible, but it is uncommon in clinical practice. When you diagnose such condition, you will have to collaborate with an expertise center who can do comprehensive assessment, an individualized prognosis estimation, and then can counsel the patient and make timely arrangements for delivery. As you will see today, the prenatal management will become increasingly more important. Please do not state anything about the prognosis before all of this is done. You have to first rule out associated anomalies because they are quite common. They can be both structurally as genetic. Today, but I'm speaking only about isolated congenital diaphragmatic hernia, and I will speak mainly about the left-sided phenotype. Already early in pregnancy, the viscera ascend into the thorax, and therefore the lungs are underdeveloped at birth. It is a surgically correctable defect, but the problem of these babies is mainly lung development, both in the airways as well as the vasculature. There is ventilatory insufficiency and pulmonary hypertension, and as you can see on this slide, the mortality over the last 15 or more years has virtually not decreased. Overall, still a 30% mortality. Many of these babies have longer term morbidities, and nevertheless, when they rate their quality of life, they usually rate it as in the normal. For those who would like to read more about this and the long-term morbidities, you have this interesting publication. In the prenatal period, we assess the severity by measuring the lung. On a 4-chamber view, the lung is traced, the head circumference is delineated, and the lung-to-head ratio is calculated. A correction for gestational age is done by expressing the lung-to-head ratio as a percentage of what is normally expected. The other structural finding is whether the liver is in the thorax or not, and both together can be used for making a personalized prediction. This paper shows in instructional videos how you have to do this. This is what we use for patient counseling. So babies with a lung-to-head ratio under 25% are considered to have severe hypoplasia, and they are called like that because their survival rate overall is under 25%. Moderate hypoplasia has a 60 to 70% survival rate and mild hypoplasia above. Today, the trial that I will propose to you, the results, is in isolated severe diaphragmatic hernia. So the moderate lesions are also part of a trial, but at this moment, I will summarize the results at the end. But today, what I present mainly is the results of the severe trial. So what can one do before birth? Tracheal occlusion is a way to stimulate lung growth. It replaces the anatomical repair, which was done 30 years ago, but abandoned for morbidity. The occlusion is actually inspired on the observation that in fetuses with laryngeal atresia, they are born with hugely developed lungs. And this is because fluid entrapment in the lung makes them grow. There was then about 10 years of experimentation done to try to find out the right time point to do the occlusion and to develop techniques to do so in a minimally invasive way. Initially, the procedure of occlusion was done with hysterotomy and external clipping, as you can see here, plugging, and then all kinds of variations. Our group has focused on the development of a fetoscopic technique that can be done under local anesthesia. And in a phase 3 trial, we could demonstrate that the survival rates apparently were increased in the fetal group. But that, of course, were very biased data. We also have shown that this operation is from a maternal viewpoint quite safe, and that the reproductive potential is not compromised by fetoscopic surgery. In this trial, we used the technique which is usually referred to as feto. It's a procedure that is done percutaneously under local anesthesia with fetal immobilization and pain medication, and using standardized balloon and fetoscopic instrument. Mothers could not participate to this trial if there were maternal risks, technical limitations, a high risk for prematurity, and psychosocial factors or non-compliance. For centers to be able to participate in this clinical trial, they had to be having an active fetoscopy program and a wide experience with fetal procedure. Now, you have to keep in mind that we insert a balloon in pregnancy, but that it also is removed, and it is removed either by ultrasound guided puncture, by fetoscopy using the same instruments as for the insertion, or in need, when delivery is imminent, one can even extract the balloon on placental circulation and even puncture it after birth, after division of the umbilical cord. In this trial, the postnatal management was standardized according to European CDH Consortium consensus protocol. In this trial, the patients were screened at referring centers, referred for fetal surgery to a fetal surgery center, randomized 1-to-1 to either expectant management or to tracheal occlusion at 27 weeks if the condition was severe, or to moderate, in moderate cases, a bit later in pregnancy. The balloon removal was at 34 weeks, and the postnatal management was, as I said, standardized afterwards. We hypothesized that fetal, compared to expectant management, followed by this standardized care, would increase survival to discharge. The primary outcome was survival to discharge, but there was a secondary outcome, which was survival till 6 months. It was an open label randomized superiority trial, and we hypothesized that it would double the survival. And for that, we would need twice 58 patients. We screened 170 patients, 95 were randomized, half-half, and at the third interim analysis, this trial was stopped because of efficacy. At that time, there were already several patients included and not reaching the endpoint, but the results that I will show you are of the first 80 patients, but no different in the remaining patients. We had comparable baseline characteristics, both from a maternal viewpoint, also from a viewpoint of severity of the condition, as well as predictors of prematurity. The primary outcome and the intention to treat the intention to treat analysis showed a clear benefit of fetal surgery. The survival was increased from 15 to 40%, and this gives us a relative risk of 2.7 nearly. The survival persisted until 6 months of age. The difference in oxygen need, however, was not significant. It came at a price, and the first thing that one expects with fetal surgery is that it increases the membrane rupture rate, which occurs in 1 out of 2 patients prior to 37 weeks. As a consequence, gestational age at birth is earlier, and 40% of patients will be born prior to 34 weeks. This gives a lower birth weight, and of course, this has consequences on some parameters, such as the use of ECMO. When looking at the other morbidity indicators, such as ventilation days, days enteral feeding, there were some trends for a shorter stay, but again, this trial was not powered for performing statistics, so it was not even attempted. Now, in terms of surgical technique, because this is a fetal surgery session, the insertion failure is very limited. There were no instrument failures. The only failure was a surgical one, so where the surgeon could not reach the fetal mouth and no procedure was done. A problem is that this is a handmade balloon, that it is used off-label, and that when it deflates, one loses, of course, the occlusion potential. In terms of removal technique, the preferred technique apparently was fetoscopy, certainly if it was done electively. The balloon removal was not successful in one case. It led to an iatrogenic death. And in one patient who moved away from the fetal surgery center, she presented at the local unit and the balloon could not be removed. So in conclusion, I can only say that today it is now proven there is level 1 evidence that in severe diaphragmatic hernia, feto increases survival. We have done last year a similar study in right-sided cases showing the same results. In moderate CDH, there seems to be an effect in survival increases from 50 to 63%, but that did not reach significance. You can see here the confidence interval. The fetal procedure is associated with a high risk for membrane rupture and preterm delivery. There are no severe maternal complications reported, but from a fetal viewpoint, of course, it can lead to iatrogenic death. Long-term outcomes are not known yet in this study. Of course, there might be an impact of prematurity. We will now analyze the pool data to know where the real cutoff would be for fetal surgery. Other gains in the future will be a reduction in invasiveness by avoiding the second procedure and using less invasive instruments, and perhaps potentiate the effect with medical adjuncts. Of course, we have to keep in mind this is a surgery that is best done in experienced centers if one wants to reproduce this type of results. I would like to thank all the co-investigators and all centers in 45 places and 15 countries across the world for doing this trial. I do thank you for your attention. For those who would like to read up, these are the publications that are behind these data. And I would like to thank you for having interest in a surgical conference for the unborn patient. Thank you very much.
Thank you very much, our dear Jan de Preste. Could you tell me, please, well, how many years have you been doing fetal medicine? How many years?
Well, thank you, Professor Damian. This is indeed already a historical procedure, so to speak. It took 10 years to complete this trial. It took 18 years from the first in-human procedure to the finish of this trial. And before that, there were 7 years of experimentation.
And who should be a fetal surgeon? What kind of surgeon can be a fetal surgeon? And a gynecologist, a gynecological surgeon? You are a multidisciplinary surgeon. Well, who should be a fetal surgeon? What kind of surgeon? From what area? Yeah. A common surgeon or maybe someone else?
So for this type of fetoscopic surgery, there are 2 skills required. One, it's an endoscopic procedure, so you have to have stereotactic skills and be used to do single orifice surgery, because that is what we do. The second thing, and that is not very common, you need to be familiar with ultrasound guided procedures. So in that case, you need to have this marriage of the 2 types, and therefore I think a obstetrician that has been working in both sides would be appropriately trained to do this. So that is how in Europe, and I include your country in that, in Europe it is typically done by maternal fetal medicine specialists who have been trained in endoscopy.
Okay, tell me please. Well, you've come through all stages of fetal surgery. You prepared even our specialists in this field. Thank you very much for this. Well, maybe some procedures, we'll discard them. We won't use them in the future. Some operations will be used in the future. What operations will be done in the future? What operations we should forget about?
Well, what we are at this moment, of course, witnessing, and other speakers will address that, is the introduction of fetoscopic spina bifida surgery. And at this moment, a new indication we are exploring is the use of fetoscopic coverage for gastroschisis, but this is completely experimental still.
All right, it was a pleasure to listen to you again and to see you. There will be also other doctors talking about fetal surgery, academician Kurtz, Professor Kostikov, Bashmakova's group, and Professor Valsky. If you have time, stay with us. If not, well, go with your chores. Thank you very much, Professor Deprest. Now the floor is given to a group of scientists and researchers from the Kulakov Center of Obstetrics and Gynecology. These are Doctors Kostikov. Dr. Kostikov will make the keynote presentation together with Kristina Gladkova and Dr. Sakala. Professor Kostikov, are you ready? Yes. The theme of your presentation is intrauterine surgery for complications of monochorionic pregnancy. Well, good afternoon, Professor Adamian, dear colleagues. I represent a group of the authors from the National Center of Obstetrics and Gynecology, the Kulakov Center, and I'll be talking about intrauterine surgery for complications of monochorionic pregnancy. You know the complications that you see here. First and foremost, that's twin-twin transfusion syndrome that occurs in 10–15% of cases, while TAPS that occurs in 4%, the syndrome of reverse arterial perfusion, and TRAP, also small for gestational age and antenatal death of one of the fetuses in case of monochorionic pregnancy. Well, twin-twin transfusion syndrome takes place in 10–50% of all cases. It leads to perinatal death among twins in 17% of cases. And if there is no intrauterine treatment, well, the unfavorable outcome occurs in 80–100%. Well, the problem of this condition leads to the presence of a venous anastomosis when the blood flow goes just one way. And thus we have a cascade of pathological changes on the part of the donor and on the part of the recipient. As for the diagnosis of this condition, it is rather simple. The key diagnostic criteria is the omnihydramous of the donor, which is characterized by the pouch less than 2 centimeters, and oligohydramnios in the recipient fetus. The oligohydramnios depends on the duration of the pregnancy, when we have enough water, and the border is 6 centimeters from 18 to 20th week, it's more than 8 centimeters, and after 20 weeks, it's 10 centimeters. The second stage was offered in 1989, and Robin Fontaine proposed the classification 5 stages you are all aware of, which reflects the progression of this pathologic condition, and the stage 5 leads to the death of one or both fetuses. As for the methods of treatment, they are shown on this slide. They can be symptomatic, such as amnioreduction and the reduction of the amniotic fluid from the recipient fetus. Well, it may be the selective feticide, or there may be a combination with a small for gestational age or anomalies in one of the fetuses. But as for twin transfusion syndrome, well, fetoscopic selective laser coagulation, which boils down to the coagulation of anastomosis, which causes twin transfusion syndrome. Well, at our center, we started to introduce this technology starting from 2011, and by 2020, we had performed 234 fetoscopic laser coagulations. The overall survival was 81%. As for one fetus, as for 2 fetuses, 56.8%. Starting from 1919, fetoscopy is done using the Solomon technique, and the overall survival accounted for 91%, both fetuses 68%. The delivery time is 32 weeks. This slide shows the typical operation, anastomosis coagulation. All procedures are being done at our center are done under local anesthesia, and it is done under ultrasound control. We choose the best place for approach. We enter the amniotic cavity of the recipient, then we examine the placental surface with detect anastomosis and do the coagulation. The Solomon technique modification is that we coagulate not just anastomosis, but also we connect the placental plane between them in such a way so that we could prevent any possible complications. We know that from 15 to 20% of anastomosis can be missed during fetoscopy when selective coagulation is being done. Thus, the recurrence rate in case of twin transfusion syndrome can be up to 15%, and the anemia polycythemia syndrome from 5 to 10%. The idea is to calculate not just the anastomosis, but also to connect each point from the calculated anastomosis with one another. Thus, we have a line along the vascular bed, and we have the real placenta from the monochorionic one. So we can reduce the recurrency rate to less than 1%. And we also reduce the anemia polycythemia syndrome. And quite drastically, we compared the 2 different operative tactics, the selective coagulation and the Solomon technique, and the duration of the procedure was comparable in the groups. The localization of the placenta along the anterior and posterior wall was basically the same, no difference. the stages of twin-twin transfusion syndrome were basically the same in both groups in terms of the frequency rate. The interval between the thetoscopy and the delivery date was basically the same. The delivery date was about 31.3 weeks in the group of selective coagulation and 34 weeks in the group where Solomon technique was used. The analysis has shown that such complications as the recurrence of twin-twin transfusion syndrome, the development of anemia polycythemia occurred only in the group of the selective coagulation. Moreover, the introduction of the Solomon technique allowed us to increase the overall survival rate of both fetuses from 48% in case of selective coagulation to 77% in the group where the Solomon technique was used. We also analyzed the factors that could have an impact on the operative treatment of twin-twin transfusion syndrome. It is believed that the risk factors could be the third and fourth stages of twin-twin transfusion syndrome in combination with the small for gestational age or a normal departure of the umbilical cord, the cardiomyopathy of the recipient, ischemic cervical insufficiency, well, oligohydramnios, the placement of placenta on the interior wall of the uterus, and the analysis has shown that the risk of unfavorable outcome is twin-twin transfusion syndrome stage 3 and 4, well, a combination with a small for gestational age and body mass index of the pregnant woman more than 25. There are factors that could reduce the risk. Experience of the surgical team, the more interventions we do, the less the risk we have, and also the use of the Solomon technique. The next complication I'm going to talk about is the anemia polycythemia syndrome. There are two options described in the literature: the spontaneous development of the syndrome, which occurs up to 5% of cases, and post-operative syndrome, which occurs up to 16% as a result of our intervention of twin-twin transfusion syndrome, when we did not calculate all anastomoses, when some of them are very small, that led to the development of this complication. The basis of this complication is slow intrafetal hemotransfusion up to 15 milliliters per day through the arteria of the venous anastomosis of a small diameter less than 1 millimeter. And here you can see the classical characteristic of newly born children. When they have this syndrome, one of the twins is very pale with the decreased concentration of hematocrit and hemoglobin, and the second twin usually has a high blood viscosity and all classical manifestations of polycythemia. The diagnostics of this syndrome is based on assessing the blood flow in the middle cerebral artery. The donor has the anemia, and in this case, we have an increase of the blood flow, and the recipient fetus had the slow blood flow, less than 1.5. For diagnosis, we use also delta mom, and in this case, we subtract the figure from the mom donor recipient. If it's less than 0.5, in this case, we diagnose this condition. On top of that, we can use other ultrasound criteria of anemia polycythemia, well, the difference in the thickness and echogenicity of the placental area of the fetus. Well, you can see the donor fetus, you can see the blood flow is 1.79 and the recipient 0.7 centimeters per second. So the delta is more than 1. That means we have the manifested stage 2 of anemia polycythemia syndrome. You can see stages 1 and 2 on the slide. There is just the difference in the blood flow in the middle cerebral artery. Stage 3, in this case, there is the problems with the fetal placental blood flow in both fetuses. Well, dropsy of the donor fetus, stage 4 and stage 5. That means the death of both or one fetus. Well, as for the management of pregnant women with this syndrome, it can be different. We can use expectant management or preterm delivery or intrauterine blood transfusion to the donor fetus with the removal of the specific blood volume from the recipient with the use of saline solution to reduce the polycythemia. We can also use a selective feticide or fetoscopic laser coagulation. And let me just compare these tactics. Expectant management, this is usually done up to week 34 of the gestational age when there is a stage 1 or 2 of anemia polycythemia syndrome. The advantages are the lack of risk of invasive therapy, and the drawback is the risk of antenatal complications, which can occur even when there is the thorough dynamic control by the ultrasound. Fetoscopic laser coagulation is usually done before the 28th week when it's a stage 2 or higher. The advantages is that this therapy is ageotropic. We remove the reasons for this complication, but as for the drawbacks, there are technical difficulties of doing a fetoscopy because we do not have oligohydramnios or omniohydramnios when we have in case of twin-twin transfusion syndrome, and due to this, it is very difficult to examine the entire surface of placenta. That is why we have the higher risk of pregnancy interruptions, the risk of monoamniotic twins, and some other complications are related to the technical difficulties of fetoscopy. Intrauterine transfusion is done up to 30 weeks in case the patient has a stage 2 and more. Minimally invasive treatment of anemia is the advantage. The disadvantage is that this is symptomatic treatment. It is temporary in effect. The blood from the donor goes to the recipient rather quickly and unfortunately leads to enhancing polycythemia in the recipient, the donor, and such complications can be arterial thrombosis in the recipient, the fetus, with all the negative affecting consequences. Well, emergency delivery after week 28, if it's a stage 2 and higher, in this case, we reduce the risk of antenatal complications, but in the same time, we increase the risk of severe preterm conditions due to anemia, polycythemia, and the selective feticide. It's done up to week 26 when it's a stage 3 or 4 of the syndrome. The only advantage is that it allows us to prolong pregnancy with one fetus when the fetus becomes a term fetus, but there are ethical issues, the issue of selection of one fetus over the other. That's the drawback of this strategy. And at our center, we were lucky to participate in a big study. As you can see it here, CAPS trial, 17 centers from different countries of the world, again, treatment and outcome of 370 cases. And again, you can see anemia polycythemia syndrome. And you can see different outcomes when different tactics were chosen. And you can see these types of management on the slide. I will just focus on such factors as perinatal death, neonatal morbidity rate, and the ability to prolong pregnancy. Well, as for these strategies shown here, well, perinatal death was the lowest when we used emergency delivery and when we used selective feticide from 7 to 8%. The highest neonatal morbidity was when we used emergency delivery, and also the prolongation of pregnancy was the lowest in the intrauterine blood transfusion and emergency delivery. So right now we don't have the gold standard in the treatment of anemia polycythemia syndrome. Even in case of expectant management, the results are the same as the fetoscopy data in terms of perinatal death, in terms of the duration of pregnancy, prolongation, although fetoscopy is the gold standard in the treatment of twin transfusion syndrome. As for anemia polycythemia, here we still have room for studies. We have room for confirming the efficacy of this method as compared to expectant management. You already overran your time. 2 minutes. No, just 1 minute. You overrun your time. We have other people who would like to make presentations. Another complication is the syndrome of reverse arterial perfusion. And I'd like to say here that indications for conducting interventions here is the tachycardia, and the methods of treatment is interstitial laser coagulation and fetoscopy. When the umbilical cord is cut, we analyzed our cases at our center. We had more than 50 cases like this of reverse arterial perfusion. 33 procedures were done in 17 cases. We used the expected management. Interstitial laser coagulation boils down to the fact that under the control of ultrasound, we calculate the vessel feeding the fetus. As for monochorionic, monoamniotic twins, in this case, we do the fetoscopy. We cut the umbilical cord from the fetus with sarcardia. In this case, there is no umbilical cord clamp, and in this case, the fetus can develop normally. Here you can see how we're doing it with the help of the laser. The umbilical cord has been cut. We analyzed the outcomes of the surgery and expectant management, the high risk of neonatal death and morbidity. So in case of surgery, well, the 82% were the good results, 47 in case of expectant management. Thank you very much. Okay, thank you. Kirill, please do not go away, because right now we're having the breakout session of fetal medicine. At the end, you'll have a chance to answer specific questions. Thank you very much for your good presentation and for the unique material. Now the floor is given to Dr. Kosovtseva Natalia. You are here. Please, the floor is yours. Please do not overrun your time. 15 minutes max. At minute 14, you should wrap up your presentation. The theme of the presentation is intrauterine laparoscopic neurosurgery.
This presentation is delivered from the group of Dr. Bashmakova from Yekaterinburg, and the next, and then will be Dr. Valsky and academician Kurzer. Dear colleagues, I would like to thank you for invitation to present our data at such a respected symposium, and we would like to share with you our views on endoscopic intrauterine surgeries. So we follow the rules of intrauterine surgeries in experiment, and we are based on precise diagnostics. We also take into account other factors and follow minimally invasive approach. This is our basic principle that should all the fetal surgeons use. All the surgeries are done in the OR, so this is our endoscopic OR, and currently you see the interventions that can be done using intrauterine approach. This is a spinal hernias hydrocephaly correction, and a year ago we started using intrauterine Gallen's vein correction. Let me start with minimally invasive approach to correct spinal hernias. These are the pioneers of spina bifida correction. We have also a Russian experience of endoscopic correction was first performed in our institution a year ago, and we celebrated the first anniversary of our patient the recent month. And this was, she was operated in an open fashion. So the approach was approved by the ethical committee. So we are based on a legal background, and legislation was reinforced in the last year to include also the spinal hernia correction. The ethical committee also discussed indications and contraindications for intrauterine correction of spina bifida. And these are the options for minimally invasive approaches in spinal hernias using open fetoscopy and transcutaneous correction of the spinal hernia. So we decided to go for open surgery, and we developed this approach on a phantom, on simulated surgery, as you can see here. And currently, we realize all the complexities and difficulties, including intraoperative mortality, multiple punctures using trocars, difficulties in fetoscopy, premature rupture of amniotic chorioamnionitis development, and repeated surgeries. Open fetoscopy provides more comfortable access to the surgeon, and thanks to the fixation of amniotic membrane, we can prevent bleeding from the puncture site. So we operated the first time on the patient with the spinal hernia. Multidisciplinary team was set up to include pediatric surgeons, nurses, and there were 13 doctors and nurses participating in the team. The patient was diagnosed at 19 pregnancy weeks, and it was confirmed also on the MRI. And after that, a gestation age of 27 weeks, the surgery was done in an intrauterine fashion. We used intratracheal anesthesia, including virtual intramuscularly. So we entered the abdominal cavity. The uterus was pulled down to the wound, and additional cannules were used to insert the instrument into the uterus. So special gas media was prepared, the defect was closed, and the operation time was 4 hours, 50 minutes. Then the integrity of the abdominal wall was restored, and this is the view of the uterine, of the uterus after the cannules were removed. In the post-op period, the patient was followed on the ultrasound as well as MRI. Here we see the area of spinal hernia correction, and the patient delivered at week 36, 2 kilo 200 grams, 8 scores by Apgar. She was the patient, the baby was examined, and on MRI, which was done at week 1 after delivery, and myelomeningocele was confirmed on the MRI. So these are the first steps of the patient. She was admitted in our hospital for nearly a year Now she's trying to walk spontaneously. She's developing normally, and our neurologists are quite happy with her. And on the right, we see the patient non-operated who was delivered with severe spinal hernia with a very unfavorable prognosis. Also, a first experience with a fetoscopic correction of hydrocephalus. Hippocrates did the first case of hydrocephalus, and the causes of hydrocephalus are quite numerous. There's intrauterine infection, genetic aberrations, congenital abnormalities that may result in hydrocephalus, Arnold-Chiari syndrome. There are other congenital conditions as well. And intrauterine surgery can be recommended, including shunts, placement. And back in 1982, there were first attempts and indications were identified for hydrocephalus correction. And since that time, many surgeons attempted to correct hydrocephalus using these techniques. And 2 years ago, it was the first intrauterine trisisternectomy, sternotomy, and German colleagues assisted us in the surgery. The patient was attended at week 26. The diagnosis confirmed. Aqueduct occlusion was revealed, first diagnosed on the ultrasound, then on MRI. This is the picture, intrauterine MRI. The tactics for the surgical treatment was identified. It was a Kocher point for puncture, and minimally invasive approach was decided. And here we see the angle of attack for intrauterine puncture through the Monro, foramina Monro. We accessed the third ventricle. The fetus was turned upside down for us to be comfortable with the puncture, and we established communication with the fundus of the third ventricle. And this is the footage of the surgery. The surgery was confirmed by the ethical committee. All the steps were performed prior to the experimental modeling. We use a pregnant sheep for modeling, and this is a Monro foramen, and using Fogarty technique, we can ensure good fluid outflow through the basal cistern along with the occluded aqueduct. Here we see the vessels at the third ventricle fundus in order, and afterwards we insert Fogarty a balloon to inflate it afterwards. Now we insert the balloon. Neurosurgeons assist this surgery step. And, Dr. Yakimov was inflating the balloon to provide good ostomy between the ventricles. Here we check the stoma, and the effect was quite nice. Hydrocephaly stopped from developing, and at gestation age of 37, a baby was delivered, and gestation age was prior to 38th week, and intrauterine triventriculostomy was done, and it enabled us to prolong pregnancy. This is a mother with her child. They participate in our prevention program. The child is coming to his third year, and we were rewarded with this reward. Over the recent year, we have developed a new program for intrauterine correction of Gallen's vein aneurysms. So this is a quite severe condition with a very high mortality rate. It results in a hydrocephalus, intraventricular hemorrhage, gliosis development with subsequent ischemia of the brain cortex. And in the recent years, using endovascular approaches, we managed to reduce the mortality rate, and morbidity rate was also reduced to 20% from 90%. Postnatal correction of this defect is still not feasible compared to other neurological complications. So what backgrounds were used to develop the program for correction? The newborns with Gallen's vein abnormalities require urgent postnatal correction of Gallen's vein and requiring qualified medical care. It all depends on the stage of the condition in the postnatal period. The later you operate on your patient, the better the results are. And the second cohort that can perceive watch and wait tactics. And the third one do not require urgent correction of the Gallen's veins. And for intrauterine correction, you should consider the patients from the first cohort. They can be operated while in utero, and the probability for mortality is quite high. We should use all the imaging techniques, including ultrasound and MRI, to predict the further development of the condition. We plan the next conference on this topic in the coming September to discuss the clinical implications in the outcomes. Despite these abnormalities are quite rare because of high mortality rate, we should pay attention to this problem. So what are the prospects for this problem? We want to improve the existing and as well as develop new methods of in utero correction of these abnormalities, also including medical correction of using cellular techniques, surgical correction of spina bifida, and we are developing our new platform to develop the surgical correction. And Kulakov Institute, we cooperate with, were one of the co-inventors of the Russian-made balloon to include trachea in diaphragmatic hernias. We also use the same approach to provide bypasses for ureters and other organs. And this is the plot of our new institute that will be built in the near future. It will be equipped with all modern instruments and equipment, and hopefully we will succeed with this project to continue developing fetal surgeries. Thank you very much for your nice talk. I visited your center some time ago, and I would like to extend my greetings to Dr. Bashmakova. Thank you for your efforts. and contributions. Please stay with us. Our next talk will be delivered by Dan Walski. It is his second presentation of today, and he is going to discuss the role of ultrasound imaging in fetal medicine. Please, the floor is yours, dear Professor Walski. He's the head of fetal medicine and ultrasound unit in the Department of Obstetrics and Gynecology in Hadassah University, Jerusalem. Good afternoon, dear colleagues. Again, I would like to thank you for your invitation, and my current topic is shown on the screen. It's about fetal medicine. We all know that ultrasound techniques have passed through evolution, starting from the simple ultrasonic scanners that were implemented back in 1960s to more sophisticated modalities with high resolution, including 3D reconstruction that enable us to diagnose not only anatomical abnormalities, but they also provide us better understanding of physiological processes that occur with the fetus. And they also laid a good background for improvement of diagnostics of various fetal abnormalities, as well as identify possible fetal interventions. Also, starting from the first fetal transfusion that took place back in 1960s to the first laser surgery and the first tracheal balloon that was put in 1991, and as the first speaker presented it quite nicely, we can appreciate the unlimited possibilities we are having now in a fetal surgery. So what's the sense of fetal surgery nowadays? We know that most fetal abnormalities, besides they are diagnosed on time or can be diagnosed on time in utero, can be well treated after delivery. But at the same time, there are certain abnormalities that have certain window of opportunities only during a pregnancy, and after delivery the consequences are irreversible. And this is a sense of fetal surgery. So these are the interventions that can dramatically improve the condition of the fetus as well as a prognosis using either medical or surgical techniques. And this is actually the background for fetal medicine. Ultrasound is the essential diagnostic tool. Not only it provides new insight for diagnosis, but it has a very important illustrative results. We see not only beautiful pictures, but we can also diagnose our fetuses, and the modern equipment and the scanners with high resolution provide diagnostic tools to reveal spina bifida and other congenital abnormalities, as well as we can track complete fetal physiology using ultrasound. Sometimes we're not even thinking about what possibilities we have to diagnose a fetal development syndrome. So we should try to prolong pregnancy to provide possibilities for the fetus to mature and prevent severe complications as well as central nervous system involvement. On the other hand, some fetuses may be in critical conditions that because of fetal insufficiency, placental insufficiency, may develop severe complications, and we should be more certain at what point we should get down to surgery to prevent complications and a subsequent retardation of development in utero or development of hypoxia or acidosis. The factors that we can monitor using ultrasound or Dopplerography are very well known and established. So we can be very certain with the term of pregnancy and decide on when to go for delivery to provide the best result. Not only the degree of placental insufficiency, but also the condition of the fetus, like cerebrovascular circulation and central nervous system development. So these areas are quite feasible for imaging. Another area is related to the unexpected fetal death syndrome or sudden death, and so which tachycardia may be benign in some cases, and we can, but on the other hand, the AV blocks may be spontaneously resolved, not requiring any active interventions. But in other cases, should fetal arrhythmias develop, the condition may become critical, and within a short time, we may end up with cardiac failure and a sudden fetal death. So ultrasound can be used to diagnose these arrhythmias, as well as we can better understand what medical or invasive interventions are required to correct those conditions. Some approaches are very well developed, and like in this example, in addition to the medical treatment, we can go for surgical treatment, and we can appreciate how ascites is disappearing, how arrhythmias are disappearing, and finally we end up with good results. Another example is related to fetal anemias. Fetal anemias are diagnosed now using ultrasound, and there is no need for invasive diagnostics, and currently the perfusion in the middle cerebral arteries can be evaluated using ultrasound, and it is 100% of cases we can use ultrasound, and we count on this method in our practice while diagnosing this condition. For 20 years, this method has been used, and the diagnosis of anemia is quite precise and accurate using ultrasound. Similar to the previous examples, I should say that ultrasound enables not only to reveal anemia, but also the severity of anemia and what impact it has on the fetus, what risk it poses, and the process of anesthesia, as well as blood transfusion that is required for certain cases, is also very well established and safe. And the success rate is higher than 95%. The complication rate, whereas, is less than 3% per transfusion. Also, ultrasound can be used for inserting shunts in a thoracic cavity, abdominal cavity, in urinary bladder, in a urinary obstruction, or in a thoracic disease, when, because of accumulation of fluid in the thoracic cavity, the pressure is elevated and the central veins are compressed, with possible rapid cardiac failure and sudden death. In most cases, we know that these hydrothoraxes are quite benign, and they may resolve spontaneously after delivery within a short period of time, or after having drained the patient. So we can go for a spontaneous delivery, provided shunting is feasible. And as anywhere else, we use pigtails. This is a special shunt that is inserted using special cannules, and it provides for good fluid outflow and also normal relief of the lungs is possible. Central veins are released, and if the shunt is put correctly, there are no more signs of edema, or the patient is resolved completely with very good outcomes, and the results are quite stable. Fetoscopy has become a basic method, basic procedure, and in many centers it is available. The spectrum and the indications are quite broad, and they are now become broader and broader. Twin pregnancies that require coagulation of anastomosis using bipolar umbilical occlusion, this was our past, and now these methods can be used to treat diaphragmatic hernias, including severe cases where this procedure has proven to be effective.
And naturally, when we treat different neuropathologies, well, of course, the ultrasound has a critical indication in terms of diagnosis and in terms of indications for administering these procedures, in terms of assessment, when and what access should be used to do the fetoscopic surgery. In speaking about twins, ultrasound is important not just to make a diagnosis, but also to assess the placenta, to assess the location of the fetus, to assess the possibility of anastomosis, to assess the place through which the pod goes, and to assess the successful outcome of our procedures. Naturally, the ultrasound allows us to assess the severity of the process, the severity of heart failure, and also to monitor the improvement of these indicators when we have a successful or a less successful procedure. Here you can see how during the fetoscopy, we study the equator of the membrane, dividing two fetuses, and you can see the assessment of anastomosis and the coagulation of anastomosis using a laser. Naturally, other fetoscopic procedures such as cord occlusion are performed at our center with the ultrasound control, much less with the fetoscopic control, especially when we're talking about the laser. That's also possible, but more often we use the ultrasound and we use a bipolar forceps to do the umbilical cord clamping. As for diaphragmatic hernia, and there was a wonderful presentation on the subject, it's hard to add something new to that, but naturally, we can say that the treatment of diaphragmatic hernia is based on the right diagnosis, the right exclusion of other pathologies, and the right assessment of the degree of the disease and the assessment of the degree of lung collapse, which in turn will give us the opportunity to see the probability of a success in a particular patient and whether there are any indications for this procedure before we started. As for diaphragmatic hernia treatment, well, endotracheal balloon placement is one of the procedures that can be used here. You can see how it goes all the way to the vocal cords. We go through the area of vocal cords. And we place the balloon with endotracheal occlusion. Right now, ultrasound is an integral part in diagnosis and assessment of the results while conducting different fetoscopic procedures, as well as different intrauterine interventions. Well, there are a lot of fetoscopic interventions, be it fetal blood transfusions or fetal shunt placement or intrauterine interventions like using fetoscopies. Thank you so much. Professor Damian, we give the floor back to you. Thank you very much. Well, you are like a champion today, talking about uterine malformations and fetal malformation. Then please do not go away. Right now, we're giving the floor to Professor Mark Kurtzer, then we'll have a discussion. Well, can Professor Kurtzer start his presentation, or we have several minutes? Yes, Leila, I am ready. Well, wait a minute, I must introduce you. Dear colleagues, it's hard to overestimate the importance of today's conference because, well, we've been dealing with fetal medicine for a long time, and for the first time, I remember when Dr. Quintero, Dr. Newton, Dr. DePresta came to Russia for the first time. At that time, we had nothing, but right now we are moving drastically forward, and we have the major centers built in Russia, the Kolokov Center of Obstetrics and Gynecology, also the center headed by Mark Kurzer, and our Euros colleagues are catching up with us. So as soon as Professor Kurzer's presentation is over, we'll have a discussion. While academician Mark Kurzer, the theme of the presentation is intrauterine surgery for spina bifida, outcomes in children. Mark Kurzer is a famous OBGYN. For many years, he was the chief obstetrician and gynecologist of Moscow. He set up several directions in this field. He is the chair of the Department of Obstetrics and Gynecology of the Pirogov Medical University. Professor Kurzer, Mark, the floor is yours. Esteemed Leila Vladimirovna, dear colleagues, thank you very much for this presentation. Well, and I am a student of academician Galina Savelyeва, and I've been working under her auspices basically all my life. As for spina bifida, well, I'm not going to go into detail what is meant by spina bifida. We have discussed that in other presentations, but I would like to share our experience in operating on such patients and what the difficulties we have encountered. Well, I should say that in the previous presentation, our colleague emphasized that for the first time, the diagnosis of spina bifida is a serious problem. The correction or the surgery for spina bifida for the first time was done in 1998 in the US. Well, in 2011, there was MOMS, management of myelomeningocele study. And of course, I should say that our main goal is to achieve good results. So you can see in the green square, in the green box, well, there should be specific indications for the surgery for spina bifida, especially when we bring to bear that this procedure is very complex and we should avoid any possible damage. And here you can see the postnatal surgery. Well, that's when the child was born. That's done in the first 24 to 48 hours. Here you can see indications for surgery for spina bifida. And again, as for moms, so we were not included there. As for open surgeries, there are more than 2,000 open surgeries for spina bifida. And right now, I should say that those indications that are shown here, we should take them into account when we do the surgery. Well, that's our own study. Well, we did the intrauterine correction of spina bifida. We have the interdisciplinary team, and we have neurosurgeons who operate on a patient with spina bifida. And each time I want to emphasize that that's difficult to do because I sometimes don't see the ureters, I don't see the great vessels, and sometimes, I want to do this procedure myself, but I don't have a certificate. Well, I should say that neurosurgeons do this procedure from beginning to end, but unfortunately, we should involve the interdisciplinary team. Maybe I'm wrong here, or maybe, well, it's fortunate that we need to involve the interdisciplinary team, but this procedure is very well structured. Everything is on the surface. This is the diagnosis of spina bifida. Well, here you can see the geographic breakdown. Well, you can see different areas of Russia, Moscow, the Moscow region on the right, and the number of cases of intrauterine correction of meningocele. And again, you can see also the number of cases on the left in other regions of Russia, such as Perm and others. Here you can see the average age of our patients. You can see the number of births that these women had. Well, the first births, well, 3 patients that we operated on. And here you can see the 13 cases of the spinal cerebral hernia. And let me just say a few words about what factors have an impact on the efficacy of our procedure, so that you could have a clear understanding that you should not include incurable cases. Well, we must understand that a decision must be made first, aimed at assessing all the risks, so the level of damage of the spinal brain, the size of the ventricles, and other factors. And it was not quite clear how many endoscopic procedures were made, but I think there was just one procedure. And well, you can see our procedure usually lasts for 2 hours and 10 minutes, including laparotomy, while suturing the cavity of the uterus. And the only thing is that we use painkillers, and we use the endobronchial anesthesia, and we use the lateral catheter. This helps us a lot, and especially in terms of managing women in the post-operative period. Well, here you can see the intrauterine correction of spina bifida. Laparotomy is being performed. Well, again, we control the markers. Well, here we choose the place. We just go away from the edge of the placenta. We use the electric knife, and you can see how we do the procedure. Well, you can see that there is the myometrial wall, the walls of the fetus. Well, you can see there is no oligohydramnios, and one of the key success factors. And by the way, I should say that as for the practical skills that we develop well in this process, we try to honestly share them with others. So we have the ability to fix the ROMs, and the deeper they are fixated. In this case, we will have less complications. And here we reduce the thickness of myometrium. We open the uterine cavity, and again, you can see the membranes. Well, here you can see the Ringa solution introduced. Well, everything is on the surface, everything is all right, then we use the optical devices and we do the incision of the hernia. Again, you can see the soft membrane, the hard membrane, and I should say that we had one case when a woman was pregnant. We managed to prolong her pregnancy. In 19 cases, we had the deliveries. Out of 19 patients, we had just one patient when we were unable to put a patch here because of the serious defect. And we had problem here. Usually we put a patch, we suture it here on the entire surface, except for one case. Why am I showing you this? First of all, I want to emphasize the fact that out of 19 patients who gave birth, only one needed postnatal procedure. So you see, we restored the integrity of the uterine cavity using the sutures, and the abdomen was sewed up. Then the next stage, the child was born. It's a boy, and you can see what is the condition of the patch. Usually like 2 weeks passed since it had been placed. Well, you can see the condition of the patch. And I always say that as for intrauterine infection, there is an epidemic of such infections. Any obstetric complication leads to such complications. And well, you can see there might be different malformations, congenital malformations. And well, here you can see no signs of inflammation. Well, and you can see also that we reject immediate procedure and to restore the defect. And here you can see that 1 month later, this boy is called Leo. He is in the ICU. He can move his arms and legs, and you can see the patch, what it looks like after a month of postnatal life. And I would like to show you some other video. Well, you can see now neurosurgeons are involved. They have a license for that. They do the dissection, and then we separate this patch. You can see it is done very easily, and we restore the structure. Well, now we need to make a comparison. These are the mom's results. This study has been stopped, and there was also a comparison with postnatal and prenatal correction. 26% is the dissection of membranes. I also saw the patient who was operated on, and she had a spina bifida. Well, we could see the dissection of membranes, and when we had some specific problems in the post-operative period, and we can see that this complication does exist. And also, for example, Alexander Zverev showed that there are more cases when we have more cases of oligohydramnios, and again, we see what particular pouch should be left intact. Also, premature abruption of placenta, one case, as you can see it here. And this slide shows our results. And just summing up what I have said, well, you can see 20 intrauterine surgeries, 19 live births, and you can see that you can see preterm babies, preterm babies 17, term babies 2, and you can see the average weight, well, 1920 grams. When we had preterm babies, term babies, the average weight was 3,220 grams. Well, how did we do a cesarean section? That's also an important aspect when we have a discussion, Professor Adambian. Well, the discussion boils down to what is better, fetoscopic surgery or open surgery. And it seems to me that, of course, the fetoscopic surgery is better, but right now, open surgery can also have advantages in terms of its reliability. In Brazilian films, videos, I saw how they introduce the inert gas, and there might be problems related to gas embolism, but right now I should say that when you do a fetoscopy and then a cesarean section, there will be an incision on the uterus. And well, in 10 patients, it was in the external uterine segment. In this case, we can see that one woman had a cesarean section of the fundus, and also there was an incision along the scar after the surgery for spina bifida. The scar assessment, well, we can compare that with the mom's results. Well, as for the scar, well, that's an individual parameter, and you can see that, well, a good scar occurs in 64% of cases, thin scar 25%, well, and you can see also partial rupture is 9%, and the complete rupture in 1% of cases. And our colleagues also said that they had 9 ruptures altogether. Well, but well, you can see as for the complete rupture, it was just in 1 case. And of course, we made the comparison of the condition of newly born children. Here we had specific complications such as pneumothorax, and we basically can say that as far as respiratory distress, acute respiratory distress syndrome is concerned, well, we had basically 21% of cases, well, sepsis in 5% of cases, well, necrotic enterocolitis 1%, and we have a lot of orthopedic anomalies. So our patient, well, unfortunately is not free from such conditions, and we have to involve orthopedicians. What is happening with extremities? What is happening with urine oozing? And here we provided a systemic view. Well, most patients had good results obtained. Only 3 patients, we do not see any movement in extremities. Also, muscle tone decline in lower extremities. Well, of course, we tell parents that surgery for spina bifida do not give 100% optimal result. It reduces the symptoms, it gives a better results, but unfortunately not 100%. And here you can see that hopefully hydrocephaly level was lower than in other groups. Only 4 children needed drainages, and whether shunting or bypass was needed or not. In other presentations, I didn't quite get it, but you can see that we did not use shunting, and when we use the ultrasound or MRI, well, you can see that we didn't have a lot of cases of hydrocephaly. All too often, well, you can see that the anal condition, well, urine oozing, well, in 6% of cases, we didn't have problems like that. And here you can see what is happening right now. As of today, we cannot maintain contacts with 2 moms. I hope we'll solve this problem. Here you can see our results at the age of 6 and 12 months. And you can see that the neurologic outcomes in children who had the surgery for spina bifida, well, and you can see the number of intrauterine operations. 19 children were born. Well, of them older than 1 year is 16. Well, children who keep walking, as you can see, not in all cases we achieved the best effects, and 50% of cases still have urine incontinence, and in 16% of cases there is the slowdown of the mental development. When again you can see cases when bypass was done, and as well as additional procedures for spina bifida in case of 1 patient. Once again, I should say that we always make presentations at large-scale conferences concerning rehabilitation methods. That's our first boy, Sasha. He is in the swimming pool right now. He is swimming, and we teach parents how to use the void methods. Well, you can see we've been dealing with this problem for several years. This is the girl Dasha, and we'll show you a short video how the child developed. Well, you can see her spina bifida in the left hand corner. Here are the results of the procedure. Well, and now her mom will be talking. Unfortunately, there is no sound coming from the video. The woman had spina bifida at the 24th week of pregnancy. That's Dasha, the girl. She is 3 years and 6 months. Mark, we have no video, we have no sound. All right, the video is wonderful, but it's a pity we have no sound. There is sound, but it's very weak. Okay, I will just repeat. This is Dasha's mom. Yeah, I can see it. Well, and she said that the girl was developing very well. She is moving.
And we can appreciate her moving and jumping and walking. So we will take into account all your remarks. So it is quite justified. And here we see the way she moves. Well, let me rewind the video. Sorry for this technical problem. Well, actually, the girl was dancing, and so there should be a music, and so she likes dancing very much. Now she goes down the stairs. She's running, jumping, and actually she's dancing. So this is not her gait which is impaired, but she's actually dancing with music. So when I was attending a World Congress of Antenatal Medicine, I can recall that the Zanger reward was handed over. It was Florencia, if I'm not mistaken. And usually prominent scientists deliver their lectures, and it was Professor Radzik who demonstrated a similar case with some differences. And later, he demonstrated how the girl was scooping, and we appreciate every life, and we obstetricians were blamed for pushing our patients for interrupting pregnancies, but it is vice versa. So we give life to our patients, and spina bifida is no longer an indication for interrupted pregnancy. So the fetuses should be operated on, and the surgery is available in many centers in Russia. And thank you very much. I was listening to your presentation, and you are absolutely right, saying that every life matters. And many years ago, one of my assistants moved to the United States, and we were discussing a series of conferences on fetal medicine. It was Dr. Newton and Professor Deprest, and this was the very beginning of the series. So let us get to discussion. Who is there online? Professor Deprest, are you with us? Professor Deprest, are you with us? Will you please get him connected? Jan, can you hear us? Please have your camera on. So we would like to discuss some things with you. Dear Professor Deprest, please get your camera on. This is Dan Valsky. And where is Professor Deprest? Okay, let us get down to discussion. So let me ask you some questions that occurred to me during the presentation. Who can become a fetal surgeon? Dear Mark, what's your take on this question? You said you would operate on this patient, but you do not have a certificate. I want you to get this certificate. Well, we should understand that when you present, I want to get some intrigue, and when we operate on our patients, we get them myo relaxation and some anesthesia, and it should be the surgeons who operate on the patients every day, those who are quite certain what to do with the spinal roots. And I appreciated the approach of our colleagues from Yekaterinburg who promote multidisciplinary approach for these patients. And I also appreciate the conclusion that was made by a Professor Deprest, who is a big friend of ours, and it should be an obstetrician, as he was saying. It is the doctor who makes a decision, who prolongs the pregnancy, and it should be obstetrician. So this is my take. And if required, neurosurgeons, endoscopists who are good at operating on such cases. Anybody would like to object? Does everyone agree that this should be a multidisciplinary approach? So of course, we are quite good at doing cesarean section, and I enjoyed your video. And how did you call it? Not a sticker, but yes, a patch. What is it made of? So this is a biosynthetic material. So this is a certified material, kind of a patch or a sticker, and we decided to use it. It was a very small patch, and it was used only once. And we sutured the patient all around. And the quality was quite good. And the results were quite good as well. And we were scared about inflammation, some complications, septic conditions, because of high humidity of the material. Will you please show me all the participants? It was a very nice, it was said that we should not take incurable conditions. What do you think incurable? Well, it depends on the condition. If it is a spina bifida, rachischisis is an incurable condition. It implies interrupted pregnancy, or spina bifida occulta, with very low defects that cannot be operated on because of lacking indications. So there are very clear indications on when to operate. So please give me your quick answers only. Dr. Kostyukov, what do you consider as incurable cases? Not only spina bifida, but other conditions as well. Fetal surgery is aimed at helping the fetus to overcome some life-threatening conditions, and taking into account those prerequisites, we should try to provide care for any fetus or any child who is in a life-threatening condition. Our female patients are easily referred to pregnancy interruptions But my point is that what is curable and what is incurable, we should be very cautious about it, and we should make our decisions on individual basis, whether we have technological possibilities, whether there is a real life-threatening condition. So your recommendation is to organize the prenatal concilium. Is that right? Yes, yes, but it is not always feasible, unfortunately. So who should participate in this multidisciplinary concilium? So it is an operating surgeon, and it is my responsibility. We've seen severe kyphosis or racheschisis, are also very severe cases. We do operate on racheschisis, but severe kyphosis should not be, in severe scoliosis, we do not operate. And there was a case of that spina bifida may be very severe, and thoracic complications also prevent us from operating. And the level of the lesion, the level of paralysis. Well, I take the maximum responsibility, but I also consult my colleagues. Well, and I never say that we operate on 100% of patients, but we only deny surgery when we do not expect any good outcome. And there are also conditions that may result in severe patient disability afterwards. So I understand your level of understanding and your level of responsibility. And in this case, the responsibility should be shared with pediatricians, with general surgeons, with neurosurgeons. Yes, I agree. But well, let's say I am an operating surgeon, and it is hard to believe that someone should persuade me from operating for operating on a patient. You see, shared responsibility results in no responsibility at all. And I think the leading one, so the leader, it should be the surgeon who is the lead. And when we do MRI, we want to develop a model, but not only for the modeling process per se. We do see what is there inside, and despite it was not discussed, but we demonstrate the pictures to the parents, and well, so you actually foresee have foreseen my next question, because well, I wanted to say that the parents should also participate in the decision-making process. I would like to ask Dr. Valsky what he thinks. What does he think about the indications for surgery from the ultrasound specialist? So you have been dealing with fetal diseases for your life. And what's your take on the tactics? There are current approaches to navigation, modeling, not only taking responsibility. And if you do not have such experienced doctors, in our center, we do consult, we provide counseling for every patient for congenital conditions every week. So, but what's your take on that? So when we plan a surgery, a fetal surgery, we should understand the level of the defect, the size of the defect, and whether this defect is a single one or is it a combination defect like kyphosis or scoliosis. And if there is a herniation of the cerebellum, and if at the time of diagnosis the cerebellum is herniated, also these factors identify your prognosis and possible success of your surgery. And here, not only ultrasound, but also MRI plays an important role. And currently, MRI is always used for this kind of surgeries. And later on, when we are following the degree of herniation in the cerebellum and the other factors that can help identify the prognosis, the success rate or failure of your surgery. We have still some 5 minutes for our discussion. I would like to raise the following question. Why there is scar failure or suture failure? So actually this is a standard surgery. I would like to ask our international colleagues. So this suture failure, why is it so? So I said that there was no case of uterine rupture. So in this series of 200 cases, there was no case of uterine rupture. So this is something that should not be there. And actually, we observed out of 19 patients, the suture, the scar was quite consistent, and it was 100%. There were also other factors, and like any scar or suture, because the uterus is still growing, and provision sutures are made that enable further fetal growth. And when there is no tension, the uterus starts contracting, and when we suture, so the volume is reduced. I was following your technique very attentively, and what I should say that the next time you're going to demonstrate your surgery, I should ask you to tell us some tips and tricks of your technique. Well, I think you have some tips and tricks. We are surgeons, and everyone has their own tips and tricks, and well, I agree. Well, the next lecture will also cover this topic. So not only for fetal aspects of, so what we should do, obstetricians, how we should suture the spina bifida and other cases. And my last question to you, what we should do to prevent our patients from becoming spinal patients, disabled individuals. What are the prediction factors? Of course, we should not be satisfied with the results. Can we tell right away if a patient would develop any spinal problems afterwards? So I demonstrated it in my presentation quite clearly, I believe. Probably I was not understood very well. So we want to put it in a systematic manner, but in medicine it is not always feasible, like ABC or something like that. Out of 15 delivered babies, there were different problems in 4. Some have problems while walking, and some had some neurological deficit in their feet. Some had other problems related to the spinal roots. But we can never say that it is 100% 100% warrant not only patients from the Moscow regions that had been operated previously in utero, but still we see some changes in their life. So, and it can be seen when you examine your patients afterwards. And we provide all the information to the couples, and they decide whether to operate or not to operate. And actually, we provide objective information. This is our goal. Well, I should say that it all depends on your technique as well as on the specific things of your case. Our patients go to the swimming pool and they get some aid and care free of charge. And we are licensed to operate on spina bifida, and we do it at our own expense. And these patients complete the program of rehabilitation after surgery. Of course, they require extensive correction. And my very last question to all of you. I think almost all of us have certain experience, including negative experience. What surgeries would you like to stop doing? And what's your dream to do in utero? Let us start from our young doctors. So I cannot refuse any type of surgery, and those very well established interventions that had been already implemented into practice have provided also evidence, and we cannot refuse operating on such patients. There is a big area for improvement using the stem cells and developing methods of treatment of monogenic diseases. So there are also abnormalities of urogenital system that were started with Michael Harrison back in 90s, but there is no evidence whether these patients should be operated in utero or should the pregnancy be rather interrupted. If not, what to do, whether we should shunt our patient, whether we should do retrograde cystoscopy, and whether we should use lasers. There are very many questions still opened, and my dream would be to start operating on cardiac abnormalities in utero. Dr. Kosovtseva, what would you say? What fetal surgeries should be stopped, and where we should be striving for? Well, I wouldn't refuse any type of surgery: cardiac surgery, renal surgery, diaphragmatic hernia, neurosurgical interventions that are actively developed right away. But the aneurysms of Gallen's veins, so another very interesting area. And I should say that I want to implement cellular technologies into practice, because not always we succeed. It is the new area for us, cellular technologies that are aimed at covering a tissue defect that is there. I will be very brief. I would like to stop transfusing our fetuses in utero. Why? Because it causes some rhesus conflict, post-transfusional syndrome. And so these surgeries should be stopped. It's very strange. It was you who started, who were pioneering these kind of interventions. Yes, yes, indeed. But now we are no longer in favor of such interventions. Of course, they are done sometimes, but we would like to stop them because it is iatrogenic conditions that result from this kind of intervention. That's why I would like to stop doing them. There are other surgeries that I would like to stop, like stenosis and the operation of the left ventricles. We have set up a working group in cooperation with vascular surgeons, but we cannot find a good candidate for a surgeon for this surgery. And this is our dream. Well, I think we have had a very interesting discussion. And if you have something to add, well, you can do so. There are thousands of people listening to us right away. Okay, thank you very much. See you soon and good luck. Dear colleagues, it is a 5-minute break. And a new plenary session will be opened in some 5 minutes on new technologies in reproductive medicine.
Well, let's get started. We're ready. Distinguished colleagues, good afternoon, good evening. We're starting a very important plenary session, New Technologies in the Diagnosis and Treatment in Reproductive Medicine. We have Professor Kazuhiro Kawamura, Japan, Professor Yoshiaki Ota, Japan, Professor Hans Rudolf Tienberg, Germany, Professor Stefan Gortz, Belgium, Professor Antoine Waterloo, France, Professor Viticello, Italy, Professor Antonio Setúbal, Portugal, Professor, not a professor yet, but will be a professor soon, maybe an academician, Victoria Allegrova, who is our postgraduate at the Kulakov Center. She will present interesting material concerning issues related to ovaries. Also, Professor Marina Shachova, the Kulakov Center, Professor Dubrovina, Rostov-on-Don, Professor Korneyeva from the Obstetrics Center in Moscow, Professor Uranieva, Moscow, and Professor Dumanovskaya, Moscow. We're starting this plenary session. I'm glad to see all of you, and in particular, the first two gentlemen from Japan. We've been communicating for a long time. They are wonderful Japanese scientists and researchers. Professor Kazuhiro Kawamura will be speaking first. The development of the new approach in IVA, in vitro activation treatment for ovarian dysfunction patients. Professor Kazuhiro, the floor is yours.
Okay, can you hear me? Yep.
Yes, we can hear you. Go ahead, please.
Okay, thank you very much. Today, actually, I really appreciate Professor Adamian to give me this, very unique opportunity. And the title of my talk is the development of new approach in IVA treatment for ovarian dysfunction patient. Actually, I have worked on to develop this new treatment, IVA. But recently, we found very, unique materials to activate dormant follicles within 30 minutes. So then I like to, share our data to develop the new the treatment. Okay, and here's my COI. So I just want to follow the almost similar slides I presented before. And actually, the premature ovarian insufficiency, this patient diagnosed by amenorrhea before 40 years of age, and hypogonotropic hypogonadism. And these patients show the infertility and symptoms caused by estrogen deficiency, such as hot flashes, mood disturbances, sexual dysfunction, etc. So the specific feature of the POI, like follicle growth and aberration, and also the exhaustion of the ovarian follicles. And they should have less than 1,000 follicles. And that's why if we try to measure the MH levels, almost all the patients showed undetectable levels. Because of these specific features, the patients are really resistant to traditional gonadotropin treatments, and thus egg donation is the most successful treatment option. But, the couple would like to conceive their own genetic babies. And then we have that, is it possible to activate residual dormant follicles in POI patients to develop new treatment? Based on knockout mouse studies, Reddy and Castridon reported similar phenotype in P10 knockout and FOX3 knockout mice. And as you can see, at day 5 after birth, left panels are P10 wild type and right panels are P10 knockout. there is no difference in the ovarian morphology at day 5 after birth, but at day 35, as you can see, the ovary became bigger and you can see multiple growing follicles inside. They are actually spontaneously activated primordial follicles. So that's why 6 weeks after birth, the ovary in a P10 knockout became shrunken and looked like a pure ovary. And completely similar phenotype could be obtained in P10 FOX3 knockout mice. So this similar phenotype could be explained by this PI3K signaling pathway. This pathway begins a PI3K activation by receptor tyrosine kinases after binding growth factors. And PI3K activates AKT, which inhibits the activity of FOX3, resulting in cell proliferation and survival. And P10, this molecule negatively regulates the PI3K signaling pathway. So in primordial follicles, local factors activate dormant follicles through this pathway, where the P10 acts to block the signaling pathway. So then we have that it is possible to activate residual dormant follicles in PI patient artificially by transient P10 suppression and or PI3K activation using some kind of drugs. Other than we use a P10 inhibitor, a very long name known as a highly potent and a specific inhibitor at nanomolar concentrations. And we also use a PI3K activator. This one is a cell-permeable phosphopeptide, which binds to the SH2 domain of the P85 regulatory subunit of PI3K and activates its enzymatic activity. So using these two reagents, we have assessed our hypothesis. Actually, we use a day 3 mouse ovaries that consists from only primordial follicles. And these ovaries are treated with P10 inhibitor and PI3K activator or without treatment and culture for 2 days. And then after that, the ovaries were transplanted into a Curing capsule of adult ovarectomized mice. Ovarectomization was performed to increase an endogenous FS level to further support the follicle growth after activation. And finally, we treated animals with HCG to try to obtain a mature oocyte. And then we performed IVF-ET to try to get healthy pups. So this slide shows a change in ovarian side at day 14 after transplantation of day 3 ovaries. As you can see, if the ovary treated with P10 inhibitor, they became bigger, and also the ovaries treated with a PI3K activator also became bigger. If we try to use both P10 inhibitor and PI3K activator, they show the synergistic effect. Ovary becomes much bigger. And then we check the follicular dynamics at 40 days after transplantation of activating ovaries. So the gray column indicates control, the black column indicates drug treatment. So as you can see, as actually expected, the proportion of primordial follicles are decreased, and then the proportions of primary preantrum, antrum, large antrum follicle all increase in the case of the drug treatment. And then we check the normality of the eggs oocyte obtained from the drug-treated ovaries. We confirmed the normal morphological spindle formation evaluated by beta-tubulin staining. And also, we checked the integrity of genomic imprinting using the differentially detected methylation of the CPG site in DMR region of some imprinting genes. We checked the maternal one is the IGF2R and the RIT1, and also the paternal H19 gene. And then we performed IVF-ET, and actually the eggs obtained from the drug-treated ovary could fertilize and develop to the breast-stage embryos. And after embryo transfer, we could get healthy pups. As you can see, the fertilization rate was a little bit lower in the case of the eggs obtained from the drug-treated ovaries, because actually we need to dissect the follicles from the eggs from the activated ovaries transplanted beneath the Curing capsule. So that's why during dissection, some chemo cells were detached, and then it caused a decline of fertilization. So, but after the fertilization, almost all the embryos could develop normally. And then we moved on the translational studies using human ovarian cortices. And we, at that time, we just treated ovarian cortices with an PTEN inhibitor alone, but later on, we confirmed both PTEN inhibitor and the PS3 activator treatment was more effective. And again, after 2 days culture, we then transplanted ovarian cortex fragment into the capsule of overreactive skin mice. And then again, that we treated animals with an FSH to further support follicle growth after activation for 6 months, because it takes around 6 months from the primordial to pre-ovulatory stage in a human. So that's why we treated animals with FSH for 6 months. And finally, we gave an HCG to try to obtain mature oocytes. And this slide showed the morphology of the human ovarian fragments after 6 months of then transplantation. So as you can see, the red circle indicates transplanted human ovarian fragments. When in a control group, you can see the small transplanted ovarian fragment, but in a PTEN inhibitor treated group, you could see large multiple antral follicles growing onto the kidney. And then we check the histology, and then after, actually at 36 hours after the treatment, the upper picture showing the almost ovulating oocyte with first polar body extrusion, that means the M2 stage mature oocyte, and lower picture showing the oocyte still attaching the follicular wall, but showing a cumulative expansion in response to the HCG stimulation. That is a normal response to the HCG. It's ready for the ovulation. And then after success of these animal studies, and also we confirmed the safety using animal studies, including monkey model. Then we moved on to human clinical trial. So this is our, the scheme for the original IVA approach. And the first step is the ovariectomy under laparoscopic surgery. And then ovarian tissue are cultured with an PI3K activator, that means PTEN inhibitor and 740YP, and treating for 2 days. And then after 2 days, we were going to the additional second surgery to transfer the treated cultured ovarian tissue. And then we can do the regular IVF-ET treatment. And this slide shows the first I dissected ovarian cortices containing the residual follicles by removing medulla and cut into the small stripes around 1 centimeter square with 1 to 2 meters 6, where residual follicle located. And then we can do the cryopreservation by, now we are using the vitrification method as an option. And usually from one pure ovary, we could get 6 to 8 pieces of ovarian stripes. And then we performed histological analysis to try to detect the residual follicle using a 10% volume of each ovarian stripes. And then we, after confirmation of the presence of residual follicle, we further fragmented the 2 to 3 ovarian pieces into 1 to 2 meters squared over very tiny ovarian cubes here. And then treated with an PTEN inhibitor and a PS3 activator for 2 days to activate dormant follicles. And then here's a picture for autotransplantation and laparoscopic surgery. We first cut a serosal making a pouch between serosal and fallopian tube, and grafted multiple ovarian cubes beneath the serosal with fallopian tubes. And the wound was covered by the interseed to avoid a cube loss from the graft side. And also we transferred the ovarian cubes into the remaining ovaries. And at that time, after obtaining IRB approval, we enrolled 83 of the PI patients, and their duration of amenorrhea was around 6 years. And then among 83 patients, we could get 28 out of 46 patients contain residual follicles based on a historical analysis. And then after an IVF, embryos were preserved at day 2. And at that time, we have performed soil element transfer in 8 patients, and others were accumulating the cryopreserved embryos. And 3 out of 8 patients became pregnant after embryo transfer. And unfortunately, one was a miscarriage, but we could get 2 successful deliveries. This is the first baby in the world after IVA. Now he became 9 years old, totally healthy. And second baby also developed totally healthy. And as I already explained, it takes around 4 to 6 months from the primordial to prepuberty stage. So that's why first we expect to have a follicle growth at 4 to 6 months after the grafting, the surgery. But as you can see, not all the patients, but some patients show the follicular growth even earlier than 4 to 6 months after grafting. So the results suggest IVF method also stimulated growth of secondary follicles in grafting ovaries. So then the question is, how could activated dormant primordial follicle grow into prepuberty follicles in just a few weeks? We are reaching that growth on the potential of adolescent secondary preanterior follicles after ovarian fragmentation in PI patients. What is the mechanism behind? So we have done all the molecular studies. And then the first step that we have done, we try to cut the ovary into the 3 at days 10 months ovaries that contains both primordial and secondary follicles. And then the grafting again into the current capsule adult ovary ectomized mice. And after 5 days, we removed the ovaries and weighted the ovarian weight. And as you can see, the ovaries cut into 3 pieces became heavier than the whole ovary. And then we checked the follicular dynamics again by histology and found the ovary cut into 3 pieces, the proportion of primordial follicles declined, and also the proportion of late secondary and anteron prepuberty follicles are increased. So now it is clear that just cutting can stimulate the secondary follicles, but the issue of what is the molecular mechanism underlying follicle growth after fragmentation. So due to a shortage of time presentation, I'm not going to the detail, but here I summarize the molecular mechanisms. Actually, ovarian fragmentation led to the change in intercellular tension and facilitated the conversion of G action to F action. And subsequent disruption of hepcidin decrease in phospho-YAP to total YAP ratios, leading to increased expression of downstream CCN growth factors. And these CCN growth factors can stimulate the secondary follicle growth. So now there are 2 steps in follicle growth stimulation in an IVA approach. One is a PI stimulation to stimulate to activate dormant primordial follicle to be primary stage. And second one is hepcidin disruption to stimulate the secondary follicle growth. So then we try to develop a new treatment approach targeting the immature secondary follicles. Actually, in the cases of the diminishing ovarian reserve and early PI patient, we have that is it possible to stimulate resident secondary follicles to increase the number of the anteron follicles by disruption of hepcidin only, so without culture. So actually, original IVA approach, actually it required 2 times of surgery, but in the new drug-free IVA, we just remove not the whole ovary, just part of the ovary, and they should have a much higher ratio of follicle as compared to the severe PI cases. Then cutting the tiny pieces, and then grafting back to the patient within 1 surgery. So then we could get the clinical data, and we could have the successful pregnancy was achieved in a 4 out of 11 DOR PI patient after drug-free IVA. And also we recently published another paper with 4 additional patients. The success rate is around 40% in the case of the DOR PI patient. I hope this the percentage is very high. And then actually a drug-free IVA is only applicable to the DOR PI patient who likely to have secondary follicles. This is one big issue. So then we again hypothesize, is it possible to activate restricted dormant follicle with short duration of in vitro culture in severe POI cases to develop another new treatment? So we added the kind of the cocktail of the PI3K stimulators, including an EGF, in the media for preparation of the fragmenting ovarian tissue like this. And then just treating ovarian fragments with the PI3K stimulator, the cocktail, 30 minutes. Actually, here I'd like to show the data of the changing ovarian size at day 14 after the transplantation of the day 3 ovaries treated with a cocktail of the PI3K activators, just 30-minute treatment. So as you can see, even with just 30 minutes culture, the ovary became bigger in a dose-dependent manner, and also in the follicular dynamics by histology, we could find the decrease in proportion of dormant primordial follicles by, sorry, this is at 0.6 microgram per ml. And by PI3K activated cocktail. And also this cocktail stimulate the growth of the secondary follicle. We could get much higher percentage of the late secondary follicle and antral follicles. Then now we are planning doing the clinical study. So then we can cover the even severe PI cases. We can perform only one surgery without necessary to do the 2 times of surgery, then can minimize the invasiveness of this IVA approach. So here's all our collaborators. I especially thank the Professor Aaron Schwein at Stanford University for a long time of the establishment of this IVA treatment. Thank you for your kind attention.
Professor Kawamura, thank you very much. It was a revolution. Your previous revolution brought us to Japan. I and my student came to Japan and looked at the results of your work, and now you'll have a chance to listen to the results of this work. It's a pity that this pandemic has interrupted the process of our communication, but I am very grateful to you for sharing your knowledge, your data with us. You can stay with us, and are you going to participate in this discussion until the breakout session is over, or you are busy and you have to go? What's your answer?
So because now Japan is nighttime and I need to do another work, so I'm so sorry to not being able to participate in the discussion session. But I really continue to collaborate with you for a long time to further expand this IVA treatment in Russia also.
Thank you very much. Good luck. Good luck. And we will call you soon. Thank you. Good luck.
Thank you very much.
Our next presenter is Ota Yon Kurashiki.
And his topic is we know very well Professor Ota Yu and his results and the results of the Japanese school. We admire your results very much. Thank you. Please go ahead, dear Professor Ota.
Okay. Thank you for Leila for giving me the opportunity to the lecture at wonderful web conference during the Corona crisis. My lecture title is 3 Innovations to Improve Fertility After Laparoscopic Adenomyomectomy. So Let's get started. As for the classification of adenomyosis on MRI image, Kishi in Japan classified adenomyosis originating from the inside of the uterus as type 1, and regions originating from the outside of the uterus as type 2. Chaperon defined type 2 as focal adenomyosis of the outer myometrium. Faum reported that there is significant correlation with the presence of DIE in endometriosis. Here's another report from the same chaperone group. They reported that the group with preoperative Faum on MRI had significantly more DIE. Similarly, revised ASRM score were also higher in the Faum group. Faum was significantly associated with greater deep infiltrating endometriosis severity. Furthermore, a pathogenic link between deep infiltrating endometriosis and Faum cannot be excluded. Kahn performed immunostaining for type 2 adenomyosis and DIE. The staining pattern was similar between type 2 and DIE. Therefore, they report that the two were histologically similar. Human uterus is embryologically composed of archimetra and neometra. Hyperperistalsis can trigger the development of type 1 adenomyosis. Type 2 adenomyosis may result from pelvic endometriosis and focal adenomyosis of the outer myometrium, Faum. Therefore, adenomyomectomy to type 1 and type 2 should be considered separately. He is Professor Osada. Osada reviewed the literature since 1919 and reported that adenomyomectomy was the most performed surgery in Japan, with 2,123 cases performed. Among them, he reported 23 cases of uterine rupture. The red box was my patient. This case was silent rupture at 34 weeks gestation. A hysterectomy was performed and the bleeding was about 5,000 millimeters. Unfortunately, both mother and child were safe. Osada said, electrically powered instruments are associated with most cases of uterine rupture, and the causal relationship is suspected. So far from this review, I decided to stop using energy device and selected scalpel and scissor forceps. Due to the effect diluted vasopressin and insufflation pressure, there was no bleeding from incision. Not only was there no thermal damage to myometrium, but the absence of smoke made the surgical field very clear. Real-time tissue elastography was developed in Japan. Relatively stiff tissue structures are displayed in blue. and relatively soft tissue structures are shown in red. Here, we employed elastography and ultrasonic probe for laparoscopic surgery, and adenomyosis remaining after the procedure was identified and removed. This is the probe for using elastography. The size is 13 millimeter, and the price is about $4,500. We make an incision on the posterior vaginal fornix and insert in the intraoperative probe into the abdominal cavity. This is a report my laparoscopic myomectomy using the barbed sutures published in this April. The use of barbed sutures in laparoscopic myomectomy significantly reduced the operative time and the amount of the blood loss. Repair of the myometrium is also an important factor in adenomyomectomy in terms of strength, time, and blood loss. Therefore, as the third innovation, we introduced the barbed sutures into the suturing of the uterine wall. The first case of laparoscopic hysterectomy, laparoscopic adenomyomectomy using the elastography was reported at this conference last year, and it was published in last August. To date, we have performed laparoscopic adenomyomectomy with elastography in 8 patients. This includes 6 cases of type 1 and 2 cases of type 2. The average operating time was 180 minutes, and average blood loss was 159 grams. The average weight of removed adenomyosis about 50 grams. The preoperative thickness of myometrium decreased from 40 millimeters to 22 millimeters with a reduction rate of 47%. Last week, we performed another surgery for type 1 and removed 68 grams of adenomyosis. The first case underwent assisted reproduction, and the second case is trying for pregnancy. The other case is waiting for permission to be pregnant and is on Dynachest. Case 6 was a patient with a chief complaint of hypermenorrhea. Preoperative MRI image showed a thickened anterior uterine wall of 35 millimeters. And transvaginal ultrasound elastography also showed adenomyosis region were harder than the surrounding area and thus was shown in blue. Case 6, a diluted birthplace was injected, and the scalpel was inserted through the central trocar wounds. Under insufflation pressure, the white ischemic uterus was cut with a scalpel but did not bleed. The region of adenomyosis was removed while preserving the serosa. The incision made by scalpel had an angular limitation. Therefore, we changed to incision with scissor forceps. type 1 adenomyosis lesion are up to the uterine cavity, so the uterine cavity is always open. All visual regions were removed. Hard adenomyosis tissue was shown in blue on elastography. The residual region was removed. The uterine cavity is shown in red. The blue display disappeared. The region was removed through the posterior vaginal canal. Barbed sutures were used to repair the uterine wall. The continuous suture did not loosen and could be repaired quickly. In the 3rd month after the surgery, the thickness of the myometrium was reduced 35 millimeter to 14.5 millimeter, and the pain was improved. Transvaginal Doppler ultrasound showed good blood flow, and pregnancy was allowed. Case 5 was also operated on for type 1. This is an MRI image of the 2nd month of after surgery. This is no hematoma formation, and thickness of the anterior wall is about 50% reduction rate. As for the good blood flow, the Doppler ultrasound for the 1st month after surgery showed the blood flow was recovered. Case 4 also showed a 52% reduction rate and good recovery of the blood flow 3 months after the surgery. Case 2 was a severe case, type 1 adenomyosis with a thickness of 3 centimeters 3 years before surgery. Right side image, and the thickness of increased to 5 centimeters. There was anemia due to hypermenorrhea. Adenomyomectomy was performed after explaining the risk of uterine rupture. One month after the surgery, hematoma was seen in the muscle layer, but it disappeared 3 months after the surgery. Four months after the surgery, a contrast-enhanced MRI showed good blood flow in the myometrium, so the patient was allowed to become pregnant. At 10 months post-operatively, the patient had a good endometrium, but not yet achieved pregnancy. We are still back to the Osada's review here. It states that there is no reliable correlation between contraception duration and the incidence of uterine rupture. It is noted that what is important is a reopening of blood flow. And I have allowed pregnancies after confirming good blood flow with contrast-enhanced MRI. The removal of type 2 adenomyosis requires the simultaneous removal of firm and deep endometriosis. In case 8, the deep endometriosis caused narrowing the ureter, resulting in hypernephrosis. This time, the ureter was able to be completely detached from the DE, and the stent was inserted after consultation with a urologist. The left hydroureter was seen. The left rectal cavity was opened. The right endometrioma was removed. The right ureter was identified and the lateral rectal cavity was opened. The both side rectal lateral cavity was opened, and then the central adherent area was cut. Douglas patch was opened. The left ureter was entrapped in the DE. The ureter and DE were detached under the guidance of urologist. The left ureter was completely freed from DE. The DE involving the left ureter was removed. The right DE and the foam on the uterine surface were also removed. Diluted vasopressin was injected. The posterior wall of the uterus was incised with a scalpel without the use of energy device. Therefore, there was no heat damage and no smoke generations. So the surgical field remained clear. Type 2 adenomyosis, which was present deep within the foam, can be seen. Due to the effect of the inflation pressure and diluted vasopressin, bleeding was minimal, even with a scalpel and scissors. The uterine cavity was opened and repaired fast. The posterior vaginal fornix was opened. The adenomyosis was removed, and the probe were brought in. The regional region were confirmed the elastography. There was no region shown in blue. The uterine was repaired using a barbed suture. Hopefully, this approach will reduce the number of uterine ruptures.
How much time do you need to finish your lecture?
Yes, okay.
How much time do you need?
1 minute. Last slide. Within the introduction of the 3 new innovations, we hope to reduce uterine ruptures. There were no pregnancy case yet, but we are making preparation with a perinatal unit. Thank you for your attention.
Well, thank you very much. A very interesting work. Will you stay with us till the end of the session? Or do you need to go?
But in Japan, the night, I can sleep possibly in the short time. I'm sorry.
Then let me thank you for your interesting talk. This is a very emerging area, and you are doing a big work in this area using MRI and other imaging modalities. It is very important for adenomyosis. I'm fond of this topic also, and we widely use both elastography and functional MRI in order to identify the circulation changes in the areas of adenomyosis lesions and to prevent subsequent ruptures to provide good suturing. Thank you very much for your lecture.
Thank you. Thank you.
Our next presenter is Hans Tinnerberg, who is going to discuss the quality issues of management in reproductive medicine. Professor Tinnerberg is a very good friend of ours. Every year we were meeting in different cities, at different congresses. He knows everything about everything. He's a real expert in this area and a very prominent scientist. Professor Tinnerberg, now the floor is yours. You have some 20 minutes to present us your data on quality management in reproductive medicine. Please go ahead. Hans, you have your mic off. Will you please turn on your microphone?
It should be better
Professor
now.
Tinnerberg, will you please have your mic on?
Yep, it should be on right now. Can you hear me now?
Yes, yes, I can hear you.
Well, again, I'm very happy to see Professor Adamyan again. She looks younger than ever. I was a little puzzled by hearing a male voice in association with this very female face, but I think it was due to translation. Now, also, let me take this opportunity of greeting Dr. Ota, whom I know for many years. Definitely, definitely my topic is not as sexy as the other ones are, but on the other hand, it is very important. And why is it important? It is important because we know that reproductive medicine has always been regarded as being problematic on ethical and moral terms. And you can see here on the left-hand side, a good friend of mine, Alan Trounston from Melbourne in Australia, who made it on the first page of the Australian Weekend magazine as the man who plays God. And definitely everyone who is involved in vitro fertilization or in reproductive medicine knows we cannot play God. All we do is we help couples that have problems to fulfill the dream of a child. And since this is such a difficult task, we need to recognize that quality management is of utmost importance, because this is the only way of creating trust and competence. Now, what is the common practice? The common practice is that there are usually different files from different patient information, and for each different laboratory procedure, there are also dedicated files, and that finally leads to low efficiency because we have repeated activities and redundant data. We have more errors because the number of manual activities increase the probability of human errors. We also know when there's a consultation, it becomes more difficult because we have to consult all files individually. And this in the end means waste of time and energy. So what can be done? There is one solution, and probably Germany was one of the first countries to implement a register. And this was at my university in Kiel in 1982. It was much before governmental institutions started to have a registry and to control what was done. And so it was an activity started from doctors for doctors, and all data that was agreed were collected prospectively and anonymously. This finally developed into an electronic medical record registry, which was administered by a medical chamber, and all centers were paying money for it, and it was finally transferred into what is called DIR. It means German In Vitro Fertilization Registry. You can see the emblem on this side. And the most frequently used IVF software, which is in more than 14 countries, is also from a German company called Meditex in Regensburg in southern Germany. How can we optimize performance and accuracy? And we know that we have to have a well-structured data group. One is witnessing lab procedures. All of you that have dealt with in vitro fertilization know how easy it is to change samples. And we all know of these horrible incidents where, for instance, the sperm was taken from a different husband, so that this led to a lot of confusion. Also, another problem is the data transfer from lab instruments. And meanwhile, we can also have instruments and apparatuses where we can collect all this information into the same one single data collection system, including also the cryopreservation management. As mentioned, the witnessing lab procedures is very important, and by having such a system, we can remove errors and we can improve traceability. It means that we have to have biometric ID checks, that we have labeling. It could be barcode or QR code for identification, and this will also be an electronic witnessing system, and it means that gametes and embryos will be traceable. On the other hand, how can we increase the productivity and the data quality and therefore user satisfaction? So what we have here is the electronic medical record and the electronic health record. And we can see that all data, for instance, from time lapse, from the embryo development visualization, from the microscope, and from genetic testing, all can be fed into one system. What are the key performance indicators of embryology? It is fertilization rate, cleavage rate, in most cases, day 5 embryo use rate, the total embryo use rate, and the survival rate when it comes to vitrification and to thaw by the embryologist. Also, when we plan to introduce changes into our lab, we should follow the very common protocol of Plan, Do, Study, Act, which is also in industry processes. We have this PDSA protocol. And this might apply to progesterone duration and time of frozen embryo transfer on 5th or 6th day of progesterone, and also when we want to introduce or implement different culture media. Let me take this last point for a further explanation. Here we have a documentation sheet where for 5 months different culture has been used. Culture 1, culture 2, and culture 3. Taken together, we can see that when using culture 2, we have a decrease in usable blastocyst rate. So this is below the threshold that we have defined beforehand, and which we know from our previous culture medium that this was giving optimal results. And here we can see a slight elevation, but it will level out later on. And here we can see it is also referred to age group, because age groups can have different requirements.
We can also see what are the upper and lower limits, and we can see what happens to every patient. But overall, this is what counts. So this is where we want to see where we have our cuts and where we have our improvements or our disadvantages. We can also follow up the performance of our staff. And you can see there is an assistant called Jane Demo, and we can follow the ICSI fertilization rate. We can have the total blastocyst usability rate. We can have fertilization rate, and we can also have the 3 peroneal stage rate. And we can see how there is a development in Jane Demo. What is the conclusion of this electronic medical record? We can see that it facilitates powerful analysis of key performance indicators to quickly identify shifts in clinical performance. This does not only reflect on the staff, but also on doctors with a stimulation protocol or with patient selection. And of course, this can be stratified according to age groups of comorbidities and other things, which means that we need a multifaceted approach to data analysis, and that we can also use these KPIs, both clinic-wide and embryologist-specific for KPIs. And this leads also to comparing institutions between each other. Coming back to the German IVF registry, all the data that have been collected, and this includes all German institutions, are discussed in the year following the year before. In other words, in 2020, we discuss early 2020, very late 2019, we discuss the data from 2018. These data are anonymous and they are available on this internet platform if anyone is interested in finding these data. And these data are sort of concluding all the centers in Germany. However, each center gets an individual evaluation so that each center can see these are my data and can compare it with the overall data. However, and this might be of interest, subsets of these individual data are sent to medical chambers for governmental quality control. By law, all these centers are forced or are obliged to subject themselves to a quality control. And since I am the chairman of this quality control system in our state, which is based in Frankfurt, I have access to all these data from each individual center, but of course it is secret. Nobody else can have access to it. This is, for instance, one graph showing the data of all centers altogether. And this is a very interesting graph because it shows what is the pregnancy rate per embryo transfer. And you can see this is related to age. And you can see this well-known drop after age of 35. You can see how it drops. Nevertheless, saying that at the age of 42, there's still a pregnancy rate of 15.4 point. This is in average, but you can also see that the abortion rate has risen, and of course that the birth rate is even lower than the pregnancy rate. Now, what are the quality indicators that are checked by the medical chamber? These are only selected numbers like plausibility of cycles and documented cycles, and of course, percentage of ongoing treatments, fertilization, pregnancies per IVF and ICSI, and percentage deliveries per IVF and ICSIs. Percentage of cryopreservation and of complication, including hyperstimulation syndrome and multiple pregnancies. And we have an additional aspect that is pregnancy rate per ideal patient, because whenever you talk about pregnancy rates, Normally the center says, oh, our pregnancy rate is a little lower than the others because we have so many old patients, we have all these difficult patients. So we defined an ideal patient as 25 to 35 years of age and 2 embryos being transferred. This will be changed soon because we want that only 1 embryo is being transferred. Now, last not least, this is how these graphs look. You see, for each individual centers, we have 1 bar, 1 column. And you can see concerning the pregnancy outcomes, it is excellent that we have many centers with very high pregnancy rates. Little lower, so it is quite horizontal. But this is when it starts becoming interesting. And when a center can see I am the blue line, this is fine. However, if a center has to recognize I'm the red line, it is quite obvious from the very beginning. It's just one single look that this center knows that something is not working so very fine. And we of the IVF Commission look at these graphs and discuss with the centers where might be the problem and what can be improved. I'm coming to the end of my presentation. Let me thank you once again for having me at this conference. I'm sorry for a dry topic, but I hope that it might be stimulating to introduce a very good and efficient quality management protocol in every institution. Thank you very much.
Distinguished colleagues, well, you heard the presentation of a person who has been dealing with quality control all his life in surgery and in reproductive health. Hans, could you tell us, please, will you stay with us till the end of the session or you will leave? Because we're going to have a discussion later. Are you going to stay until the end of the session or not? Do you have time for several?
I will try to stay until the end of the session. Of course, will be interesting for me.
Thank you very much. Then please answer the question. Right now, a lot of people are talking about quality control, not just KPIs of embryologists or doctors, but what about the big data, artificial intelligence? Do you use artificial intelligence in quality control programs? Do you use big data in quality control programs? And do you monitor such situations as the development of pregnancy and pregnancy loss of those patients whose data you are using? Not post factum, but when the woman is pregnant, do you collect data? Do you process those data? What's your take on that?
Well, as a matter of fact, right now we are starting.
Sorry, not now. Just think about it and prepare the answer later. Yeah. Thank you. That's very important because right now, the work we're doing today depends on doctors and their experience. Everyone wants to open an IVF center, but what is happening in this IVF center, we do not know sometimes. But in some cases, we depend on very simple things. The wrong media, the wrong catheter. One embryologist is more experienced, the other one is less experienced. To what extent we should use quality control and introduce new technology of quality control? Please think about it and answer this question later. Professor Gortz is our next speaker. He represents Leuven, Belgium. He's a big friend of ours. And dear colleagues, as for today's plenary meeting, it is outstanding. Professor Gortz is the scientific director of the Institute of Fertility and Embryology. I know Professor Gortz. I've known Professor Gortz for many years. We were there in Leuven, organized workshops and conferences. Professor Gortz was head of that department, and now I know he's still the head of this department, but together with his daughter. Thank you very much. The theme of the presentation is added value of endoscopic management in case of unexplained infertility. I am anticipating your presentation. Thank you, Professor Gortz.
Thank you very much, Professor Adamia, and thank you, Laila. It's really a pleasure to take part in this interesting meeting, and I enjoyed very much the previous lecture. So we will skip a little bit from the IVF unit and go back to what we are calling now the unexplained infertility. So let me go for the terminology, and if it's speaking from unexplained infertility, is it at least 1 year of unsuccessful attempts to conceive in absence of identified, and this is important, identified fertility impairing factors. It is in fact a diagnosis of exclusion. It is clear the more parameters assessed, the more likely to identify an etiology and the less likely to be characterized with unexplained infertility. And nowadays, its diagnosis of infertility is frequently based upon the use of indirect imaging techniques like ultrasound and hysterosalpingography, and the need of endoscopy, in fact, is questioned. Is it still necessary to perform an hysteroscopy and still necessary to perform a laparoscopy? So what I will try to show to you is that still there is a need of endoscopy to reveal pathology which is not detected with the indirect imaging techniques. And I'm speaking here from minimal endometriosis, tubo-ovarian adhesions, the status of tubal mucosa. And we have nowadays new, smaller instruments available where we can do the diagnostic procedure in a minimal invasive way. So if we go to the hysteroscopy, we need only a scope. We do not need any forceps anymore, and we can perform without any anesthesia a vaginal cervical hysteroscopy, like you can see on the video on the left of your screen. And it's important when you're performing diagnostic and also certainly operative hysteroscopy that you have the availability of ultrasound. So I think ultrasound becomes mandatory when you're performing an hysteroscopic procedure, diagnostic or operative one. And here you can see an image which I did together with Professor Gianarolli from Bologna. And you can see on the left side this image we did the mock transfer with methylene blue, like we are loading a catheter for embryo transfer. And you can see that when the uterine cavity is normal, the methylene blue is spreading around the cavity going up to the fundus. However, on the right side here, you can see a very small polyp, and you see when you do a
I'm sorry, we do not see your slides. Can you share your slides with us? Stefan, will you have the slides? No slides? Okay, yes. You have no slides. Yes, or you have the slides. Could you share your slides if you have them, because we cannot see them.
Okay, one moment. Why is this? Okay. So sorry for that. Okay. Is it okay like this?
Yes, we can see them.
Okay. So excuse for that. So you can see here on the left side, you see this normal uterine cavity with the methylene blue, which is going till the fundus. And here on the right side, you can see a very small polyp. And when you do the mock transfer for the embryo transfer with methylene blue, you can see that most of the methylene blue is positioned at around the polyp and is not going till the end of the uterine cavity. So, and what about endometritis? Are you going to use make the diagnosis of endometritis if you do not perform an hysteroscopy? Because most of the endometritis is without any symptom, and diagnostic accuracy of hysteroscopy is about 94%. So hysteroscopy certainly has a place there. And we know that the prevalence of endometritis in patients with infertility is around 50% in patients referred for IVF treatment, and it is 45% in patients with recurrent implantation failure. So I believe the diagnosis of endometritis becomes an important issue. And we know that by using antibiotics like doxycycline and clindamycin, you can increase the ongoing live birth rate, as you can see here, and also the ongoing pregnancy and implantation rate. So I believe that the diagnosis becomes very important. Also, as we have seen in previous lectures during this session, adenomyosis is a very important issue in infertility. And also here, hysteroscopy can be of value. You can see here a very cystic bulging. And when you open it with the scissors, you see the abnormal vascularization. And when you open it with scissors, the blood, the chocolate fluid will come out. You have the typical images on the right with the endometrium defects. You can see here the small vesicle here and another vesicle there. So there are some signs of adenomyosis which you can see when you perform hysteroscopy, and we should miss in other cases when you do not the endoscopic inspection of the uterus. So you will see unsuspected intrauterine pathologies in about 25 up to 56% of the patient, depending on the report. It's also important when you're looking at the uterus to have an exploration of the subendometrial area, and fusion with ultrasound is mandatory for diagnostic and for operative hysteroscopic procedures. Let's move to laparoscopy. And laparoscopy as a diagnostic tool is postponed in the exploration of the female pelvis because it's been seen like too invasive. It's not an obvious procedure, and it asks for some expertise by performing it. And a lot of centers now are frequently standalone centers where no laparoscopy is performed anymore and where they are relying upon ultrasound. And that's one of the reasons why, and that you know that we started many years ago in '98, the transvaginal lateral laparoscopy, because it's a minimal invasive procedure which can be done under local anesthesia or under sedation in a day hospital setting. And I will not go into details because you must know about the transvaginal. But let us see what can we find if we perform a laparoscopy in infertile patients with so-called unexplained infertility and with normal hysterosalpingography. And you will see in several publications here that when you perform a laparoscopy in those patients, that you will find pathology in about 50 to 70% of the patient. You have another publication with a very nice one from Bono. He looked at 140 infertile patients with so-called unexplained infertility. There was no other problem, normal ovarian reserve, normal ultrasound scan, patent tube and hysterosalpingography, semen analyses were normal, and there were 3 cycles of relation induction with or without IE, which were performed previously. So when he performed the laparoscopy in those patients, he found abnormality in 83.4% of the patients, with in a majority of the patients the presence of endometriosis, mostly minimal endometriosis, stage 1 or 2, in 70% of the patients with endometriosis. So when he is going to treat this patient laparoscopically, then you see that he has a pregnancy rate of about 77 out of 102 patients, where 35 of these patients, which means 50% of the pregnancies, 35 of the patients became pregnant in vivo, which means that 34% of them received pregnancy in a spontaneous way. Another publication in patients with repeated implantation failure, we have 3 failed IVF attempts with the so-called diagnosis of unexplained infertility. When he performed the laparoscopy in this patient, 70% of these patients had 60% of these patients had endometriosis, 23% had periadnexal lesions, and 18% were indeed unexplained. Also here, when he treated the patient, you can see that cumulative pregnancy rate after about 6 months goes up till around 50 to 60% of these patients. Another publication, very nicely, also unexplained infertility with 3 failed IVF cycles. Important here that he divided randomly the patient in 2 groups. In 45 patients, he performed a laparoscopy, and in the other 45 patients, he did not perform a laparoscopy. In those patients where a laparoscopy was performed, 16 patients conceived spontaneously, again, a spontaneous pregnancy rate of 35%. But what is more interesting, when you looked at the pregnancy obtained after IVF in those patients who did not become pregnant spontaneously, in the study group where he performed the laparoscopy, you can see that the pregnancy rate is 45% versus only 23% in the control group. and the live birth rate 35% versus 17% in the control group. So also the laparoscopic correction of the pathology that's been seen at laparoscopy is increasing the pregnancy rate in this publication after IVF. So not only for spontaneous conception it's important, but also for the pregnancy after IVF. I had a look at our procedure of transvaginal laparoscopy, which is now for more than a decade, and it's about 2,280 procedure, which was normal in about 50% of the patients. Just to remind you, these are patients without obvious pelvic pathology with normal vaginal examination and normal vaginal ultrasound. So here we found in 16% of the patient endometriosis and in 14% of the patient tubal pathology. Tubal pathology mostly due to the presence of adhesions, infectious adhesions, or either salpinges, fimbrial abnormality, or failed patency. And we know that there are a lot of subtle tubal lesions, which some of us will consider as being normal, but where some of these subtle lesions indeed can play a role to become pregnant spontaneously. And this is a nice publication from Ben Mokhtar and from the group from Waterloo, where they saw that in 67 out of 341 cases, there were tubal abnormality, and when he treated this tubal abnormality, he had a pregnancy rate of about 50% in those patients, and no pregnant and no ectopic pregnancy. And probably Antoine will speak after my lecture about this tubal pathology. Fimbrioplasty, you can see the small bridge here between the fimbriae. So this modified laparoscopic fimbrioplasty can indeed result in a higher spontaneous pregnancy rate, which you can see on the graph on the right side, which goes up to 40 to 50% of spontaneous pregnancy rate, depending upon the age of the patient. This is a simple procedure allowing patients to become pregnant spontaneously. Another publication is that from Rashid, where he looked at the presence of cyst of Morgagni, and in 127 patients, he removed the Morgagni cyst, and he obtained a pregnancy rate of around 60%, where in group 2, he did not perform an intervention at all, and there the pregnancy rate stays around 20%. So although the cysts of Morgagni are not considered systematically as some pathology which can interfere with fertility, this publication indeed shows the importance of this infertility and of the cyst of Morgagni. And if you look at patient in infertility versus no patient with infertility, the probability to find cyst of Morgagni is around 38% in infertility patients versus only 60% in patients which are fertile. Coming back to the endometriosis patients, you know that at transvaginal laparoscopy, we can see the small endometriotic cyst. And when you have a look inside of the small endometriotic cyst, you see this neoangiogenesis, which is present, and you see the inflammatory reactions. So these are really very active diseases, and it can be discussed if this should be treated, yes or no, as we have no real biomarkers which can tell us which disease will further evolve to a more severe form of endometriosis. We are treating this with a bipolar instrument, and you can see on the right side the end result, which is really minimal, causing a minimal damage to the ovaries. There's a very nice publication of Almquist showing that when there is an aberrant expression of BCL6 in the endometrium, this has a very high sensitivity for diagnosis of all stages of endometriosis. And when the BCL6 expression is abnormal in patients with unexplained infertility, then in those cases, the pregnancy rate is much lower. It's around 20% versus 60% in those patients with a normal expression of BCL6. So the pathology of endometrium plays an important role in obtaining a pregnancy. We looked at 320 patients where we had a diagnosis of endometriosis. 52 from the 71 patients which we asked to try to conceive spontaneously, 52 became pregnant spontaneously. This is 73%. The other patients were sent for IUI or donor insemination. So in total, the in vivo pregnancy rate in those patients which we treated for these endometriosis is 43.8%. And the rest of the patient, we send it to the IVF program. So the results of endometriosis, treatment of subtle lesions of minimal endometriosis results in spontaneous pregnancy rate of 72% and in vivo conception rate of 44% within a delay of 1 year. So the incidence of unexplained infertility is normally reported as being 25 to 30% of couples trying to conceive. If you look at the Belgian register for assisted reproduction and for centers referral for patients to IVF, mostly 21.5% is due to unexplained infertility. If you are looking at their personal data, where all the patients received the transvaginal laparoscopy, our diagnosis of unexplained infertility is only 5.3% of those patients referred to our IVF program. So endoscopy, to conclude, for the diagnosis and treatment is indeed an added value in patients with unexplained infertility. Only visual inspection of the female pelvis enables identification of lesions not visible with indirect imaging, and subtle lesions may represent an underestimated cause of infertility that could be present in so-called unexplained infertility. So combination of ultrasound, transvaginal laparoscopy, and hysteroscopy offers a potential for minimal invasive exploration of the female reproductive tract. And treatment of diagnosis of subtle tubal or ovarian lesions results in spontaneous pregnancy rate, depending on the publication, between 50 to 60% of the patient within a delay of 1 year. So yes, I believe in the added value of endoscopy. So thank you very much for your attention.
Dear Professor Gortz, thank you for this presentation. It is indeed of great importance. You know that I've been in medicine for 50 years. We have a wonderful school of endoscopy, and our data show that when we use the endoscopic control, it improves the pregnancy rate, even for patients who are referred to IVF by 1.5 2 times. And you cannot just do IVF blindly if you do not know what particular concomitant diseases this patient has. We're talking about unexpected infertility when we do not have any imaging, but when we have imaging techniques, this unexpected pregnancy, unexpected infertility becomes explained infertility. Please, Professor Gortz, stay with us. Professor Vatrilo, well, bilateral hydrosalpinx treated by salpingoplasty, 450 cases. Anton Vatrilo is the counselor of the King's College in London and St. Bartholomew's Hospital in the UK. He is a wonderful surgeon. He is consulting in different fields, and we are also friends. Professor Vatrilo, the floor is yours.
Thank you very much for your kind introduction. Share my screen. Okay, so I will speak about today the result of our series of 480 bilateral hydrosalpinges. First of all, to say that you have no conflict of interest in this presentation. We know that the hydrosalpinx and IVF outcome are not good. You see the historic paper of Strandel, I think everybody knows. If you have hydrosalpinx and if you perform a salpingectomy, will you have almost 30% of pregnancy rate. If you don't do salpingectomy, you have only 16. So almost half of the result. It has been already demonstrated by other authors like Deschaux, Contovadis, and Average. And you see that every time we know that if you keep the hydrosalpinx, you have a very deleterious effect on IVF. First of all, we have to be precise in our definitions. And when we speak about distal lesions, we have two kinds of the phimosis, we have salpinx, which is a total occlusion of the tube, even if sometimes you may see some femoral part, but there is no connection between that and the hydrosalpinx. In case of distal lesions, we will do a fimbrioplasty, as Stefan told you. In case of hydrosalpinx, we are going a neosalpingostomy because you are going to create a new osteum. An example of hydrosalpinx, still we have a fimbria, but we have no connection between. It means it is really a complete hydrosalpinx. So we can do two things: conservative treatment, which is a salpingoplasty, or radical treatment, which is salpingectomy. If you compare, when you do salpingectomy, of course it is efficient for IVF, but it is psychologically difficult to bear, especially when bilateral, and of course it is definitive. When you do a salpingoplasty, it allows spontaneous pregnancy, and sometimes several, if wished. It is a little more technically challenging, and of course, also we have the risk of recurrence. But we consider today that conservative treatment may give result as good as IVF, depending on three kinds of criteria: the tubal criteria, the technical skills, and human criteria. I want to show you quickly that. First of all, the tubal criteria, sometimes it is evident. If you see this hysterosalpingogram, obviously we have nothing to do except remove the tubes and go to IVF. But we know that if you only do hysterosalpingogram, we have a lot of false negative in the meta-analysis of SWART, and it has been demonstrated, and Stefan showed you that just one moment ago, that it is something we don't release only on hysterosalpingogram, we have to go further. Then we have the tubal criteria, and when it is very important, it is a salpingoscopy. And salpingoscopy could be done by transvaginal endoscopy, as demonstrated before by Stefan, which is the father of the technique, and we adapt that technique. We call that fertiloscopy, but basically it is the same. And you see we are using the pouch of Douglas. We put some water in, and then we inflate the balloon to stay in. And then we have an hysteroscope. We go in the central channel of the device, and you will see that immediately when we do that, sorry, yes, when you do that, the hysteroscope is inside now, and we are very close to the genitalia, and especially of the tube, so you can easily go in the tube and perform a perfect salpingoscopy just with the same hysteroscope, which is something very convenient. And so that the two criteria, the tubal mucosa and the tubal wall, we have to be seen. So for the selection, the prognosis is good if the mucosa is healthy, normal thin wall, and we can do that by transvaginal salpingoscopy. Then we have to see that when you have problem with the mucosa, we have the tubal score from Brosans, and you see then we have one or two stages. It is almost normal. 3, 4, and 5. It is abnormal salpingoscopy. And if you compare now, when you do the hydrosalpinx treatment, if you are dealing with 1 or 2 stages, we have very good result. 3 and 5, very bad. It means that if the tubal mucosa is not good, then it is much better to refer the patient to IVF. Also, we have to consider the adhesions, and you see the scoring of adhesions by the French scoring system. And when you have a stage 4, you see the pregnancy rate is very low, whereas when you have a stage 1, so few adhesions, we have a good pregnancy after treating the hydrosalpinx. The second criteria is the technical skill, and it depends on the hands. You see in two non-specialist hospitals, in 1990, there was a publication showing that they get only 5% of pregnancy rate, which is very low, of course. If you see specialized hospital, you see that the pregnancy rate is around 34, 31. And so if you do this kind of surgery, we have to have a certain skill in it. Technical skill also require to use microsurgical principles defined by Gommel and also Winston in the 80s, which are the no-touch technique, magnification, irrigation, acute and economic hemostasis, and microsuturing of the eversions, and not to use the coagulation to have the flower effect. So the technique, you open the hydrosalpinx, you do stellar incisions, and you make eversions. I will show you that in a moment. Knowing that we have two kinds of salpingo-neostomy, the racket form and the cuff salpingostomy. And we will see that the results are totally different. We have to prefer to do a cuff salpingostomy. So that is hydrosalpinx. A racket form, it is like that, just open as you can. And when you do a cuff neostomy, you can make a complete eversion and create, a much better fimbria end. But it is some imaging, so you try to find the old osteum and then you open it. You see the mucosa in this case is good, and then we have to fix the eversion, like in this case, for end result which is not bad. I will try to show you a video. I hope that the video will work because I think my connection is not that good. So you see that it is the time of adhesiolysis. Adhesiolysis has to be complete. And then you have to try to find the old osteum. We put some dye in the tube, and then we open the tube very gently. And immediately we have a lot of blue coming through. And you can start to make the eversion, like in this case, where the mucosa, you see the mucosa is not bad. And we will be able to do a cup salpingoneostomy. Another case, which seems to be not very good because a lot of adhesions, but in fact, when we will see when you open the tube, like here, you see the mucosa is already coming through here, healthy mucosa. So when you have this kind of mucosa, then you can go on and expect to have a good result. At the end, we have to fix your eversion. You have to use small thread, 6070. Here you see a cuff salpingoneostomy when you can make totally a good fimbria, and at the end we have also to recover and to fix the eversion, and if possible to cover these white pieces, which was some coagulation area, and if possible try to cover it, because each time you do this kind of burn, it is a risk of postoperative adhesions, and therefore it is important to try with your suturing to cover as much as you can this kind of area. So you have to use small thread, like in this case. You see it is a little more complicated, but in fact it's a little a bit now. By laparoscopy, we are totally able to do this kind of suturing. My target in this case was to cover, the burn that I have made. So it is why you know that we have to be very economic when you do coagulation. Sometimes it's not possible. And then we have to do the suturing. You see, we have at least covered part of the burn, and at least it is now quite far from the osteum, which is not bad. Then we do usually 2, 3, 4 suturing. It is important to fix, because if you don't fix your eversion, you'll be sure to have recurrence of the hydrosalpinx. You see in this case, the tubal wall is good, the mucosa is good, and we may expect to have probably quite good result when you do this kind of surgery, that it is the end result with the blue coming through. Then we have the third criteria, which is a human criteria, because there is a tremendous psychological impact of self-injectomy, especially if it is bilateral. And of course, if we have male fertility problems, then it is more easy to do self-injectomy. And we have always to discuss the interest of the conservative treatment versus IVF, and when it is who has to decide what to do. And you have to, if you decide to do the conservative surgery, you have to inform her of the risk of recurrence and of the risk to have a second laparoscopy at that time to do self-injectomy if she has recurrence of hydrosalpinx. What are the results we can expect to see from the literature? With a quite good selection, 26%. I show you my own result. The first period was at the time of microsurgery by laparotomy. You see 18% only. And by laparoscopy, we have 48. But there is a bias because at the time of microsurgery, we did not selection at all because at that time IVF was not good. So almost all the patients were operated. Now on, we make a very careful selection. And if you do a good selection, then we may expect to have a good result. Also, what it is important, it is the kind of, you see that the pregnancy rate is only 24% with a lot of miscarriage and ectopic salpingoneostomy. It is much better, 57% of pregnancy rate and only 3% of ectopic. In all, when you combine both, we have 49% rate. But we may say today probably that tracheotomy salpingoneostomy is less effective and probably IVF should be preferred. In this case, if you cannot do curved salpingoneostomy, probably it is better to go directly to IVF. Once again, it is a question of selection. So in conclusion, I will say that salpingoplasty is still a valid option. It should be strongly considered when we have hydrosalpinges which are bilateral, because in this case you have to remove both tubes, which has a big impact. And information is critical since recurrence is always possible, leading of course to a secondary salpingectomy. And I thank you very much for your attention. Thank you.
Thank you very much, dear Professor Batelou. We are moved back 20 years ago, and I recall when we had nothing, there was only, IVF was only introduced at that time. I had the similar series comparing microsurgery and laparoscopy, and pregnancy occurrence rate was about 30%. It is still 30% of pregnancy rate. Perhaps we were dealing with different types of patients at the same time. And if you stay with us till the end of our session, we're going to have a very interesting discussion. Thank you. Let me give the floor to Professor Vito Cella. Today, he presented a very interesting overview on robotic surgery. Several thousands people were listening to us, and Professor Vito Cella, he's a young professor in obstetrics and gynecology in the University of Pisa, and he is a prominent expert in robotic surgery. He's a director of IVF unit, and he's going to deliver a lecture, Does Surgery Improve IVF Outcome? So I'm very certain about it, but you should prove it to us. Thank you very much. Dear Vito, the floor is yours.
It's really not easy because you are a big, one of the big experts in endometriosis in the world. So I will share our experience in our surgery and IVF in our center with you. As we know, as we know, endometriosis is an infertility is still a matter of the debate. and endometriosis infertility is a difficult disease. And we know that the prevalence between 25 and 50% of infertile women has endometriosis, 30-50 women with endometriosis are infertile. Infertile patients with untreated mild endometriosis have a spontaneous pregnancy rate between 2 and 4.5%. Patients with deep endometriosis has less than 2% to become pregnant spontaneously. Which are the mechanism, the biological mechanism that related endometriosis and infertility, we think are different. We know that endometriosis is probably a multifactorial disease, so it could be an alteration of distortion of pelvic anatomy and impaired peritoneal fluid because we have a lot of cytokine, we have a lot of adhesion factor. It could be an anomaly of the tubal function, an alteration of hormonal and cell-mediated mechanism, anomaly of endocrine and ovulatory function. We have still sometimes PCO patients that have endometriosis in the same time, and we have an impairment of the implant and also of the quality of the oocyte and of the embryo. Which is the management? The management is not easy, is a difficult, and we have to think about, because first of all, we have the different phenotype of patient with endometriosis. We have a superficial patient with only superficial endometriosis. We have a patient infertile with endometrioma. We have a patient with deep endometriosis, and we have a patient with both endometrioma and deep endometriosis. We have patient with symptoms, and we have patient without any symptoms. It's depending the infertility of the age of the patient, or we have to consider the ovarian reserve, other associated infertility factor, and if the patient had already previous surgery, and also how much is the size of the lesion. So important is the time when we see the patient. This is a report of Italian IVF register. Those are the data of 2016, and you see the patient that do IVF with endometriosis, they are 4.5%. As we know, we have a lot of patients, a lot of papers come out to talk about how to treat the patient with the infertility and the endometrioma, how to treat the patient with the infertility with the endometriosis, and it's still a matter of the debate, because if the paper is wrote from people doing IVF, they say that IVF is better than surgery. If the paper are wrote from doctor they are the best in surgery, they say surgery is better than IVF. So it's not easy. What we know, and this is a good paper from Koch in 2008, that after surgery, we can have a spontaneous pregnancy. And the pregnancy is correlated with the age of the patient. You see blue line is they are patient after laparoscopy with endometriosis less than 35. The green line are patient after surgery, is the pregnancy rate, more than 35. But is also correlated with the stage of an endometriosis. Blue line, pregnancy, cumulative pregnancy rate after surgery in patient with stage 1, stage 2, and red line, surgery, spontaneous surgery after laparoscopy in stage 3, stage 4. So we have a possibility after surgery of spontaneous pregnancy. Still, we know this is deep endometriosis, and this is what say infertile woman with stage 3 e stage 4 on endometriosis clinica can consider operative laparoscopy instead to expectant management to increase spontaneous pregnancy rates. So if we do surgery at the patient with deep endometriosis, is only to increase the to have faster pregnancy rates in comparison with the expectant management. But at the end, after 2 years, is the same pregnancy rate. So when we think about still patient with endometriosis and infertility, we have to evaluate which are the risks of surgery prior IVF and which are the risks of IVF prior the surgery. Which are the risks? So the risk of surgery is depend on the skill of the surgeon, the cost, the possibly complication, the impact of ovarian reserve, the incomplete surgery recurrence, and may delay the time of pregnancy because delay ART. What about IVF, which are the risk progression of the disease, increase of inflammatory reaction and oxidative stress, difficult oocyte retrieval, risk of cancellation, follicular fluid contamination, endometrioma infection, undiagnosed occult malignancy, risk of rupture and subsequent peritonite, or pregnancy-related complication because we have endometriosis inside. Also, the guidelines, they are not very clear. They are not, mainly when we talk about deep endometriosis. What they say, those are the actually guidelines. And they say that in fertile women with endometriosis larger than 3 centimeters, there is no evidence that cystectomy prior the treatment with the IRT improve pregnancy rate. And we recommend to consider cystectomy if there is improve endometriosis associated pain and the accessibility of the follicle. And the recommendation also is to counseling the patient. Then if they do surgery, if they proceed for surgery, should be considered a decrease of ovarian reserve. So that is the guideline for endometrioma. What about deep endometriosis? The only thing that they actually say is the effectiveness of surgical exclusion of deep nodular lesion before treatment with assisted reproductive technology in women with endometriosis associated infertility is not well established with regard to reproductive outcome. So guidelines, they are not clear. Go through. So we try to study, our study you will see has been a retrospective study that we published in GRAM. And we want to determine the impact of endometriosis surgery on the result of ART, the impact of surgery of different endometriosis phenotype in the ART result, and the impact of surgery after failed IVF on the result of the RT. It's a retrospective observational monocenter study, January 2011, December 2018. Inclusion criteria were infertile patients with histological clinical instrumental diagnosis of endometriosis, age 18, 43 years, indication for IVF. Exclusion criteria as other associated female infertility factor, endocrinopathy, other comorbidity, severe male factor. So we made a history, complete history with the comorbidity, duration infertility or previous surgery. Those are all the diagnostic examination, genetic counseling, biochemical serological test, breast ultrasound, hormonal profile evaluation, ultrasound transvaginal, hysteroscopy, and check the seminal fluid. Which parameter we evaluate? Age, body mass index, FSH, MIH, AFH, surgery, non-surgery, site of endometriosis, and which result? Average number of sites, mature, fertilized, embryo transferred, a good quality, average value of estrogen and gonadotropin used, percentage of fertilization, percentage of mature oocyte, percentage of good quality embryo. Pregnancy rate by cycle, embryo transfer patient, percentage of implant, rate of miscarriage, rate of live birth by cycle, embryo transfer, and patient. So totally we had we had 106 patients for 177 cycle, but 22 patients were excluded because they have superficial endometriosis with male factor or endometrioma with the male factor. So at the end, we included 78 patients for 131 cycle. And 4 phenotype of endometriosis patient: endometrioma, endometrioma plus surgery, deep endometriosis plus endometrioma, deep endometriosis plus endometrioma, and surgery. Those are result, the patient characteristic, and you say age, 35, BMI 21, OMA 36 patient, deep endometriosis OMA 42. Those are the ovarian reserve characteristic. And you see we had 37 patients, had 37 cycle 1, 30 cycle, 2 cycle, 10 3 cycle, 1 4th cycle. We had 107 embryo transfer. The cancellation rate was 80%. The clinical pregnancy rate for cycle 25. The clinical pregnancy rate for embryo transfer 30. The clinical pregnancy rate for patient 42. The implantation rate 15%. The miscarriage rate 30%. Live birth for cycle 18. For embryo transfer 22. For patient 30%. So those are the clinical characteristics and ovarian reserve for a different phenotype. What we can see there is no difference statistically different. What we see, the MH is a little bit lower in the patient that has surgery in the phenotype with endometrioma and the phenotype with deep endometriosis, but it's not really statistically significant. What about the outcome, the RT different, the outcome in a patient with a different phenotype? So we can see that also this is not statistically significant, but patient with surgery has less retrieved oocyte, OMA surgery, and the deep endometriosis plus OMA surgery, but it's not statistically different. And the patient with endometrioma surgery has not statistically different, more use of gonadotropin in comparison with the other patient. If we go to the comparison with now we talk about patient with the 2 phenotype, with endometrioma and with endometrioma in comparison plus surgery. And we see this is a significantly different. The patient had surgery with endometrioma had a more good quality embryo rate, 72 against 37. And we have also statistically significantly different the cancellation rate. The patient with surgery had more cancellation rate in comparison with the patient without surgery, 26 in comparison at 0. Sorry for that. Yes. If we go, but there were no statistically difference in the patient about the live birth. That means probably then the good embryo quality, the good embryo rate of the patient they had surgery, they overcome the cancellation rate of the patient with surgery. And at the end, we have the same live birth. Same things if we go the characteristic of ART of the patient with deep endometriosis and deep endometriosis plus surgery, this is different. This is another things. The patient that had surgery with deep endometriosis has a better fertilization rate, 84 against 71. They have a best metaphase due to oocyte rate, 18 against 77. The best good quality embryo rate, 76 against 73. The best clinical pregnancy rate, 36 against 13. The best clinical pregnancy rate for embryo transfer, 43, and also for patient, 64 against 21st. The implantation rate was better, 19 against 7.8. The miscarriage was better, 27.7%. So that means that also the live birth was better in comparison with the patient they had done surgery. This is impressive how surgery, the impact of surgery in the patient with deep endometriosis. This is the univariate analysis to compare for prognostic factor to compare pregnancy positive or negative. And it's interesting to see that age, BMI, FSH, MH, AFC, they are not different. Endometrioma, if it's bilateral or unilateral, there is no difference in the positive or negative pregnancy test of pregnancy. The phenotype, endometrioma or deep, is not different. What is different is surgery, yes, surgery, no, in the positive pregnancy rate. You see, there is 47 against 28. They had no surgery. This is not significantly different, but it's a tendency. If we go still and we share and we go to see the phenotype, we see that the patient with deep endometriosis and surgery has a significantly different good pregnancy positive test in comparison with the other. They are 57. Okay, this is in comparison with the negative. So the patient with deep endometriosis, their surgery really benefits. They have a benefit for surgery. There is no difference also if we compare the protocol between agonist or antagonist. The other really difference, interesting, is if the patient they had surgery with the AVF, after IVF failure, as a significantly pregnancy positive test in comparison with the negative test. And this is also impressive, and it could be, after failing the IVF, could be really an indication. So, which are the limit, the strength of our study as is a retrospective, little sample, non-homogeneity in priority medical therapy, which are the strength. There is no other factor of infertility or comorbidity. Is a sample, homogeneous sample, and the surgery is performed in a single center. So discussion, we go to discussion. We know that the management of infertile patient with endometriosis is still a matter of a debate. Guideline is not clear. We have the lack of randomized clinical trial. We have to think about where are the surgery risk or the IVF risk. We have to think about ovarian reserve, age of the patient, which is the operator experience, the surgeon experience. If we are in front of endometrioma or deep endometriosis, because you will see, and you see it's different. And if there is a desire of pregnancy, and if the patient has a symptom. So important also the time factor. So I think probably the combination of IVF and surgery is the best approach for this patient. So it's important, a personalized strategic decision. So if we have endometrioma, which is the strategic decision, we have lower level, we know lower level of AMH, greater rate of cancellation cycle in operated patient, lower number of oocyte recovery for operated patient, greater dose of gonadotropin used for operated patient, greater good quality embryo for operated patient, but no different in pregnancy rate between operated and non-operated patient. So which is the flowchart? Probably surgery when it's suspicion of malignancy or intense symptom or a poor quality of life. IVF is, we have a poor ovarian reserve, depending on the age of the patient, previous surgery or other factor infertility. If you have a poor ovarian reserve, we need faster IVF. We have to consider also fertility preservation. What about deep endometriosis, which is the strategic decision? Poor evidence in literature, inconclusive guideline, often symptomatic patient. We know that operated patients have lower AMH, no different in cancelled cycle or cycle-led transfer embryo, dose of gonadotropin in operated patient versus non-operated. Greater rate of mature eggs, fertilization, good quality embryo in operated versus non-operated patient. Greater pregnancy rates and implantation rate in operated patient versus non-operated patient. Lower abortion rate in operated patient. If we have IVF failure, success of surgery and not to attempt or surgery. So in conclusion, so those are some of the papers they are published on the endometrioma, and people then do surgery, say it's better surgery. People then do IVF, they claim that it's better IVF. So, I mean, it's not clear. This is another paper from Soriano, where they treat with surgery patient who had IVF, previous IVF failure, and surgery. This patient benefit about surgery. Those are another with the patient with colorectal endometriosis. We should do surgery or IVF. And also in this paper, they said first-line surgery may be a good option for women with colorectal surgery because live birth, the pregnancy rate is better. And those are the, this is the blue line, is first-line surgery and IVF. This is first-line IVF. This is live birth. This is pregnancy rate. So in conclusion, endometrioma surgery don't offer an advantage in terms of increased pregnancy rate. Deep endometriosis surgery appear to be beneficial in terms of fertilization rate, good quality embryo, implantation, and pregnancy rate. We think after IVF failure, surgery appear to offer an advantage, a big advantage. So what is important is personalized strategic decision, counseling, and share with the patient our decision. And also another thing is a preservation of fertility in patients with endometriosis. Thank you very much.
Thank you very much, Professor Cella. You surprised me today because I always considered you as a robotic surgery, but you gave a wonderful presentation based on analytical material. Please stay with us if possible. We're going to have a discussion at the end. And the main question of this discussion, and well, I must know if I'm going to stay or not, what mechanism of surgery can play on the restoration of the reproductive function? How can surgery restore the reproductive function? Do you use robots in treating endometriosis? You will mention this during the discussion if you stay with us. Thank you very much. Our next presenter is Professor Antonio Setúbal, Lisbon, Portugal. He is a big friend of ours. We've known him for 30 years. We've been communicating for 30 years. We organize joint conferences, joint works. Professor Setúbal is the leading endoscopic surgeon in Portugal. He is the director of the OBGYN department at the Luz Hospital, Lisbon. The theme of his presentation is seal and surgical treatment in case of uterine scar inconsistency. Antonio, please, the floor is yours. I'm glad to see you.
Hello, Leila. I don't know if you are listening to me or not, but again, thank you for your kind words, and again, thanks for inviting me to be, let's say, in Moscow all together, except for the dinner of tonight. I will talk a little bit about isthmosil. I know we are late, and I'll talk about the diagnosis and treatment. First of all, let me remind you that by definition, isthmosil is a pouch-like defect on the anterior uterine isthmus at the site of a previous cesarean section. But also, if you go into the literature, you have to take in account that that are synonymous. If you want to look for isthmosil, you also have to look for niches, cesarean scar defect, and cesarean scar descent. The incidence for the C-sections all over the world are multi-factor. It depends on ethnics, cultural, geographic, medical indications, and those are becoming more and more important because of maternal increased risk of obstetrical complications and because of fetal increased risk. That is, a maternal and fetal increased risk because women are getting pregnant older, meaning more than 35 years old, especially in our country. Infertility rate also, it's a risk. Some diseases like obesity, diabetes, hypertension, of course, smoking and other chronic disease. But above all, remember that the ladies, the women are have more and more late family planning. The C-section rate all over the world, there are some figures that you can see, even some more figures and data, but in France, it can go up to 20%. In the UK, you can see that it raised until July 2012 until 29%. In USA, there was an increase of 50% between 96 and 2007. In Brazil, the overall C-section rate is 45%, but on the private sector, it's 81%. And in Portugal, the C-section rate is 35%. The risk factors for isthmoceles are multiple C-sections, the retroflexure of the uterus, the cesarean in advanced labor, and the way that you close the cesarean, the field of the C-section, meaning that now it's most of the people are doing just one layer, and this is clear, not a good way to do. You have to do it in a double layer because we know that the thickness of the myometrium will be bigger, and of course, the closer you do the incision to the internal os of the cervix, the more factors for isthmocele you're gonna have. So about etiology, why do niche develop in C-section uterine scare? You can see that, as I told you before, a low cervical location of the uterine incision, an incomplete closure of the uterine wall, again, due to the single layer modality, and it's better to close it in 2 layers, and some other surgical activities like can induce adhesion formation, like non-closure of the peritoneum, inadequate hemostasis, and for instance, the use of adhesion barriers and patients-related factors that possibly hamper normal wound healing and related angiogenesis. Symptoms. Well, most of the patients are asymptomatic. The most important is when you have intermittent post-menstrual bleeding, pain and dysmenorrhea. I don't know, it's a big problem related only with isthmocele, and of course, in cases of infertility and subfertility. Obstetrical complications, the most important is uterine rupture. And the other one that is becoming more and more important, and probably more than 6%, is the ectopic pregnancy at the site of the isthmocele. The diagnosis is clear: transvaginal ultrasound, hysterosalpingogram, hysteroscopy, and magnetic resonance. This is a publication by Jeremy in which you can see a huge in hysterosalpingogram defect and also on MRI. I'll show it to you also on MRI with blood in the interior of the niche or the isthmocele that you can see over here. And we published back in 2017 on JMIG, the treatment of uterine isthmocele, and just 3 months ago, we also published the demonstration of isthmocele surgical repair. Treatment. Okay, we have the medical. I will discuss a little bit about that. And we have the surgical repair. The surgical repair, you have descriptions by vaginal, laparotomy, laparoscopy, robotic, combining techniques between laparoscopy and, of course, hysteroscopy. And if there is no desire for pregnancy or to preserve the uterus, of course, you have the hysterectomy. For medical treatment, the most important one and effective is the pill, the oral contraceptions. And remember that Mirena, for instance, have no benefits on the treatment of symptomatic ladies with isthmocele. This is the first algorithm created. It's in French, but it was created by Jeremy, saying that the cutoff to decide to operate or not, it will depend on the thickness of the myometrium, about 2.5. But saying that if it is less than 2.5 millimeters, you can go vaginally, laparoscopy, or laparotomy. But if it is thicker than 2.5, they go more or less the same, they follow more or less the same treatment. This is more difficult to read, but I'll try to explain. It was published by Marotta and Olivier Donez, and the cutoff was 3 millimeters. If you have residual myometrium of less than 3 millimeters, laparoscopy repair should be used. If it's more than 3, and if there is an indication for surgery, then hysteroscopy should be the one to be used. I will not go in details about laparotomy, vaginal surgery, just to stress the point about hysteroscopic repair. And as you can see, even if hysteroscopic treatment seems to be useful in infertility, like it was described by Tanimura, Raimondo published that at least 16 out of 120 patients still have the same post-op symptoms. This is the classic image of receptoscopy, of hysteroscopic treatment of the isthmocele. And when we talk about laparoscopy, we have to, first of all, to define tips and tricks to identify the C-scar defect or the isthmocele. So you can use hysteroscopy, like we do. You can use a 6-Egger dilator, a combined hysteroscopy and the Egger dilator, and even it was published with the use of a Foley catheter. As I told you before, we published the demonstration of isthmocele surgical repair, and as you can see, we go by transillumination by hysteroscopy to define the margins here of the isthmocele. Then we use only cold scissors, and we don't use any kind of energy, because when you do the repair, the edges of the myometrium will be better healed. And we use figure of 8 double suture to close the isthmocele. So there is no consensus how to do it, by separate sutures, double layer closures, separate with a figure of 8, or running suture. Again, there is no data about this. The results for the laparoscopic repair, it appears that according to all the publications, the clinical symptoms improved, the thickness of the myometrium improved, and as it was reported by Olivier Donez, the spontaneous pregnancy rate improved 44%. I will not use all the video in sake of time because we are already late, and I know that Leila wants to keep the time all in all the sessions in Moscow or in a webinar. Sometimes you have some more difficulties to move the bladder away. We start doing the hysteroscopy, and sometimes the thickness of the myometrium is so thin that the pressure of the hysteroscopy itself will make a hole into the uterus, and then you have the location of the isthmosil, and you can start your operation. As I told you before, we use cold scissors. I'm not going to go into all the video. As I told you before, in sake of time. So surgical repair, we have complications. Yes, there are remaining symptoms from 0 to 10, analyzing all the techniques, meaning vaginally, meaning in robotics, there is not too much complication, but for laparotomy, for hysteroscopy, for laparoscopy itself. And the most important complication is when you enter into the bladder, because there are firm adhesions, but you have only to do a cystoscopy. If the patients don't want to get pregnant, and if the patients don't desire to keep the uterus, of course, you have hysterectomy. So in conclusions, surgical treatment of isthmosil should be offered to symptomatic women who want to preserve the uterus or are preparing a future pregnancy in months or years. We propose the use of a combination of laparoscopy and hysteroscopy. But again, there is no data to support that this is the best, but this is the technique that we use. And of course, after that, after the repair of the isthmosil, cesarean delivery is mandatory. Some people will say at week 38. And if the thickness of the myometrium is less than 3 millimeters, then laparoscopy is probably the best approach. But if the thickness of the myometrium is more than 3 millimeters, so hysteroscopy approach appears to be better. And of course, we need more randomized control trials. And again, I think that I keep my time, Leila. It's because we are late. And again, I want to thank you very much for this invitation to be with you in Moscow. Thank you, Lena Damian. It's always a pleasure to see you, even in a screen.
Dear Professor Setubal, for many years we've been together. We met several times every year, even in Europe, in the United States. We live in the same world. We are together and we are discussing very topical issues. Unfortunately, C-section is growing, and however, women's health does not provide a good C-section scarring, and poor scar quality is a very important problem. I'm happy that you started solving this problem, and I wish the first C-section to be done only for special medical indications. Now we are having a big project which is called pathology of surgical uterus. It is both isthmocele with niche formation, inadequate surgery for endometriosis, and poor quality of uterine repair after adenomyosis. So this is another important problem in terms of possible complications compared to isthmocele and a C-section. So, and if you stay with us till the end of the session, we will be able to discuss those issues all together. Dear colleagues, let me give the floor to the next presenter, Dr. Dementieva. She is working in our center. She is a research student in Kulakov Center of Perinatology and Obstetrics and Gynecology Center, Dementieva, Victoria. She has done a beautiful work, and together with me, she visited Japan and also Spain. We discussed her topic with our American colleagues, and this is very important because actually no one knows what is
в фосфоинизидол-трикиназный сигнальный путь и в хипосигнальный путь. Таким образом, мы можем индуцировать фолликулярный рост от примордиальной вплоть до антральной или преовуляторной стадии и оптимизировать программу ВРТ. Итак, изучив международный опыт, исходя из крайне актуальной клинической необходимости, мы изучили этот вопрос, и Лейла Владимировна создала собственную операцию, на сегодняшний день уже запатентованную в нашей стране. Это одноэтапный хирургический метод активации функций яичников. И у нас уже свой взгляд на проблему отбора этих пациентов, на оперативное лечение и на послеоперационное ведение. Итак, на сегодняшний день прооперировано 83 пациентки, после них 52 простимулированы к настоящему моменту. Это зависит прежде всего от срока оперативного вмешательства и достижения оптимальных уровней гонадотропинов и определенной ультразвуковой картины, которая свидетельствует о наличии антральных фолликулов. Фолликулярный рост выявлен у 75% пациенток, при этом суммарно получено 96 ооцитов, 26 бластоцистов. Вот я обращаю внимание на частоту бластуляции, она не отличается от общепопуляционной при получении ооцидов. И к настоящему моменту консервировано 10 бластоцистов и перенесено 26. Наступило 12 беременностей. Здесь перечислено, какими методами они наступили. Практически половина наступила самопроизвольно, остальные беременности наступили путем использования программ вспомогательных репродуктивных технологий.
Assisted reproductive technologies. There are also live births. Well, one woman had twins. Children are already more than half a year of age, and right now one woman is at the stage of labor pre-induction, so we are waiting for one more delivery. So what is happening as far as one-stage surgical method of ovarian activation is concerned? First of all, we look at the indications for the procedure: infertility, poor ovarian reserve, and no effect of the previous conservative treatment, including ARTs. The procedure, well, the patients are sent for egg donation as the only way to achieve a pregnancy. That's what unites them, besides the fact that this disease is multifaceted. Well, they have an indication for egg donation, oocyte donation. The procedure is done at the Kolakov Center by Leila Adamian. The duration of the procedure, 1 hour, 10 minutes, even less. And you can see usually if the blood loss is 10 milliliters, the woman is discharged on day 3 or on day 5 after the operation. And we can see some concomitant diseases that we just pose questions here. How can we basically correlate these diseases with the premature ovarian insufficiency? Again, you can see that we use only mechanic energy. The surgical energies are not permitted during the procedure. Also, we just remove that part without any traumas, without any ischemia. And well, there is a space between the cortex and the cerebral substance, and we send the material for frozen section. Then we do the suturing, and then we use a reactive suture. Right now, you can see the stage of reimplantation. After this, we will just try to exclude any traction. The same happens in the counterlateral ovary. So the preimplantation stage is over for the right ovary. As of today, we have a patent for this procedure. You can see the number of the patent. You can get more information about this procedure. Well, you can see suturing when there is the juxtaposition of the edges of the wound. As of today, the method was approved in several other countries, and each author tries to modify this surgical treatment. And of course, mostly the modification takes place at the stage of reimplantation. Our method is a one-stage method using laparoscopy, because Professor Kawamura used a two-stage method. We do not use any surgical energies. and also suturing materials. Well, we do the reimplantation ipsilaterally. Biopsy is not more than 1 centimeter of the cortex, and we form niches for reimplantation. All this is written into the patent for this procedure. In the post-operative period, all 83 procedures were without any complications, intraoperative and post-operative, no complications at all. Early rehabilitation was done. Most women were discharged on day 3. Then the patients were monitored in terms of general conditions, and they were on replacement hormonal therapy. Estradiol levels were average for the early phase of the menstrual cycle. However, we can see real dynamics in terms of FSH and LH levels. There was a progressive reduction of the levels of the substances, and we can start the ovarian stimulation of these patients. I have also mentioned that we also do the pathomorphological study of a post-operative material, ovarian tissue and endometrial tissue. We identified the markers showing the reduction of the ovarian reserve in the cortex in different structures in the superficious epithelium of ovaries. Well, we can see it morphologically. That means that there are good adhesions in the area of the basal membrane, and we can also see the vascular component that is very well visualized, like there are micro vessels. You can see here the lack of a follicular apparatus. All these changes have been described by us, and we can also identify the connections between the histological structure of the ovarian tissue and response to ovarian stimulation. We made one step further and saw the response of the endometrium to changes in the ovarian tissue. Well, there is a good response on the part of endometrium because there are changes in the glandular layer of the endometrium. Patients with poor ovarian reserve have poor functioning of intracellular pathways such as YAC and mTOR, and also you can see that there are changes in the biological tissue of the endometrium when a woman is on replacement hormonal therapy as compared to patients who have the normal menstrual cycle. Well, the mucus of the uterus will be different here. What are the selection criteria? We had 83 patients. We've been monitoring them after the operative intervention. Patients should be under 40. There should be no mosaicism. Well, the duration of the violation of the menstrual cycle, such as amenorrhea, should not exceed 2 years. Well, women should be on hormonal replacement therapy, and the level of gonadotropin should be not more than 35 international units per liter, without taking into account the original basal levels that can be over 100. Also, failed IVF and no history of surgery on ovaries, because otherwise, if there is a surgery on adnexia, on fallopian tubes, on ovaries, well, this may be a problem. So refer patients to Leila Adamian, to the Kolokov Center, and she accepts patients. She sees patients every Thursday. Thank you. Well, what can I say, dear colleagues? This problem is very relative. I am not fully convinced that we have solved all the questions as far as this problem is concerned. Unfortunately, our women start thinking about their ovarian reserve too late. I am dreaming about a time when, right from the very start, at the age of 18 or at the age of 20, every woman would know what her ovarian reserve is, would know what her family history is, the duration of menstruation of her mother when the menopause started and when the mother had some particular genetic problems or not. In this case, we could have been involved at the early stage and maybe the operative intervention was not necessary. And I am dreaming of a time when you colleagues could talk to your patients so that they could be pregnant from age 20 to 25. In this case, we can achieve much better results and well, in this case, women will have to spend less money on different technologies and the results could be better if we worked on this problem when women are younger. Victoria, thank you very much for describing this problem, and I wish you a good defense at your dissertation summary. I'd like to give the floor to the next speaker. Who is director of the Institute of Reproduction of the Russian National Center of Obstetrics, Gynecology and Periodontology, a doctor of medical science, Professor Tatiana Nazarenko. Tatiana will make an interesting presentation. She has been working on this problem all her life long, and I think you will like her presentation, because she is a real guru in this field. The theme of her presentation is modern methods of predicting pregnancy and increasing the pregnancy rate in the IVF cycles. Tatiana, the floor is yours. And of course, do not overrun your time. Distinguished Professor Adamian, dear colleagues, thank you, Leila, for your kind introductory words, and I'd like to agree with you that women should give birth at least when they are to children when they are under 30, or better from 20 to 25 years of age. We have 40 years of the use of assisted reproductive technologies, and without any doubt, we have proven that this is the most effective way of fighting against infertility. In some cases, IVF is the only effective method. Moreover, as for the secrecy of conception, understanding this secret of conception allows us to enrich our knowledge. If we look at the pregnancy rate over the last 15 years, from 1997 to 2019, the frequency rate is basically the same, 30, 35, not more than 40% when there is IVF, and less when it's ICSI. We can say that ARTs are effective to avoid to combat the infertility, but at this stage, well, ART-assisted reproductive techniques that we use today, well, have reached the peak of their efficacy and have exhausted themselves. Naturally, specialists all over the world think about what to do next, how to develop our technologies where we can find new reserves to enhance the efficacy of IVF methods. We have formulated the factors impacting the IVF efficacy, uncontrollable factors. Well, unfortunately, we cannot have an impact on these factors. So that's age of the patient, of course, putting off the birth of children is the reality of our society today, especially in highly developed countries. Also, reduction in ovarian reserve, also gynecological and somatic diseases. These are problems we encounter in everyday life. Controllable factors, well, that's stimulation protocols, gonadotropins, well, also the management of patients. Of course, our work has an impact on efficacy of IVF, and these are such factors as skills of doctors, ongoing training, of embryologists, modern equipment, a personalized approach to every patient, and rational tactic of management of infertile patients is the result which we haven't fully used. If we use a rational approach, we'll be able to improve our results. In order to do this, we should look back and look at infertile patients today in modern conditions. Believe me, they're different from those men and women with whom we worked 10 or 15 years ago. Women enter the reproductive age later, reduced ovarian reserve, an increase in male infertility, somatic and gynecologic pathology. Women come to the doctor when they want to get pregnant after 40 years of age, 5 or 7 years, according to our data. A woman spends going to different healthcare facilities and use diagnostic and treatment methods which are totally ineffective. The nature of infertility has changed. 40% of women have the older reproductive age and they're sent for IVF. I mean, age over 38. This slide shows our data showing that there is a dramatic reduction in the pregnancy rate in women after 40 years of age, especially 43 years of age. The indicator is 0 as far as ART is concerned. We have different prognostic models of those factors related to couples. Married couples. Age is one of the major factors reducing the efficacy of ARTs. Women over 35 have a reduced number of oocytes, but also a significant reduction in the quality of oocytes. After 40, up to 90% of oocytes are aneuploid and cannot lead to a full-scale pregnancy. Prognostic models have shown how many oocytes are needed to have one euploid embryo. 35 or 37 years of age, that's 5 to 7 oocytes. 41, 42 years of age, 10 oocytes. After 42 years of age, we need 20 oocytes to have one euploid embryo. Where can we get them? The problem of late years is the major problem existing today in our specialty. The age of first birth increased by 10 years in the population. That's a catastrophe for the reproductive system. The average age of patients in IVF programs is 35 and older. How can we solve this problem? As I have already said, age is one of the limiting factors. And that is why early referral to the IVF center is the best option. In this case, we can improve the efficacy of such programs. Also, preliminary cryopreservation due to social indicators. Well, some people do not like it, well, because of the moral or ethnic or mental problems, but that's a necessary procedure. And many countries are working on this issue and realize how important this problem is. It's a must as of today. Suffice it to recall some articles published a long time ago in 2015 by Israeli specialists who showed the need of oocyte cryopreservation in women delaying reproduction, and they calculated the economic effectiveness of the procedure. If a woman didn't give birth under 30 or even under 35, depending on her ovarian reserve, in this case, well, she should cryopreserve her oocytes for future births. So maybe it's not quite ethical, but again, it's a must as of today. Rational medical support in the post-transfer period at early stages of pregnancy. We must say that polypharmacy is another important factor in managing such women, especially at early periods of pregnancy when organogenesis is taking place and the future baby has his organs formed. This may have a negative impact on the development of a pregnancy and the negative impact on the health of the future baby. Well, if we look at in vitro fertilization, if we look at polypharmacy, well, sometimes if we put them on the scale, it's hard to say which scale is going up and which scale is going down. This is an important question. If we can, for example, have a consolidated decision on how to administer progesterone, there is no unified decision what drug to choose and how long the drug should be administered when the woman is pregnant and how long she should take this drug. Efficacy, safety for women's health, the safety for the development of a child, well, convenience and patients' preferences should be taken into account and studies should be conducted here. Unfortunately, there have been randomized clinical trials here, and here I would like to show you one of the studies conducted by Abbott. That's the IRIS study, and Russia was also included in the study. There are two goals: to formulate the model to predict the pregnancy and successful births depending on different controllable and uncontrollable factors that we have identified. And we believe this is very important because this will be a justifiable, mathematically confirmed algorithm that would allow doctors at any levels participating in the treatment of infertility to assess the reproductive capacity of every woman and to avoid this 5 to 7 year period of expectation before something can be done. The second task is to get data on safety and the tolerance of dydrogesterone in ICSI programs. The development of the prognostic model means taking into account the different characteristics, clinical, phenotypical characteristics, and in this case, we'll be able to build this progressive model. The second task is based on international guidelines, clinical guidelines that have already shown the efficacy and safety dydrogesterone in ART programs. Right now, you can see the leading centers of human reproduction. There are 44 centers in Russia. Stage 1 is already behind us. And now we can say, as far as the IRIS study is concerned, that we have a good chance of pregnancy when different progesterones are administered, well, micronized and oral. Safety is confirmed both for women and children, and some women believe that this administration type is most preferable. What does the future hold for us? In my view, we will see the major advantages, the major breakthroughs in our understanding of the reproductive system, which has already been mentioned by Victoria in her presentation: genome editing and obtaining eggs from sperm or from stem cells. And right now, the questions that are important for us, questions that need to be solved are of the organizational issues, the rational management of the induction cycle. We should solve them as soon as possible to identify our positions and to formulate these questions and issues clearly in clinical guidelines. Thank you very much. Thank you very much, Tatiana. Everything was clear, concise, and to the point. Well, we will have a lot of victories in the future in achieving the reproductive function in severe patients, even patients with malignancy. Well, that's not a death warrant, so to say. We can achieve pregnancy even in such women. And Tatiana, by the way, sent a patient to me who 5 years ago had a radical procedure concerning cervical cancer. He was on chemotherapy, and surgeons at that time decided to do the correction of ovaries. They were not in the area of radiation therapy, and Tatiana sent this patient to me. I did a laparoscopy while the women was anesthetized. Our IVF specialists made 3 eggs mature, and we can do everything. God willing, will be able to achieve good results, but the best thing is to achieve a spontaneous pregnancy of our women. If we need to support the luteal phase, if they need progesterone or pregnancy hormone, no matter how you administer this hormone, whether it's PGT or preparation for pregnancy, will achieve good results. Thank you, Tatiana. Our next presenter is Professor Marina Shakova. Marina Shakova is head of the Educational Center Infertile Marriage and ART head of the ART Control Department of the Kulakov Center. She is a doctor of medicine, a professor. Marina Shakova has been dealing with reproductive issues all her life. She has a lot of experience in this field. She's an experienced gynecologist. She knows all aspects related to this field, including literary sources. She's acquainted with many specialists in this area. Marina, you're great, but do not overrun your time. Thank you very much. Thank you very much, Leila, for making a presentation at this prestigious Congress. The topic is innovative technologies for infertility treatment. That's a global problem of the 21st century. How can we achieve good pregnancy? Well, the quality and quantity of cells. Well, unfortunately, right now, we say that there is a drop in the birth rate in the Russian Federation. It has been like this for the next 5 years. The natural decline in population, even the flow of migrants cannot solve this problem. That is why President Putin, in his State of the Union address, said that there is a major national priority, that's the preservation of the Russian people. The government of the Russian Federation suggests we make specific decisions as part of the national birth project, and the key project is to provide financial support for families for making them give birth to children. And of course, there will be more IVF sponsored programs. And unfortunately, the average age of a woman when she first gives birth to children increased to 27 years. Hence, more complications such as poor menstrual cycle, endometriosis, infertility, up to 10% of women. And in order to restore their reproductive health, right now we have effective drugs, surgical methods of treatment you've heard about, and of course, assisted reproductive technologies. Suffice it to say that preserving the reproductive health of women starts with the proper sexual education of girls, detection of gynecological diseases and their treatment. Well, organization and issues related to dealing with pregnancy interruption. If it's an infertile marriage, we should send the patients for ARTs as the last stage.
As it is mentioned in many publications, about 20% of diagnosed pregnancies are interrupted prematurely. But if a woman gets under follow-up, the risk of miscarriage is effectively reduced and the course of pregnancy is improved. That's why it is important to prepare every woman for pregnancy. Extracorporeal or in vitro fertilization is an effective method which is there in place for over 30 years, and over 200,000 healthy children were delivered using this method. And Russia is one of the leading states all over the world. Over 150,000 cycles every year are done. And this is a sophisticated method, and the result is much dependent on the procedure, on technical aspects, and only very well established drugs should be used. And because it takes the future both for mother and for a child. And statistics shows that every 50th child in Russia is delivered thanks to IVF. And implantation is the most important multifactorial event, and it implies counteractions between embryo and the uterus and microbiota. There are multiple factors that have a great impact, and the implantation success rate is dramatically declined over years as the woman is getting older, and there are non-manageable and manageable factors. How many embryos are transferred? What's the state of endometrium? What is the preparation and support of lutein phase, as well as embryological step? What are the gestagen effects? They're very well known. Gestagens enhance a normal secretory transformation of the endometrium. They enhance and prepare endometrium for implantation. They reduce the contractility of the uterine musculature, and they reduce sensitivity of the endometrium and enhance implantation. The role of progestogens do improve the IVF results. Currently, there are oral, intramuscular, subcutaneous, and intravaginal progesterones. And the oral progesterone has great stability for double chemical link, and the progesterone activity is very high, as well as its bioavailability. I would like to tell you a couple of words on the legislation and the legal decrees and that have been recently issued. Both vaginal dihydrogesterone and intramuscular formulations should be used. I would like to present you ASHRAE guidelines on ovarian stimulation for IVF and ICSI. This is a very respected group of experts. Gynecologic and others provided their expertise of various areas for ovarian stimulation. Progesterone and dihydrogesterone are recommended to support the luteal phase. And the recent versions of the Russian guidelines are published on our website. It is Russian Society for Obstetrics and Gynecology, guidelines to treat female infertility. After embryo transfers, it is recommended to prescribe progesterone or dihydrogesterone with high evidence level. I would like to share with you the international experience and meta-analysis that is shown here, edited by Professor Griesinger and Christophe Bloquil, published the consensus on IPD Lotus trial. It was a face-to-face comparison of micronized progesterone, different formulations, and having pooled these data together, they concluded the chance for spontaneous pregnancy was very high. And when all the data were pulled together, dihydrogesterone proved to be more effective than a micronized progesterone. So this trial was confirmed by other papers and meta-analysis demonstrates higher pregnancy rate and comparatively higher live birth rate on dihydrogesterone. But these trials are ongoing, and we are looking forward to the new results. And both agents are indicated for stimulation because safety is our goal, and both micronized progesterone and dihydrogesterone proved to be effective both, and they were quite comparable for both mothers and children, future children. Thank you very much. This is what I was expecting from you. Progesterone is our goal. This is a hormone of pregnancy, and it is our assistant. Next is Dr. Dubrovina. She's going to talk about endometriosis and pregnancy. Is there any correlation between those two entities? She works in Rostov-on-Don, and she's a very brilliant doctor and a lecturer, and she's very deep in this topic. Infertility and endometriosis. Is there any relation between the two items? Good afternoon, dear Dr. Leila. I would like to thank you for inviting me to present you my views. It is a great honor for me. And your agenda is very logical. So my topic is actually a kind of conclusion from the previous presentations. Today we have discussed both surgical treatment and infertility and what we can do for our patients, what should be preferred. Finally, when a woman gets pregnant, what we can expect, what disadvantages are there. And endometriosis is extremely prevalent. The recent data on endometriosis that was held 2 months ago accounts for 190 million patients all over the world. Endometriosis became very active in the recent years, but we cannot compare the clinical manifestations of the condition now and 20 or 30 years ago. Our patients come to us to treat their infertility, and the treatment that was effective after having relieved the pain also prevented pregnancy, even despite the pain was relieved. And it was not, and it was because we didn't have any leverage to cover both problems, endometriosis and infertility. What causes infertility in endometriosis? Well, nearly all the factors, and hypophyseal, ovarian feedback, and if the pregnancy even occurs, the risk of miscarriage in these patients is very high, much higher than in general population. In order to identify the optimal treatment regimen for the patients both with pain and infertility, we organized this trial called ORCID. And it is very important to demonstrate 2 different types of dihydrogesterone, either from week 5 or day 5 to day 25. And both regimens resulted in rather high pregnancy rate. ORCID trial has been recently announced, and the results are published now. When we wanted to relieve the pain in our patients, we understand that any dosing regimen, 20 to 30 milligram per day, the ovulation is not suppressed, And when the patients didn't use any other contraception methods, the pregnancy occurred. The design of the trial that was quite successful, and the publication is being prepared for Human Reproduction Journal. And currently there are other methods available and other sources available. I would like to quote the paper that is published by Dr. Hodgson, and she admits that dihydrogesterone is one of the most promising agent to increase the probability of pregnancy. Our own Russian statistics reveals pregnancy rate after surgical treatment of infertility because of endometriosis is higher in laparoscopic groups compared to progesterone group. If a pregnancy occurs, I would like to present you a couple of clinical cases as well as international experience showing what problems the women face, those with endometriosis. This is a patient with bilateral ovarian cysts and ovarian teratoma. She was successfully operated. She was prescribed oral contraceptive to prevent follicular cysts. After the contraception was withheld, she got pregnant and 14 weeks, and later on she became painful, and at week 14 the pain increased. On laparoscopy we found left ovarian cyst and endometrioid cyst, cystic subtype. Dihydrogesterone 10 milligrams twice daily for 20 weeks was prescribed, and it was endometrioid cyst that was observed during pregnancy. Endometrioma during pregnancy was found, and the fact of pregnancy and endometrioma during pregnancy in a patient that didn't have any past medical history was quite interesting for us. After having analyzed the literature sources over 100 years, everything that was published all over the world, we issued our own paper on positive impact on pregnancy of endometriosis. Is it a fact or fiction? Why did we think of a positive impact on endometriosis? In 20s of the previous century, on a small series, there was a regression of endometriosis lesion during pregnancy. Retrograde menstruation that cause formation of endometriosis can be relieved with progesterone, and retrograde periods in women with endometriosis cause endometriotic lesions in prior to menarche. And our understanding of pseudo-pregnancy was destroyed when we encountered very unpleasant cases of bleeding from endometriotic lesions. Can it be related to increased IVF rate for infertility due to endometriosis? Actually, no. The cause of those factors, including endometriosis, reveals better diagnostic options, and it resulted in, out of 100% of all the tumors found during pregnancy, about 39% encounters for endometriomas. But in the beginning of the previous century, it was only 5 to 6%. The properties of endometriomas are quite different during pregnancy. And in every fifth woman, it can either regress or not change. And In some, they develop further on. And the behavior of endometriomas probably depends on decidualization within the endometriomas, and the same cyst that did not progress during the previous pregnancy may progress during the next pregnancies, and the same patient, after having analyzed their ovarian conditions, may result in progression of the endometriomas. About 30% of endometriomas, 39% may increase in size during a pregnancy. And they're quite different in terms of behavior and change of behavior of endometriomas during a pregnancy. Decidualization may encounter for regression. So this is the ultrasonic picture of endometriomas. And if I didn't reveal the type, so perhaps you could suspect an ovarian cancer. And actually, this is a decidual endometrioma. What complications can be there? This is abscesses of the cyst, rupture of the cyst, intra-abdominal bleeding from the endometrioid cyst. As long as we consider surgical treatment of endometrioid lesions during pregnancy, so the surgery should be done only by experienced surgeons. And because this is a very special requirement for the surgeon. Today, we are discussing those issues with the patient, and changes of endometriosis is unpredicted. We can never warn the patient from a regression, and the pain may be relieved or increased during pregnancy. And as long as we are talking about possible preservation of a pregnancy with past medical history of endometriosis, and if we want to support pregnancy despite of endometriosis, including ovarian endometriosis, dihydrogesterone should be effective. That is prescribed prior to pregnancy to relieve pain, and during the pregnancy to support the latter and reduce the risk of miscarriage. To conclude, I should say that better understanding on the relations between pregnancy and endometriosis is very unlikely in the future. I would like to thank you for your attention. I did my best to keep good timing. I know you want your speakers to be very concise. Dear Svetlana, thank you very much. You did everything all right. The only sentence I didn't like, I dislike, you said, it doesn't matter where the pregnant woman with the cyst is operated, but it is important that the surgeon would be experienced. So I disagree with you. So this is actually high-tech surgery, and because both mothers and children health is in matters, and it is in question. And well, I think you just exaggerated. I say that any endometriosis requires both experienced surgeon as well as high volume center. So you are very good in your points. And the next speaker is Professor Kornieva. She works in obstetric and gynecology center. We are one team. She's a member of our team, and she's one of the leading specialists in hyperstimulation. She is a unique person in this area. And I should say that, well, I should announce to her presentation, which is called Difficult Patients in ART Programs. Increases the risk of miscarriage, and in 30 years of age and 40 years of age, the miscarriage rate is twice higher. The importance of this problem, the miscarriage during the first trimester is 75 to 80% of all the lost pregnancies. And when the embryo quality is good, then it results in failure during implantation. It is chorionic gonadotropic hormone level which is changed, and in progesterone, progestins, and miscarriage. From clinical point, our doctors decide to use progestins, and as to miscarriage, we can distinguish spontaneous and common general miscarriage. And the question is whether it is indicated to prescribe progesterone. And endocrine factors are very important in multiple miscarriages. And if you see the patient after getting pregnant, we should discuss the other factors related to habitual miscarriage. It is high or low body mass index, which reduces the quality of embryos. And there are also genetic factors and immunological mechanisms, including stress, infections, and chronic inflammation. How can we influence chronic inflammation? Do we need to do a pre-gravid preparation? And what agents should be given or recommended to prepare the woman for pregnancy? And we should discuss what the problem is, why it is important, and what's the clinical significance of those factors. Preparation for pregnancy is very important, and it implies just genes, because spontaneous and habitual miscarriage or recurrent abortion is a very important emotional stress that should be overcome. What methods to treat this problem are there? We should be based on meta-analysis, talking about progesterone, which is important both for the mothers and for children. Progesterone is very important hormone without which the pregnancy cannot occur or cannot continue. Also, neurogenesis and cognitive functions of children are very much related to the progesterone level. And discussing the issues related to chronic inflammation and chronic endometritis, I should say that endometritis is a clinical and morphological syndrome which implies changes in receptors and cyclic transformations of the endometrium. It is related to miscarriage, including recurrent abortions. The pathogenesis of chronic endometritis is resulted from changes of microbiota and innate immunity in the endometrium. Weakening of receptors, estrogen receptors and progesterone receptors may result in impaired decidualization and implantation of the embryos. Diagnostics of chronic endometritis should be based on pathology, and first phase of the periods should be used to diagnose a chronic endometritis or confirm the diagnosis. Pathological features of chronic endometritis include the lymphocytic infiltration of basal and functional layers of the endometrium, and a special staining of endometrium is required. Antibacterial therapy, and despite there are no randomized controlled trials in this area, as well as meta-analysis are lacking, all the doctors dealing with this problem insist on antibacterial therapy because multiple trials have demonstrated a positive role of antibacterial agents. And antibiotics should be chosen based on the micropathogen profile. But if it comes to the empiric antibiotic treatment, we should always combine two different agents of doxycycline and metronidazole. This combination of two different agents is widely discussed in most of the current guidelines on the chronic inflammatory diseases of the small pelvis. We know of short cycles and longer cycles of antibiotic treatment. The current guidelines recommend at least 10 days of antibiotic treatment. These trials that have been conducted in chronic endometritis proved to be effective, and the antibiotic treatment or therapy for 10 days is much more effective compared to 5 to 7 day cycles. Therefore, when we discuss the treatment of chronic endometritis, I should again refer to the antibiotics during at least 2 periods, and anti-inflammatory drugs should be selected based on the etiological factors and taking into account their anti-inflammatory efficacy. Again, there are no randomized controlled trials on the efficacy of antibiotic treatment, and you should be based on your own experience, taking into account the condition of the endometrium and the micronized progesterone or progesterone. Utrogestan should be recommended from day 14 to day 25th in order to remove the outdated endometrium. And I would like to present to you the results of our Japanese colleagues who clearly demonstrated that chronic endometritis changes the decidualization in the stromal cells of the endometrium. They prescribed progesterone at the second phase of the menstrual cycles for the patients having chronic endometritis, and they clearly demonstrated that perceptive features of the endometrium did improve.
Here is a similar study with the pregnancy loss. Micronized progesterone 400 milligrams was administered to such women. This approach improves the preservation of pregnancy in patients with pregnancy loss. Here you can see the nucleocycline assessment, which assesses the condition of the endometrium. When this protein is more than 20%, the nucleocycline, it leads to poor implantation, poor gestation outcomes. And here you can see the results. Micronized progesterone in case of such women as part of PGT or 2 or 3 months before planning pregnancy gives us better results in terms of pregnancy preservation. Similar results were obtained in our country. There was a multi-center study conducted under the auspices of Academician Sevelieva. It was shown that the patients who had the PGT and who had gotten micronized progesterone had a better gestational outcomes when there was no PGS conducted. In talking about comparing the 2 drugs that can be used in case of the possible pregnancy loss, colleagues, there are a lot of studies conducted, and you can see these drugs are absolutely efficient in order to prevent pregnancy loss. I would like to show you the data of 2018, 118 patients with a threat of spontaneous pregnancy loss or spontaneous miscarriage. Utrogestan and dufaston were administered to such women. The miscarriage rate was basically the same, and the percentage of women who had bloody discharges, the rate was basically the same. So the drugs are very efficient. I'd like also to present the PRISM study that was devoted to the progesterone efficacy in terms of preventing pregnancy loss in women with bloody discharges at the early pregnancy stage. Well, more than 4,000 women were included. The primary endpoint is the birth rate. Colleagues, when we're talking about pregnancy preservation of the efficacy of a particular drug, yes, we are talking about discharges, but that's not the true marker showing the efficacy of a particular drug. Of course, we must look at the endpoint, that is the frequency rate of live births. Here, the live births rate was assessed and the new meta-analysis was provided, including the results of the PRISM study that showed that micronized progesterone increases the live birth rates in case women had the previous pregnancy loss or spontaneous miscarriage in the past. Here is the meta-analysis. You can hear the spontaneous miscarriages and traditional pregnancy loss. When the sub-analysis was done, we saw that the trend towards an increase in the live birth was in all women, regardless of the family history. When atragestan was administered at the 6th to 9th gestation week. So you can see that the drug is quite effective, and we should pay attention to the timelines of the therapy. If the therapy was administered at the same time, then the results of the studies will be the same. But if a drug is administered at week 5, not at week 6 to 9, or in another study when there was another drug, the therapy starts after 7 weeks of pregnancy, the results of the studies will be different, because in one case there will be genetic losses which will reduce the efficacy of therapy. In the second case, the drug will be administered when genetic losses are no longer important, but other factors are co-founders. Let me just show you another study, 2020, double-blind, placebo-controlled study, 406 pregnant women, 5 to 12 weeks, dydrogesterone compared to placebo. If the therapy starts at week 5, there is no difference in terms of whether you administer dydrogesterone or placebo. You can see dufaston and placebo, the results are the same, the miscarriage rate and live birth rate. So you can see there is no difference here. That's an interesting article from Hong Kong, where this study was conducted. Colleagues, I'd like to say that as far as efficacy of micronized progesterone and dydrogesterone is basically the same, but there is a discussion regarding the safety of both drugs. Micronized progesterone proved its safety more than 8,000 women and their children. As for some studies starting from 2015 about dydrogesterone, and there is a connection between dydrogesterone at the early stages of pregnancy and the congenital heart defects. Of course, we can consider these issues from different angles. So they are not conclusive, but there are first signs that dydrogesterone can lead to heart malformations among children born from such women. Well, ASHRAE believes that the data obtained are not enough to administer dydrogesterone to support the luteal phase, because if there are no long-term studies. Dydrogesterone is a histogen, which is different in its structure from natural progesterone. although there are 2 randomized clinical trials showing the lack of any difference, but nevertheless, these data are not enough. What does that mean for a clinician? That means that for progesterone, micronized progesterone aimed to support the luteal phase, well, the recommendation is strong. As for dihydrogesterone, it's only conditional support. As for the UK, well, you can see that they managed to preserve more than 8,000 pregnancies a year. There was the cost effectiveness analysis conducted, and the OBGYNs in the UK showed that only 11% of doctors administered the micronized progesterone before the PRISM study. After the PRISM study, 73% of OBGYNs administered micronized progesterone to prevent the miscarriage. As for our clinical guidelines, they will be mandatory starting from 2022, and in a group of pregnant patients that occurred as a result of ART, that's micronized progesterone vaginally, from 200 to 600 milligrams per day, or dihydrogesterone up to 30 milligrams per day per os. In the second trimester of pregnancy, only micronized progesterone can be administered. If a patient in the group of spontaneous miscarriage in the first trimester, micronized progesterone can be administered to avoid miscarriages from 200 to 600 milligrams per os, so intravaginally. High dihydrogesterone, 20 milligrams per os, and you can see the third trimester progesterone only, and you can see micronized progesterone will be used only in the third trimester to prevent miscarriages. Thank you very much, dear colleagues. Micronized progesterone has shown its efficacy and safety, and this has been written into all international guidelines. Thank you so much. Well, thank you, Irina, for your wonderful presentation. It is quite obvious that any pregnancy must be accompanied by progesterone even before pregnancy, and of course during pregnancy, to prevent miscarriages, to prevent the pregnancy loss. We have both drugs manufactured in Russia, so both drugs are recommended during pregnancy. Dihydrogesterone, if it is administered to treat infertility, to neutralize the luteal insufficiency, well, the drug can be used during pregnancy until the gestational age. I think it's week 20. Micronized progesterone is also good in terms of PGT, and during pregnancy, it can be administered up to week 24. As for the type of administration, everything depends on the patient's preference. As for different trials shown by different researchers, well, of course, we should pay attention to them, but also we should have our own multi-center trials. And as for our clinical guidelines, which have been recently published, both drugs are mentioned there. Thank you so much, dear Irene, for this presentation. Let's move on to the next presentation. Professor Svetlana Yureneva. She is a doctor of medicine. She is the senior lecturer at the Center of the Department of Gynecological Endocrinology of the Russian National Center of Obstetrics and Gynecology, the Colloquial Center. The topic of the presentation is hyperprolactinemia as a cause of reproductive disorders. I must say that Svetlana Ureneva is a unique specialist. She's an endocrinologist, a gynecologist. Well, we've been working with her for several decades already. She is very responsible, and I'm very grateful to her for her participation in this Congress. She is a very expert person. She took part in the development of clinical guidelines, and she is also known as a person who has an in-depth knowledge of menopause. Thank you very much, Svetlana, for your participation, because we had been developing clinical recommendations for 3 months, and we took into consideration all of the comments, and you were part of this process. Now your presentation, hyperprolactinemia as a cause of reproductive disorders. Again, do not overrun your time. Leila, thank you very much for this introduction. Thank you for inviting me to participate in this Congress. Dear colleagues, I'll be talking about hyperprolactinemia as a cause of reproductive disorders. Why hyperprolactinemia as a cause of reproductive disorders? I should like to remind you that in clinical guidelines of 2021, hyperprolactinemia plays an important role in the structure of infertility. 20%, every fifth woman is infertile due to hyperprolactinemia. And this happens usually in women from 25 to 34 years of age. What do we see in such patients? When you think that maybe infertility is caused by hyperprolactinemia, we should think about the violation of the menstrual cycle, oligoamenorrhea, and I should say that every fourth, sometimes every third women with amenorrhea, but also patients with regular menstrual cycles. But when there is no ovulation, hyperprolactinemia occurs in every fifth woman. We must also remember that depending on the manifestation of hyperprolactinemia, depending on the reasons for it, the most difficult situations are those when women have amenorrhea. If women have amenorrhea, that means no menstruation for more than 6 months. And this is a very long period of time. Well, a patient comes to see us. She has complaints that her libido is low, that she has fatigue. She might have dryness in the vagina. That's the shortage of estrogens. But here it's not just poor ovarian function, but the foundation of this process is hyperprolactinemia of the tumor nature. In this case, we identify the level of prolactin in such women, as well as in women with poor menstrual cycle. So when the patient comes to see you and you can see the prolactin level, you can see what the situation is. If the prolactin level is elevated by a factor of 2, the menstrual cycle can be preserved, but ovulation may be absent. Hence, this patient can suffer from infertility. If the prolactin level is increased by a factor of 3 or 4, in this case, there are violations of menstrual cycle or amenorrhea. And if the prolactin level is 4 and more times higher than the normal level, in this case, in 100% of cases, the woman has amenorrhea, clinical symptoms of estrogen deficiency. We must remember that if it's amenorrhea lasting for more than a year, one can encounter with low mineral bone density, and if a woman wants to become pregnant, we should to compensate the situation so that there would be no significant loss of bone density during pregnancy. And when the prolactin level is 4 times as high, we should get all the necessary information, because these patients may have headaches, problems with the field of vision, but patients with hyperprolactinemia usually are being managed by endocrinologists or neurologists if there are problems with vision. We must also remember that right now we should identify prolactin levels twice. In some situations, we must tell the patient how to determine the prolactin level to avoid any confounders. Well, the reasons for hyperprolactinemia can be pure physiological conditions like sleep. Prolactin level is very high, well, protein-rich food, so prolactin test should be done on light stomach. Well, physical exercises a day before, stress, even intercourse, the palpation of mammary glands. And when we do a prolactin test at the Kolokov Center, we always give a woman a special memo how to prepare for a prolactin test to avoid the confounding factors that could increase a prolactin level, and we could make the wrong decision. Usually it's the first phase of the menstrual cycle, day 1 to 4. Blood drawing should be done on light stomach, and it's important not to smoke at least 1 hour prior to doing a prolactin test. We must explain it to patients that when prolactin is elevated, we must realize why this happened. What's the reason? For us, it's important to have biologically active prolactin. And if this fraction is increased, but not macroprolactin, in this case, it may have a clinical importance. Here you can see the prolactin levels. Well, again, you can see the basal levels. It can be nanograms per milliliter or micro units per liter, but nevertheless, in any case, we realize what we should think about when the prolactin level is elevated, depending on how much. Also, it is important to have all the information, including the family history. Well, the use of all drugs, oral contraceptives, anti-hypertensive drugs can increase the prolactin level. Some neuroleptics lead to amenorrhea as a result of increased prolactin level. We must gather all of this information and take into account all iatrogenic factors. Naturally, we must also remember that elevated prolactin levels can be caused by different conditions, such as prolactin secreting tumors of the pituitary gland. 17 women out of 1,000, well, dopamine insufficiency in case of hypothalamus, pituitary gland system disease, hypothyroidism, or renal insufficiency when there is a significant elimination by prolactin by kidneys, and also idiopathic hyperprolactinemia, which occurs rather often. And these are patients whom we manage most of the time. So what are our strategic goals of treatment? First, the restoration of ovulatory menstrual cycle, restoration of fertility in case of prolactin secreting adenoma of the pituitary gland. We need to achieve tumor regression or to stabilize the tumor growth, but that's what endocrinologists are responsible for. Hyperprolactinemia is very well treated by using conservative treatment, even if the genesis is of a tumor type. We must understand that conservative treatment of hyperprolactinemia is the first line of treatment. And as a drug of choice, we recommend the cabergoline as the most effective drug. That's the selective agonist of dopamine receptors to normalize the prolactin level and to reduce the size of tumor, if there is any tumor. And in case of microadenoma, for 2 years, we can achieve the complete tumor regression. So we have all the grounds to administer cabergoline to treat such conditions. Well, you can see the data of dose Gynecologic as compared to bromocriptine, which is also used to treat hyperprolactinemia. Cabergoline or dose Gynecologic is more effective as compared to bromocriptine in terms of restoring the menstrual cycle, restoration of ovulation, and elimination of galactorrhea. I'd like to draw attention yet to another important aspect in any therapy, especially conservative therapy. Compliance is very important. Compliance is much better with Gynecologic as compared to bromocriptine because side effects, adverse events that occur with bromocriptine, such as headaches and others, well, are less frequent in case of Gynecologic. Gynecologic is very well tolerated. There is no vertigo in patients in this case. How long should the treatment last? The gynecologists usually treat hyperprolactinemia for 24 months, 2 years, just like in case of microadenoma, at least 24 months. So even in case of microadenoma, we see good effect from cabergoline. Well, the size is reduced in size in more than 50% of cases after the cancellation of therapy. And we can say that the probability of success is very high. And what is also important is the treatment of infertility and poor menstrual cycle. I'd like to thank you for your attention and to remind you that hyperprolactinemia occurs rather often, but we must make a diagnosis, identify the reasons, and treat the condition effectively. Thank you so much. Thank you. Well, thank you, Svetlana, very much for this presentation. Let's move on to the next topic. Please stay with us. Stay in the Zoom. Our last presenter, Dr. Dumanovskaya, hyperprolactinemia, modern understanding of the issue. Dr. Dumanovskaya is on the staff of the Department of Endocrinology of the Kulakov Center of Obstetrics, Gynecology, and Perinatology. Hyperprolactinemia, modern understanding of the issue. Please, the floor is yours, Dr. Dumanovskaya. Well, good evening, good evening. Well, you are a young and talented researcher, please. Thank you, Leila. Good evening. I'd like to thank you for letting me participate in this wonderful Congress. Thank you for this wonderful agenda, very interesting presentations. Dear colleagues, I'd like to talk about hyperprolactinemia. And this is an interdisciplinary team. That is why it is important to have interaction between physicians of different specialties. When we manage patients with hyperprolactinemia, a gynecologist would be the first doctor who is going to see such a patient. The prolactin is secreted in the anterior lobe of the pituitary gland. Prolactin is a relatively young hormone. It was discovered in 1970. The discovery of prolactin changed our knowledge about the reproductive function. When prolactin level was elevated, we can see there are problems with the menstrual function. What are the problems occurring here leading to poor reproductive function? As for the studies, they have shown that neuron GnRH contain prolactin receptors, but they do not have a lot of neurons, and it was not quite clear why when the prolactin is elevated, the secretion of GnRH is violated, there were neurons expressing histogene and developing Kiss-15. Well, and as for activation of pituitary gland, well, its function was reconsidered. Thus, you can see, well, they lead to activating signals. Well, his 15 level is increased, and there is an increase in GnRH, and hypogonadotropic condition leads to estrogen deficiency, which consequently leads to poor differentiation of osteoclasts, and that might lead to osteoporosis. There are three reasons. Physiologic is when a woman is pregnant or a lactating mother, well, stress or physical exercise, well, prolactin at night is much higher than during the day, and there are etiological factors leading to pathological hyperprolactinemia. These are different systemic diseases. Well, the intake of drugs, well, tumors, and even functional cysts can lead to elevated prolactin levels due to elevated estrogen secretion. When it's difficult to identify the reasons for hyperprolactinemia and the systemic factors are included, then there might be the diagnosis of idiopathic hyperprolactinemia. Here you can see prolactin levels depending on the original reason, but you can see that prolactin level can be elevated if it's a patient with microadenoma when the tumor is more than 1 centimeter in diameter, regardless of the initial reason of hyperprolactinemia. When the prolactin level is elevated, there are problems with the pulsatory release of FSH, resulting in galactorrhea, hypergonadism. There are guidelines to treat such conditions, diagnosis and treatment of hyperprolactinemia, and endocrine society clinical practice guidelines. We use our guidelines of the Russian Association of Endocrinologists of 2016, and there haven't yet been updates of these guidelines. So I would like to draw attention to the stages of diagnosis of hyperprolactinemia. It is important to prepare the patient for blood drawing for prolactin levels. Prolactin test should be done in the morning during the first days of the menstrual cycle. There might be the phenomenon of microprolactinemia. According to our recommendations, we need to do the test twice in order to make the diagnosis of hyperprolactinemia. When the monomer prolactin is elevated, in this case, we must exclude all the reasons or to remember about the polypharmacy, such drugs as Circal. The prolactin level can be elevated. Svetlana has already talked about hypothyroidism. We should also assess the liver and kidney function. We do MRI of the brain with the contrast media. We usually have patients with microadenoma, and
if you do not do contrast enhancement, you may miss the tumor because it may be very small in diameter. So you should always consult your patients with endocrinologists because it could be a missed secretion tumors, somatome, with the somatostatin, and it can be breastfeeding female or recently aborted women, or other conditions may arise. The therapy for hyperprolactinemia includes cabergoline regardless of the cause of hyperprolactinemia. And should the treatment be required, we should always start with conservative treatment. Currently, there are 2 agents approved in the class of ergoline agonists. And there is cabergoline and bromocriptine. So they are selective agonists of D2 receptors. Cabergoline has been introduced over 30 years ago, and the guidelines for conservative treatment should be the method of choice to treat patients with hyperprolactinemia. And cabergoline is recommended as a first-line treatment, first-line therapy. It is a selective agonist for D2 receptors, and the longer action time implies rare administrations once weekly. If your patient does not plan for pregnancy and over 2 years of continuous treatment after the prolactin level is normalized, and if the tumor shrank, which should be proven by CT scan, for microadenoma, it is 47%, for macroadenoma, it is 70%. In patients with microgalactinomas in postmenopausal women, the agent can be withheld, but the decision should be made on the individual basis. Patients with hyperprolactinemia in 10% of cases develop resistance to treatment, and this is a very promising area for the studies. And if a patient does not complain and the level of prolactin, which is not normalized, should be compared to the previous results. Prolactin secreting gliomas of the uterus are very rare, but you should be well aware of their occurrence. Dopamine agonists are recommended as contraception agents, and restoration of ovulation may occur quite rapidly. We need to normalize prolactin level in case of tumor size below 1 centimeter in diameter. And the agonist treatment should be withheld and the symptoms are relieved. We have analyzed over 7,000 pregnancies, and those that occurred on cabergoline and the spontaneous miscarriages are not increased, and pregnancy hyperprolactinemia in case of lesions should include ophthalmologists and endocrinologists, including field of vision evaluation. Hyperestrogenemia and accounts for 2 to 5% risk, and it is about 20%. Breastfeeding is not contraindicated, and it has no impact on relapse rate, and it was not described during the breastfeeding because the maximum effect should be there. In case of prolactin hyperprolactinemia, the success of treatment much depends on the teamwork. Thank you very much. So with that, we have exhausted our agenda. And now I would like to start Q&A session. I want our technicians to show us those who are still with us. I see Professor Hans Stieneberger, Dr. Dumanovska, Dr. Dubrovina, Dr. Yureneva, and Victoria. Professor Waterloo, Professor Cello, dear colleagues, I think we have had a very interesting plenary session during which different issues have been discussed, and I have a number of questions to our lecturers. And I welcome you to participate in our Q&A session. I was very much interested in the lecture of Professor Stieneberger. Hans is very good at controlling something, and from time to time he supports robotic surgeries while not, and his interesting lecture was about quality control of reproductive medicine. Hence, I'm very happy to raise this issue in your lecture.
My pleasure.
There is a big number of IVF labs opened all over the world, but what it results in, you never know. And all the reports are published post hoc. My question to you is the following. Dear Hans, when we talk about quality control, do you imply quality control during pregnancy? How many pregnancies occurred? How many embryos were transferred? At what term the pregnancy was interrupted? And what is the final results? How many children were born alive? Do you use other monitoring factors? How do you follow your patient? This is an extremely important topic. Could you please elaborate on this topic? What are your prognostic factors? I don't speak about post hoc analysis, but what are your active approach to follow up your pregnant women?
Well, thank you very much, Laila, that you're raising these questions. I thought the topic was a little dry and not interesting for most people. So basically, there are two ways of quality control. One is the internal control that I strongly recommend for every IVF or reproductive medicine institution to obey so that they can control their the quality of their work. The second way is the external control. And external control is also what you, for instance, are doing when you're visiting other hospitals and other institutions so that you check what is being done. And at least in Germany, we have a system where we also have external control, which is governmentally ruled. So for the internal control, the system that we are propagating, which is the Meditech system, has about 4,000 indicators. These are individual results. And you mentioned already what is being done with big data. So this is already big data, and that is not yet the end, because we will see that all instruments, all apparatuses in the IVF lab will also feed new data into this system. So one of your questions that you raised earlier in this session was, are we using artificial intelligence? And I can sort of confirm, I think, what you had in your mind. Yes, we do have artificial intelligence, but not everything is done with the use of artificial intelligence. And it is very complicated to see also the self-learning, the machine learning of these data, which is also due to the fact that, as we also heard during this very interesting session, that there are new ways of dealing with, for instance, difficult stimulation of patients like the premature ovarian failure and so on. So the system is constantly developing, and this also needs to adaptation of the system. But as you quite rightly said, of course, the most important ones is the pregnancy rate with the respect to the age group, and of course the baby take-home rate. This is the backbone of the entire system. But it is not possible to say an institution that has a lower pregnancy rate is bad, because it has always been referred to the age of patient, comorbidities, and other factors.
Well, as I understand your point, as soon as a woman gets pregnant, you communicate each and every case to the supervising bodies. And as you report the IVF count and the pregnancy rate and how many embryos were transferred, and you follow your patients prospectively, or are you saying about the quality control that is done afterwards, after the pregnancy is resolved?
Yeah, or after no pregnancy has been achieved. So we also check how many patients have started a treatment and how many were continued and how many became pregnant, and of those, how many actually delivered a child or had an abortion. Exactly.
So my compliments to your healthcare system, as long as you can follow all the IVF cycles, those that resulted in normal delivery or miscarriage. It means that you have a good mechanism in place to follow all those pregnant women. And if you see something is wrong, you can provide care and participate in your treatment process. So this is all good for you. We're only trying to get the system in place. Well, can you tell me, so I did my lecture on artificial intelligence, and after having analyzed many sources, I should say that regardless of whether the center is high volume or low volume, ranging from 30 to 50%, the difference is. But what is the actual problem? I'm not talking about the surgical skills. I'm talking about the IVF outcomes. Whether they use wrong catheters, the embryologist is bad. So the manual procedures are always labor consuming. What are other factors that should be taken into account? Why not all the patients get pregnant? Actually, we provide IVF for patients who are very well examined and diagnosed, including Mullerian hormones, and we use good embryos to good patients, and we use also good pre-implantation diagnostics. Why our implantation rate is very low, not 50, but rather 30% on average? What is your explanation for that? Well, I think I speak about the pregnancy rate, which is 30%, but not 50%.
Yeah. Well, Leila, this is an extremely difficult to answer question.
Where does the problem lie? How do you see it?
Well, the answer is extremely difficult, as this is a very fundamental question, as always with you. But
yes, I knew what to ask you.
But the underlying mechanism is so multifaceted, and I'm sure we don't always know all the data on the patients, and it's not only the woman, it's also the husband, and whether they smoke, whether they take alcohol, whether they consume drugs, what conditions they live under, do they have environmental hazard exposure, are they, for instance, the husband, is he always sitting on his testicles, so reducing the sperm quality, and are they very stressed? So there are many factors beside the known track that we are observing and that we are also taking into consideration. Next is, of course, what is the stimulation procedure? And you know, on what day to give progesterone supplementation, and what day to start the cultures, what day to do the follicular aspiration. This is a very complicated procedure, and if you say we have a systematic procedure, as we do for quite some time, this will not be the best for every and each patient. So we have to re-individualize also the treatment, which is difficult, but it will be for the benefit of the patients. And Leila, perhaps a last comment. I very much do look forward to meeting you in person so that we might discuss this in more detail. Also, what is perhaps the outlook on quality control in reproductive medicine?
I absolutely agree. So this is a frank answer to the very difficult question I was asking. And this is a box of Pandora. Well, seemingly everything is systematized. So we do everything in a standard manner. We aspirate the oocytes, we classify our patients. However, still there is no prospective quality control. And I should say that as long as there is a good pre-implantation genetic counseling, and if you transfer good embryos, your results would be much better. And on the other hand, if your patient is younger, she has much better chances. At the age of 30 plus and even 40, your chances are very low. And dear Hans, I should say that unfortunately we don't have sufficient control of all these factors. Am I right?
Yes, definitely.
Absolutely. What would Celavita, what would be your reply or answer to this question? Professor Vita, are you no longer with us? It looks like that. Professor Waterloo, are you with us? No more.
Yes, I am here. Yes, yes, I am here.
So what's your take on that? I would like to ask you. We were discussing the issues related to hydrosalpinx. What's your attitude to the tubal factor that leads to the ovarian cancer? Is there any relations between the tubal factor and ovarian cancer? Many say that tubes should be removed, and in patients aged 40 plus, when you do whatever surgery, you should remove tubes because this is a big risk of ovarian cancer at this age. And the same question I should address to Hans as well. First, Antoine, please, what could you answer? Well, we've been doing tuboplasty for decades, and including microsurgical, and I still do this operation using laparoscopy, but I have never seen any significance of a tubal factor to the ovarian cancer. What's your take on this new theory, I should say?
Yes, thank you for this very important question. In fact, when I do hysterectomy, I always remove the tubes due to the risk of ovarian cancer. Now, when you are dealing with younger patients around 40, if you do a tuboplasty, then we have not to take this in account. And then we have, I will say, a gray zone. When you do female sterilization after the age of 40, then we maybe should consider today to remove the tubes instead of doing only a ligation or a coagulation of the tube. So yes, it is a factor we have to consider. I don't consider this factor when the patient is infertile. I will consider it when the patient is after conceiving their child. And if we need hysterectomy, where I think we have to remove the tube, including the fimbriae, which is very important to remove the fimbriae, which is probably from the part of the tube which is the most contaminant to the ovary.
Hans, what's your answer to this question? Should the tubes be removed, considering it as a risk factor for ovarian cancer? If you see normally looking tubes, should they be removed? Should we be scared about ovarian cancer, even if the tubes are quite normal?
You know, the ovarian cancer, yes.
It is not only for me, but there are very many doctors listening to us.
Understand. Yes.
We didn't want to include it in official clinical guidelines to remove the tubes. I'm asking the same question to Hans Tinneberg. Yeah. And well, there are certain data about the serous type of ovarian cancer, and we can
Yeah,
judge,
yes.
we can count on
Yes, yes.
the opinions of our oncologists, general oncologists, because we gynecologists have not analyzed the outcomes.
You know,
Should the tubes be removed or not? Hence, I trust on your point. So what's your take on that?
Well, I fully agree with Professor Waterloo. And as he mentioned in his last statement, the most important part of the tube are the fimria, because this is where there is the conflict of cell interface. So when not any longer necessary, since we had this emerging evidence that tubes are important for the onset of serous carcinoma of the ovaries, we recommended and we encouraged women to have their tubes removed when they were no longer needed. I don't know whether anyone, including Professor Waterloo, has any experience whether deformed tube, as the ones we saw in his excellent presentation, are more likely to develop cancer. I don't think so, but this is something I don't know. But in general, as you asked, we recommend the removal of the tubes, and in case of hysterectomy, the tubes don't make any sense anymore. And in case of sterilization, which should also be a terminal procedure, also the tubes should be removed, including, very importantly, the fimria.
Yes, yes, I agree. If you remove the tube, you have to remove the fimria, as I said.
But I wouldn't dare to discuss, even to come to discussion of these issues with females who even are not going to get pregnant. And because if we remove tubes, fertility is stopped. And in your lecture, you were discussing, I think it was Professor Antoine Waterloo, when you examine your mucosa using hysteroscope.
Yes.
Am I right?
Yes.
Is it you, Antoine? And do you examine the tubes, trying to understand whether salpingoplasty is feasible or not using hysteroscope? How do you do it? Do you use a special device to visualize the tubes from the inside? Do you use special probes or optics or what?
Yes. What I do usually is to do that transvaginally with a transvaginal endoscopy or fertiloscopy, because with the same hysteroscope you can go inside the tube and inspect the tubal mucosa. You can do that also by laparoscopy, but then you need another scope, another cold light supply, another irrigation, so it is quite complicated, which means that few people, when they do only laparoscopy, do salpingoscopy routinely. So we should probably consider the vaginal route, because it is so easy to go by this route inside the tube and to see the mucosa of the ampulla, which is the most important part of the tube, as you know.
But this is quite a different story.
Well, thank you. So during hysteroscopy, you study the ostium of uterine tubes and the mucose. So that means you do it in a retrograde manner through the ampulla.
Excuse me. No, I do transvaginal. No.
Please go ahead. Please go ahead. Please go ahead.
Yes, I do a transvaginal endoscopy that we call fertiloscopy. So it is not through hysteroscopy. We do a puncture in the pouch of Douglas, as I show you in the small video. Then we are in the peritoneum cavity. We have in front of the tube. Then you can go inside the tube with a scope, which is in fact an hysteroscope, but it is not by hysteroscopy because the tube is too narrow on the ostium. So in fact, we have to go through the fimria and in the ampulla by abdominal route, but transvaginally.
Well, that's a very wise move. Thank you. There was a time when we were trying to do a sure sterilization of uterine tubes through hysteroscope. We tried to look at the uterine tubes and we blocked them in the intramural section. Well, could you tell me, Professor Vatrello and Professor Tinneberg, you are experienced surgeons. What's the future of our medicine? What should be forget in the past? And what procedures should be forgotten? And what are you dreaming about in the future? Dr. Tinneberg, Dr. Vatrello, what are your dreams in the future? What else would you like to invent that we don't have now?
I guess nobody
if I may say something,
because again, it is a very difficult question. I have many dreams and many wishes, and at present I'm developing a new device that will allow purse-string suture endoscopically in an easy and simple way. But this is not my visionary dreaming. My visionary dreaming would mean that we are extremely minimally invasive, which in the area that Antoine was reporting and that you were just discussing concerning the uterine cavity, we will perhaps tend more towards non-surgical application and interventions. And you know that there are new instruments that are combinations of ultrasound and, for instance, coagulation to treat the fibroids. And you could also see during the type of surgery that Dr. Ota was showing us that it is again the combination of different tools. One was the Doppler ultrasound, including the imaging and the surgery. I do not agree with everything that he showed, but in the end, it is a new way of dealing with particular pathologies, but being less invasive than in former days.
I agree with you. We should follow this path. In the past, you remember, myolysis was done using electrocoagulation or cryomyolysis. Well, why should we remove benign nodes? Well, we can go through the uterus, and through the uterus, we can just remove any part of the uterus. What would you leave in the past? What would you leave in the past? Robot, or do you like robot, or would you discard the robot? You also said a few words about the robots. Well, Hans, it's very interesting. What about your attitude toward a robot?
As a matter of fact, Laila, I would be very happy if I would have a robot, if I would not have to worry about the high expenses. And perhaps you remember a few years ago, I was trying to test one of the eminent Russian speakers to say, how can you Russians fly to the moon very successfully and not build your own robot? I would trust it would be really good, reliably working robot. So maybe this is in the pipeline, but I don't know yet. But basically, all that I am doing in my surgery, as you know, including surgery for deep infiltrating endometriosis and malignancy, I do without the robot, but I feel my back and my knees aching. So in the future, if I would have some robotic assistance, it would be very nice for me, but not necessary, and at present, too expensive.
In Russia, we do have our Russian manufactured robot. Several clinics already use robotic technique. Thank you very much, Dr. Vatrello. What are your dreams and what would you leave in the past? You are a genuine surgeon. What would you discard, and what are your dreams?
For me, yes, if I may say, what kind of operation we have to keep today, I think it is a reversal of sterilization, the good cases of hydrosalpinx or fimbrioplasty. We should, I think, stop to do corneal anastomosis because the results are not very good. And my dream is without considering the surgical option, but to have one surgeon in every ART center.
Keep talking, keep talking.
You translate?
Well, keep talking. Professor Berthelot,
Yes.
Can you hear us?
I cannot hear you.
We have poor connection on your part, okay? While we are establishing the connection, let's ask Dr. Dementьeva. Right now, there are a lot of surgeries, a lot of procedures, and we also see a lot of patients. And I would like to say, my dear friends, as for premature ovarian insufficiency or poor ovarian response is when young women have amenorrhea, they have symptoms of climacterics, they have infertility and no success in treating infertility, especially after IVF, and no success in treating infertility when egg donation is done. Well, so in this case, Doctor, could you tell us, you mentioned about 80 different people. Victoria, Dr. Domanovskaya, what should we do in this case? Well, I should say that we can see patients like that. We do the following thing with these patients. Could you explain the situation? What should be FSH, LH, MH, and in this case, depending on the markers, we can achieve success. What kind of patients should we treat in this case? Dr. Dementьeva, can you hear us? Again, she has no connection with us. Well, I can see her, but I cannot hear her. Did you hear my question? Have you heard my question? Yes, she heard my question, but we have no connection, no feed coming from her. Well, we mean patients with a premature ovarian failure, well, and patients with infertility, resistance to conservative methods of treatment, including IVF. We're talking about patients under 40 or under 42 years of age with AMH level less than 0.5, such as 0.4, 0.3, 0.2, down to zero, basically. As for FSH, well, here we should have a clear difference between the basal level of FSH. Well, in this case, it can be to 60, 70, well, a very high level of gonadotropin, but they should be adjusted by hormonal therapy. Hormonal therapy can be administered at the first appointment in order to reduce the level of gonadotropin to enhance the efficacy of treatment, while the patient initially can come to us when she is on hormonal replacement therapy. And another important aspect is that there should not be a family history of surgery on ovaries, because otherwise there might be a problem as far as access to the ovarian tissue is concerned. Okay, could you tell me please, Svetlana, what are the major reasons for amenorrhea, well, ovarian failure, premature ovarian failure, well, immune problems maybe, or anything else? Well, I'm upset because we have more and more young patients. Well, so what about your experience here? Well, as for our experience, when we see a patient with infertility, we must collect all the data of the family history to identify patients that might have the risk of premature ovarian insufficiency. We must ask the patient when her mother or her grandmother had the early menopause. Here, the risk with this young lady will be higher. Also, smoking women with a low body mass index, or women who were born as a result of twin pregnancy, and there might be different predictors that we can see. Furthermore, unfortunately, in most cases, we cannot identify the original reasons for premature ovarian insufficiency, but nevertheless, the genetic problems take up a certain percentage. So when patients have a suspicion of premature ovarian failure, karyotyping should be done, and to identify the FMR1 gene mutation, which is linked to the X chromosome deficiency or X chromosome failure. In this case, such patients might have premature ovarian failure. And we also know that a large number of autoimmune diseases can lead to early premature ovarian failure. So we must get all the data as far as the family history is concerned. The infection is another factor. We also know that parotitis can be one of the reasons for premature ovarian failure, both among women and men. HIV infection is another problem. Maybe COVID-19 can be also one of such reasons of premature ovarian failure. So this may be one of the reasons. Tuberculosis, which we underestimate, but nevertheless, it is quite widespread in Russia, unfortunately, and specialists in reproductive health must remember it, not to mention iatrogenic reasons, such as surgeries on ovaries, on uterus, while also the intake of different drugs. Today, we have patients with cancer. We can treat such patients quite effectively, but many drugs that are used in chemotherapy or radiation therapy have a negative impact on ovarian reserve, thus leading to premature ovarian failure. In oncology, there is such a concept as a pre-rehabilitation. And, you know, at our center, at the Gynecologic Center, you are one of the initiators of this approach to start using this method of pre-rehabilitation. If a patient has a surgery on ovaries planned or the treatment of some particular type of cancer, we must determine the ovarian reserve and to preserve the reproductive potential, to preserve the healthy ovary. That's one of the options, and to preserve what can be treatment as a result of treating cancer. Okay, I need to see the general picture. All right, I'd like to ask Hans. Hans, how do you see surgery 10 to 15 years from now? Or maybe Professor Waterloo, how do you see surgery 10 to 15 years now? Or maybe there will be no surgery 10 or 15 years from now. For example, if we're alive and meet in 10 or 15 years, what are we going to have? What kind of medicine are we going to have? Hans.
Leila, I'm afraid that I might disappoint you with my answer. What I have experienced is that progress, especially in surgery, has been very slow. As you know, I witnessed the beginning of endoscopic surgery with my former teacher, Kurt Sem. And it is now 2 generations, and still in the wide area, we do not have efficient spread of this knowledge. It is in specialized centers like yours and Svetlana and others where this is propagated and where this is being performed on a high level. But in the area, in the entire community of medical doctors, it will still take a long time to do so. What I envisage is that we have increasingly a combination of artificial intelligence and guided surgery, so that we have information not only that we have in our brains and that we put into our hands, but that we have an aid. For instance, our university has developed a knife that can sense whether you cut through healthy tissue or through tumor tissue. So this additional information, also with the mapping of the body, in the end will help us to be more precise and more exact in surgery.
What do you think, mass spectrometry? Do we need mass spectrometry in the near future? Mass spectrometry, right now, a lot of people are talking about that. Will mass spectrometry help us in diagnosis?
Well, if I may answer, sorry, I don't want to monopolize this discussion, but the new aspect is fingerprinting. And as you know, especially in malignant diseases, we are looking for liquid biopsies. The same should also be applied for non-malignant disease like endometriosis and other underlying diseases, or what our colleague from your center had just mentioned about ovarian insufficiency. So mass spectrometry is extremely important in order to analyze fine differences between people.
I need the general picture. Well, all right. Right now, the major problem in our healthcare system is malignant tumors, malignant diseases. I'd like to ask each of you within 1 minute to say, why do we have a growth in the number of tumors, malignant tumors? Is it stress, ecology, radiology? What are the reasons for malignant tumors? Just 1 minute each, or maybe because women do not give birth. I mean just gynecological cancer, breast cancer, for example, endometrial cancer, ovarian cancer, cervical cancer. What are the reasons for these cancers, and what should we do in order to reduce the number of such cancers? We must wrap up this discussion, and please, within 1 minute, give your opinion on that. Who would like to monopolize the discussion? Hans, Professor Waterloo, are you still here? Okay. Dr. Waterloo, are you here? Okay. Just within 1 minute, give your opinion. Let's start with Professor Tinneberg. When you're with us, you're always person number 1, Professor Tinneberg. So what are the reasons for such cancers? Why so many cases of cancer? What should we do with that, please?
Well, there are many reasons that are known. First of all, our society is aging and is overaging. And by age, we lose control of what our genes are doing. So it might develop into the malignant phase. Secondly, our living conditions, and there are many proofs from people that moved into a westernized society. So we have an environment that is not very supportive of not developing cancer. Thirdly, also part of our environment is we have not enough physical exercise. So we are driven by car, we sit like we do all day today during this conference. So there are many aspects that we have changed to the worse, and that might increase also the likelihood of developing cancer.
Thank you very much. Svetlana, what is your opinion? But, well, be quite frank, be quite open. Well, I should say that our task as gynecologists is to pay attention to proper food, physical exercises, and fighting obesity. This can significantly reduce the spread of cancer, endometrial cancer, ovarian cancer, breast cancer, if we use a proper food, a healthy lifestyle, and maintenance of the optimal body mass. Stress, of course, is one of the reasons, but I want to say that in principle, gonads, male gonads and the female gonads, the mammary gland is more sensitive to different agents such as food, radiation, or whatever. That is why breast cancer, well, that's the most frequent oncologic disease, and our smoking is another factor, of course, well, different bad habits. So our goal is to organize a screening of such people, because such factors as human papillomavirus, we know exactly what to do, especially among young women. As for, say, breast cancer, well, a two-stage screening should be organized here. We don't have enough questionnaires well, like you have in Western countries. That is why we need to conduct epidemiological trials. Well, oral contraceptives is a good choice to reduce ovarian cancer and endometrial cancer. And I don't want to monopolize the conversation. Well, Dr. Dubrovina, Svetlana, what is your view? Just in a nutshell, a blitz response, just your opinion, what to do next, your opinion. Well, I'm afraid after what Hans and Svetlana have said, I cannot add anything new, but what we can do, well, we cannot change the environment, unfortunately. Well, there is a lot of plastic around and the plastic has an impact on our health. Well, but that's just what we should do in the future. But as of today, we cannot change the genome. We cannot have an impact on the genome. Hans was absolutely right. The longer people live, the more cases of cancer they're going to have. So we must get our patients prepared. But don't drink alcohol, do not smoke, and well, maintain proper weight. At least right now, we can do it today. And we as doctors can explain it to ordinary people that you're also responsible for this. And all women, well, we tell all women, give birth to a child when you are under 30. In this case, there will be a lesser chance of breast cancer, and you have a lesser chance of premature ovarian failure. Okay, well, Professor Dubanovskaya, well, I have nothing to add. Well, add what you can add. Okay, I'd like to say that we as gynecologists and endocrinologists, we can prevent obesity and we can prevent smoking. We can convince women to maintain a healthy lifestyle. That's a modified risk factor. It depends on your behavior. You can lose weight, and in this case, there will be at least one risk factor down, and also annual checkups to prevent breast cancer. So everything is in our hands. All right, Victoria, what about you? Well, I'd like to say that today we see a growth in the number of cancers, but also age-related diseases, including breast cancer, cardiovascular diseases, etc. The mechanism of aging and cellular damage are universal, and everything starts with early embryogenesis up to the older age, and it's our responsibility to control, modify the risk factors. And we also should conduct more diagnostic tests, and especially as far as gynecological cancer. So we should have more diagnostic tests conducted, and the tests should be of higher quality. Well, I think that we have basically the same view on that. Of course, our health depends on several factors. 50% depends on our lifestyle, what we eat, how physically active we are, that's 50%. 20% depends on the level of medicine, what kind of medical system we have, what kind of diagnostic systems we have, what kind of medical checkups we have, what is the level of care provided. 15% depends on our heredity, genetic traits. Well, we cannot do without it. And 50% are things related to different disasters like the pandemic or earthquakes or wars or any environmental disasters and so on and so forth. But my personal opinion is that if we look at all these conditions, at all these aspects, I agree with them, they do exist. But I've been working in medicine for almost 50 years. When I was a student in the medical school in 2022, it will be my 50th anniversary since I have been working at the Kulakov Center, Hans. Well, I would say genetic traits, genetics, and stress. Well, I saw people when they were quite okay, but they were not stress-proof. Even if I look at girls with premature ovarian failure, I ask these girls, what about your mother? Do you have any stress? Well, I think half of all reasons are stresses. Well, and then inherited immunity, which is passed from the mother to the doctor, and endocrine disorders, and of course our lifestyle. Well, of course our lifestyle leads to no good things, like we live only to work, to achieve something. We do not give birth to children. We want to actually work hard. Well, I'm not talking about myself. I'm okay. Well, but people who live long, who live until 80 and over 80, and people who reached 100-year-old level, well, these are people who had motivation in life. These are creative people. These are positive people. And well, if they see that some person feels good, they also feel good. Well, that's the people who have specific habits, like to have family dinners, who have a habit of going to church on Sundays, people who are socially active. And I would say that family is number one. Family is our umbrella in any rainy day, and the pandemic proved it. That's my internal opinion. I'd like to thank all of you for this wonderful time. Today we had a very difficult day. I love you all, and I'm glad that you stayed until the end of this breakout session. Tomorrow is day 3. We'll be talking about oncology issues, and there will be key presenters. First, we're going to have the endoscopic surgery course. Then Roberto Tozzi will deliver a special course on gynecological oncology. Then Professor Kupke, Magrina, Leblanc, Marnitz, and academician Ashrafyan, Habas, Professor Mozzoni from Italy. So I think that our conference has a wonderful agenda. Thank you very much. See you tomorrow at 8 o'clock Moscow time. Dear participants in the Congress watching this live streaming, I hope you're happy spending this day with us. Thank you very much. Stay healthy. The pandemic isn't gone yet. Bye-bye.